Inside, where nourishment, comfort, and spirit reside. So, welcome, dear colleagues, to this quest anew to heal what we see and seek what is true. Let today remind us through every slide and scope that beyond the pathology, beyond every symptom, there is purpose and hope. I welcome everybody to Sigecon 2025. Today, we gather at the CME surrounded by brilliant minds of medicine, surgery, and allied specialties to discuss, debate, and deepen our understanding on the simple heartburn to the age-old connection between heart, soul, and gut. So, as we begin our session, let us carry that same spirit of curiosity, the courage to question, and the patience to understand, and the humility to keep learning. For centuries, physicians tried to understand why something as instinctive as swallowing, the very first act of nourishment, could go wrong. In ancient texts, dysphagia was described vaguely as the difficulty of the throat or a blockage by the spirits. There were no scopes, no imaging, no manometry, only observation and compassion. It wasn't until the late 19th century pioneers mapped the swallowing frame by frame. Early fluoroscopy was used to watch contrast pass down esophagus, and a moment turned mystery into mechanism. It wasn't a single motion, but a symphony. A break in this was dysphagia. Without any further ado, I call upon our pioneer speaker, Dr. Shirin A. Shetty, Professor and Head of Gastroenterology and Hepatology at KMC Manipal. I would also like to call upon our esteemed moderators, Dr. Arvind CL, Dr. Meena Kumari, Dr. D.G. Shivakumar, and Dr. Channa Basappa on stage.
Good afternoon, everyone. I welcome all the delegates, doctors, my colleagues for today's first topic, dysphagia beyond tumors. Dysphagia is a very important topic. From simple cause to complicated cause, need a very good, accurate history and history-guided investigation. So, without wasting much time, I would like to welcome Dr. Shirin Shetty. We know you, everyone. He's a young and energetic, good clinician, and he's a professor and HOD of Department of Gastroenterology and Hepatology at KMC. I've seen him from his PG days. He's very good clinician, I want to say. So, without wasting much time, sir, carry on.
Thank you, sir. Very good afternoon to everyone. At the outset, I'd like to thank Shusho, the Institute of Gastroenterology, and my dear friend, Dr. Pradeep, for organizing for this kind invitation. I think I need to congratulate him for organizing such a focused meeting, and also he's doing a wonderful job in this part of Karnataka, I can say, and also the moderator who gave a beautiful introduction, and also to sir, who was my earlier mentor in my MD days. So before wasting much time, what I'll go through is first 10 minutes, I'll just go through how do you approach dysphagia and why this is very important. So first of all, we should know what is dysphagia. Anything difficulty in swallowing or difficult to eat, we say dysphagia, and this is important because both at a primary physician level, surgeon, physician, or at a gastroenterology level, we come across in our day-to-day practice. So we should be very clear with the concept of dysphagia. See, people come with saying something difficult to eat. Everything is not dysphagia. So first and foremost, the approach becomes we need to diagnose dysphagia. The word dysphagia came from, it's a Greek word, difficulty to eat. But if you look at the classical definition, what happens? Because swallowing is a very complex mechanism with involuntary and voluntary phase. So anything which disturbs this mechanism should lead to the patient has dysphagia. We also should remember three things. Is it only painful? Is it real dysphagia? Or is it fear of eating? Or is it just a feeling of globus. Sometimes people say, I feel like a choking or something like globus. So that's actually not true dysphagia. So you need to first ask with the history, what is the patient's problem, and then you can decide what is dysphagia. So briefly, let's go to the what is swallowing. Swallowing is both voluntary and involuntary phase. So it is but oral phase and a cricopharyngeal esophageal phase. You start with the voluntary phase. So you have mastication, you grind the food, then you try to propel the food into the upper part of the esophagus. And then it starts the propagation, what we call as natural peristalsis, which is very, very important because this is involuntary. And now, before knowing, we need to know some amount of peristalsis, what really happens. So you have a voluntary phase, then you have a peristalsis. So primary peristalsis is something which decides about our swallowing, and it is very rapid. So there is a relaxation and contraction. That is the equal sequence of a primary peristalsis. And if this get altered, so we deal with something called as motor dysphagia, which usually we see on endoscopy nothing, but there is dysphagia. So that can be multiple reasons. Then there is something like other contractions based on whether there's dilatation or whether spastic contraction, like primary, secondary, and tertiary contraction. So then coming on to the tertiary contraction, it is very important that, in some of the times we see on barium, earlier days we used to see that how our esophagus contracts. There's something called secondary peristalsis, which is important to clear our esophageal contents, because that's something which prevents the reflux disease, which is also a part of our daily routine swallowing. You have a transient relaxation, we'll have some GERD reflex every day, which is normal. If it becomes pathological, then that is a disease. So two main things. So first, history, then you know that there is real dysphagia. Now this is difficulty in eating. Now how you narrow down our possibilities. So then we think it is a two types. You should just remember that I said two phases were there. So you should remember that it is either oropharyngeal or the esophageal. Esophageal is a little bit lower. So oropharyngeal is something to do with the cricopharyngeal, where you can have structural as well as the functional, or it can be physiological. Then the second one is the esophageal dysphagia, which is a lower part, when you initial, where the voluntary and the involuntary phase is not there, and it only deals with esophageal disorders, we call as a lower dysphagia. So key thing, so what happens, many patients say that food sticks, and sometimes it is non-progressive, or sometimes there is nasal regurgitation. So there are some clues in clinical practice when patient says dysphagia. One is the age of a patient, duration of a symptom, whether it is sudden onset or it is a slowly progressive. The second thing is you have dysphagia, but there's not progressive. Patient is fine with similar symptoms. It's called episodic. So these are something which gives a clue that these people might have a small ring or a small constrictions, which is actually patient can be able to eat, but however, sometimes he might get pain or some swallowing problem, which calls episodic. The other thing is you have a careful history, which provides us an accurate assessment of dysphagia, and around 80% we can differentiate. So why it is important? At the end of your clinical examination, you need to be very sure that you're dealing with something like oropharyngeal, that is the upper part, or the esophageal dysphagia, because the total approach and management is totally different here. So there are different grades which you don't have to remember, depends, because it tells how severe the patient is. The second thing is medical history will tell location, types of food. Now you have to ask the second important thing, what sort of food? Is it liquid or solids? You know that anything mechanical, obviously patient says that solid food he can't take, he can take liquids. But however, on the other side, you have a motor phase where patient says he's able to read sometimes solids because of the gravity, and there will be dysphagia for both solids and liquids simultaneously, which is very, very important. Then the other duration. So this is a diagrammatic representation how exactly you can differentiate. You have an oropharyngeal upper part, which is difficulty in swallowing. Here you have choking and coughing. Why I tell you is when you have an is normal, but you have forgotten to examine his nasal twang or regurgitation or a neurological function, because many times it's not necessarily have weakness. You have a multi-infarct state or a CVA, which actually causes difficulty in the oropharyngeal phase. So your examination and history is very, very important in clinical practice. When your patient keeps coming back and saying that he has got dysphagia and your other tests are normal, because you forgot to ask, or you forgot, we don't do a quick simple neurological examination will tell that he still has a problem. So esophageal is something which patient says that difficulty, sometimes sensation, pain, all those things are there. And always the other clue is young patient, you have to ask whether it's like episodic, non-progressive, then nasal regurgitation, choking, cough will be a cough, nasal speech, drooling, choking. These are some amount of symptoms. The other history, what we say, foul smelling breath or a food. So this tells you that patients having dysphagia for quite some time, or there's a structure like diverticulum or a motor dysphagia where the previous food is still in the esophagus and he got halitosis. So it's an indirect evidence that we tell that patient has definitely dysphagia, and you can't send the patient just with some prescription of PPA or a prokinetic medications. So now let's examine him. So you have a history, you examine him. Some quick examination will tell whether he has some malignancy or not with notes. But we are not talking about more mechanical today, more of a non-mechanical or a non-tumorous dysphagia. I'll say, how do you approach that? So quick examination, you say. This is an important slide, which I say because when somebody says dysphagia, we always think of cancer. Not necessarily. There are many other causes which can actually cause dysphagia. So one important thing, what we forget, I said now differentiating cricopharynx and esophagus. When you say upper part, what are the things? One is obviously structural. You can have diverticulum, malignancy, stricture. Other thing is neuromuscular, which we forget in clinical practice. Like it depends. It need not be an old patient, even middle-aged patient who has a muscular disease like myasthenia gravis, or you have something like a motor neuron disease starts in third and fourth decades. So something which you have to keep in mind, these neuromuscular, both muscle and neural involvement simultaneously or independent can cause dysphagia. And this is something which is very, very important because this is an initial symptom which patient has. Laterly, he will develop a full-blown symptom neurologically where it's easy to diagnose. But here it will be a clue. Myasthenia gravis, Parkinson's, anyway, age onset is later. But however, some of the neuromuscular diseases keep in mind in clinical practice. Now, esophageal dysphagia is something easier. You know, patient says that difficulty in swallowing or he has stuck or pain with which will give you a clue that whether he has got malignancy or not. The other thing is how exactly you can differentiate episodic, non-episodic, progressive, non-progressive, weight loss, associated symptoms will tell you a clue what are the other causes of esophageal dysphagia. So this is another important slide. Because here, when somebody says dysphagia, we always remember in medical school cancer. That's one of the cause, but you have other many causes which we miss. So when somebody says that you have a dysphagia, you have done most of the tests, including a CT scan, you should not brand him as a psychiatric patient because you're not evaluated other things. So remember, neuromuscular diseases are still there, although it is rare, 1 in 1 lakh or 10 in 10, 1 lakh. However, we still see some of the cases, whether it is direct achalasia or a subtype of achalasia or secondary, sometimes post-viral infection. You have a motility disease which happens, or sometimes a neurological associated or even a pure muscle involvement can have motility disorder. So that we call as a primary motility disorder of esophagus, because these are not easy to diagnose. So you need to keep in mind, if you have, then you can diagnose. So how do you diagnose? Now you have a patient with dysphagia, you have narrowed down whether it's oropharyngeal or a esophageal. Then what investigation? You don't need everyone to be, you have to choose your investigation very religiously. So simple test, earlier days we used to say barium swallow, which now no longer we use very frequently. However, there are some indications. The other investigation, obviously endoscopy becomes one of the gold standard. It has to be done nicely with all the parameters. Then the important tool which we got in this era or now in 2025 is the high resolution manometry, which actually can subclassify all the motility disorders. So barium, just a few line on barium, still useful when you don't have other facilities. Simple but not plain. It's a dynamic barium. You need to time the barium, ask your radiographer timing of swallowing and take sequential pictures. So you can take this time barium or a video barium or a modified barium. So what else, what are the information you get here? You might get stricture, some motility disorder you can diagnose like achalasia if you don't have a manometry. But however, with more and more newer technology, the barium is being used in a very select group of patients. Then these are few pictures where you can see dilated esophagus, esophageal junction obstruction. The other second one, what we see, you get a patient of chest pain, you send to cardiology, we do all the tests, cardiac is negative, then they say it's a non-cardiac chest pain, you do endoscopy normal, then you send them to psychiatry. You don't have to, because you need to rule out certain things called as a spasm of esophagus, which can present with a tight chest pain or what we call as a non-cardiac chest pain or a atypical pain. So these are some of the subclass of people whom you have spastic disease of the esophagus. So endoscopic evaluation will not get into the detail because most of the B town or a small town have this endoscopic facility, but the important point is endoscopy has to be done very important. Like you have to check the upper esophageal sphincter, cricopharynx, esophageal mucosa, either ring, we cannot miss the ring, and webs. This is something very important, which is Western country. We see more and more case what we call as eosinophilic esophagitis, or simple, it's called as asthma of the esophagus. You have bronchial asthma. Similarly, esophagus also is sensitive, what we call as an asthma of the esophagus. Patient has allergic disease, mainly in children, dysphagia. So these people can have eosinophilic esophagitis. How do you diagnose? History. Sometimes endoscopically you get some exudates, which is similar to candidiasis, but there is exudates, some ring-like features, and biopsy. This is something which is treatable. But however, you need to have some history or suspicion that patient has eosinophilic esophagitis. If you send for an endoscopy, the gastroenterologist generally takes a esophageal biopsy, because that's the one which diagnoses eosinophilic esophagitis. Now, coming on to very interesting and a very exciting test, what we do in gastroenterology practice in 2025 is the high resolution manometry, both for esophagus and for esophageal sphincter. You can look at the physiology. So the upper part is the sphincter. This is a topographical graph which tells about the pressure gradient. So the minus is usually, the negative is on the blue side. You can see as it keeps becoming pink, it is positive. So you have a sphincter which is pressure is there. You can see that, and you start swallowing. There is a propagative peristalsis, small break, distal esophagus, and the sphincter. So general peristalsis is like this. So you have contraction, relaxation of the esophageal junction, then the primary peristalsis. That's the normal swallowing. So what we can see, these are some parameters which comes with this manometry, where we analyze this and we classify what type of dysphagia it is. So what is this? See, you can see the first picture was a normal physiology. Now you can see how abnormality we can see. There are a wide variety of abnormality. The first one, there is LES, lower esophageal sphincter pressure is high, but there is no contraction or peristalsis. So it tells that there is something, disease of the motility. So primary peristalsis becomes eclasia. Second one, there is some pressurization but no peristalsis. Third one, there is contraction. It's not a normal peristalsis. If you see the first picture which I showed you, you can see this is a normal physiological peristalsis. So then you can see this, how abnormality we see, and based on manometry and 4 or 5 parameters, we classify them as what type of motility disease is, because we can have precision treatment based on certain things. We can advise certain treatment so that patient gets benefit with the therapy. So these are some of the pictures which says that there is difficulty in the relaxation of the esophageal sphincter. So usually when there is relaxation, sphincter is not there, that means it becomes an obstruction at the esophageal obstruction. But when you do an endoscopy, they appear normal. So you can't tell them normal until you have this high resolution manometry. So that's the importance of manometry, which can classify whether patient has disease of the motility, disease of the esophagus or not. So how exactly it's going to be helping in our clinical practice? So if you look at this eclasia, where initially we said only type 1, now we have different class of eclasia, where because based on the resolution manometry, we can classify them as type 1, type 2, type 3, or other types, because treatment slightly varies for different types of eclasia. But this is mainly diagnosed by high resolution manometry. So now in practice, like you have to ask me, what is our at tertiary or low at a district level, what we can do? So you can still classify patients who don't have, who have dysphagia with this modality. So you know that what are the things you can tell normal. You can tell the sphincter is very low, and if you're a surgeon, if you're planning for a surgery like hiatus hernia, this will give an appropriate tell whether really there is hiatus, or because when you do an endoscopy, when patient is retching, that becomes hiatus hernia, and you operate the patient, and patient will get more symptomatic, so he will not get relieved. So before treating as hiatus, so this will tell us definitely what is the pressure at the LES or at the crural diaphragm. So you can actually confirm your presence of hiatus hernia before subjecting the patient for a surgery. Then you have normal contraction, ineffective, fragment, absent. So when you get this kind of picture, you can explain patient symptoms rather than telling that patient has psychological problems. So patient do have defective peristalsis, so which is one of the contributing factor for the symptoms. So you have LES pressure, you have contraction. So with these two, you can actually classify them what kind of motility disease he has. So let us summarize. You have a patient of dysphagia, diagnosed dysphagia by history, then your diagnosis confirmation with some history to rule out oropharyngeal and esophageal, then possible oropharyngeal, you have other fed, then you have a esophageal dysphagia. So how do you approach now? Patient with oropharyngeal dysphagia, you know there is anatomical problem, that is basically there is a diverticulum. The neurological extensive evaluation will tell you what kind of neurological problem he has. Now here, your management is multimodality, because as a gastroenterologist, you can only diagnose that, but treatment is multi, because you have neurological problem, you have a muscle problem, you have a combination of team like physiotherapy, speech therapy, and some medications, and tweaking some of the medications if it's a Parkinson's disease, so reduce the spasm. So these are something like how do you approach the oropharyngeal dysphagia. Coming on to esophageal dysphagia, you know it's esophageal, simple endoscopy will tell tumor, block or no tumor. Non-tumor resolution, just do a resolution, high resolution manometry. If it is positive, you have a classification what type of motility this is. If it is negative, now what to do next? So you have a negative, so you still have something like pH component. If all the things are negative, you can still do something called as imaging or an EUS to look at the sphincter. The last thing is CT scan to rule out any smaller paraneoplastic or an extrinsic compression, which will be the rare cause. If all the tests are negative and patient still has dysphagia, that becomes a functional, where you have to have some, patient might have some depression or associated psychological disorder. Sometimes they might have component called as functional dysphagia when all these investigations is normal, and then you have to use your other colleagues' help or a psychologist with some combination of medications. So esophageal dysphagia, now I said already you are diagnosed for HRM. What you do? We have any therapies? Yes, we have. We can actually do now endoscopic treatment like balloon dilatation we do. The other thing is we do per oral endoscopic myotomy. You can refer to surgeons, they can do myotomy HLRs, but now we do POEM or balloon. Then if it's elderly patient, we have some drugs like botulinum or calcium channel blockers to reduce the sphincter pressure, so it will benefit. So it depends on the age of the patient, underlying condition. So that's the algorithm for how we do approach dysphagia. So last slide, summary slide. So dysphagia in clinical practice is common, but when you get a patient of dysphagia, keep asking history, try to localize whether it's oropharyngeal or an esophageal, structural, non-mechanical. If you have structural, then it goes in other, you have to treat appropriately. If it is motility, you have to subject and diagnose through a resolution manometry, so that you classify what kind of motility disease he has. Then subject him either for an endoscopic therapy or a surgical based on the expertise available. Thank you for your patience hearing, and I'm happy to take some questions.
Audience, any questions, please? If there are no questions, I would like to thank Dr. Shirin Shetty for his wonderful, sweet and short talk about the dysphagia. Thank you.
Folks, let's remember, behind every radiograph, every report is a person simply waiting to enjoy a meal again. And that, more than any metric, it is what makes the pursuit worth it. Thank you, Dr. Shivan Shetty. I would like to invite Dr. Virupaksha Padi, Director cum Dean of SIMS Shimoga, to felicitate the moderators. I request Sir to felicitate Dr. Shiran Shetty. Thank you, sir. On to the next talk. GRD may sound like a simple reflux of acid, but for many, it's the quiet reflux of comfort itself. It turns something as ordinary as a cup of tea, a good meal, or a night's sleep into a source of anxiety. It's the sting that rises uninvited, the burn that blurs joy. Yet, what makes this condition remarkable is how far we've come from dismissing it as mere indigestion to understanding the complex dance of anatomy, its lifestyle, and emotion behind it. In treating GERD, we don't just soothe acid, we help people reclaim ease, rest, and the simple pleasure of living without the burn. Without any further ado, I invite our next speaker, Dr. Anand Totagi, trained at Jawaharlal Nehru Medical College, MD at MMC, and acquiring his DNB in Gastroenterology and Hepatology from Apollo Hospital, Chennai. I would also like to invite the moderators, Dr. Arvind CL, Dr. Mahendra M, and Dr. Madhusudan on stage.
Good afternoon, everyone. At this outset, I would like to thank you, Dr. Pradeep JK, for giving me a talk on review on gastroesophageal reflux disease. So this is a most common GI disorder that we see in outpatient in day to day. Every one of us will agree for that. So the presentation will have a pathogenesis, clinical presentation, evaluation, and treatment, mainly focusing on few of the things which have come recently into the GRD management. So it is defined as a condition where there is a reflux of gastric content into the esophagus, resulting in symptoms and complications. So the prevalence, if you look, the West has got almost 30 to 45% patients will have a GRD. In India, data says 7%, but definitely everyone will agree that it is increasing as our lifestyle is changing. So if you look at the lower, contains the intrinsic lower esophageal sphincter, diaphragmatic pleura as an external compression to the adding to the lower esophageal sphincter, raising the ileus pressure, and intra-abdominal location of the ileus, and phrenoesophageal ligaments which only support the ileus, and acute angle of His, which results in acts like an ball valve mechanism, so that it will prevent the reflux set coming back from the stomach into the esophagus. So one of the main one of these, when goes into a disarray, we will develop the reflux disease. So if you look into the pathogenesis of GRD, main important things are the first, that is impaired esophageal clearance, decreased salivation, impaired tissue resistance. The tissue resistance is very important. That is mainly epithelial and pre-epithelial. The reflux set always, most of the time, contains two important components. One is acid, another one is pepsin. So the constant reflux set will cause a constant injury to the lower esophagus, and lower esophagus is constantly exposed to these two things. So this barrier, or the epithelium, how long it will hold will depends upon the symptoms. If the barrier breaks down, then definitely the patient will become a symptomatic. Second, there is decreased ileus pressure, and the associated hiatal hernia, which is a very common association. So the presence of the hiatus hernia will push the lower esophageal sphincter above and the crura below. So the together, whatever they form, the basal LES pressure will be reduced. So there will be more reflux. And there is a bile reflux, which will add to the reflux entity, and it will exaggerate the injury to the lower esophagus, and lower esophagus will be more, so the patient will become more symptomatic. Delayed gastric emptying will result in more time the food will remain there. So if there is a reflux phenomenon is going on, so it will worsen. Actually, it will increase the duration of the reflux. So very important concept, that is acid pocket. That is the presence of an unbuffered acid in the proximal part of the stomach, which is seen normally in healthy individuals also in a patient with a reflux disease. But in healthy individuals, this will not cause into this will not be pushed back into the esophagus. But this component is mainly responsible if there are existing lower esophageal pressure, if they are reduced, or there is a hiatus hernia, or there is a resistance to the barrier. So in those patients, this acid pocket, which is present in the proximal aspect of the stomach, will go into the lower esophagus, and the patient will develop the symptoms. The important thing is that it has got a clinical implication also. Nowadays, I think many of us, we are using the raft, actually, that is sodium alginate. So the sodium alginate mainly forms a coat over this acid pocket and helps for the it prevents the reflux into the esophagus. So that is mainly for the prevention of this acid pocket coming back into the esophagus. The one common entity with what we commonly see is a hiatal hernia, where the part of the stomach which is pushed into the chest, actually. So the lower esophageal sphincter moves up. The part of the stomach has moved into the chest. That will cause as a hiatal hernia, and this will reduce the lower esophageal pressures, lower esophageal resting pressure, and there is a always reflux will be there from the gastric to esophagus. So the few important things, that is the volume clearance, that is mainly because of the defect in the lower esophageal peristalsis, and the acid clearance, that mainly because of the salivary gland secretions, if they are abnormal, that will add to it. Then the failure in the tissue resistance because of the continuous exposure of the acid and the pepsin. So that will lead to the symptoms. So we can consider it as the phenomenon where there is a gastric content containing the acid and pepsin is refluxed into the esophagus, and there is a failure of the peristalsis of the lower esophagus to clear it, and there is a reduced barrier that will lead to, and the one important component will be always an hypersensitivity. So if the patient is hypersensitive, then we will become more symptomatic for the acid exposure. So these four phenomena will contribute as for the pathogenesis of the gastroesophageal reflux disease. So the gastric factors which will contribute are mainly the volume of the food and the components of the gastric reflux, as I said, the acid and the pepsin. And duodenogastric reflux, that is bile, mainly add to this phenomenon. And delayed gastric emptying will make the more exposure of the gastric contents to the esophagus. The clinical presentation, mainly two important symptoms. The one is heartburn, another one is regurgitation. But never forget that it can radiate to the neck, sometimes to the throat, and even some patients do complain the back, actually. And the important thing is that when the patient has got alone chest pain, never take it as without absence of the heartburn. So we have to evaluate. The first thing is a cardiac evaluation has to be done before we attribute it to the esophageal reflux, the gastroesophageal reflux disease. Then other less common symptoms are the water brush, odynophagia, hiccups, nausea and vomiting. And dysphagia do one of the common component, but it is usually seen as a complication of the gastroesophageal reflux disease. Extraesophageal manifestations are very common in GERD, and they are non-cardiac chest pain, asthma, posterior laryngitis leading to the cough, chronic cough, and change in the voice, and recurrent pneumonitis and even dental erosions. So we need to be very careful regarding the extraesophageal symptoms, because many a times these may be the only symptoms the patient can present. But during the evaluation, the first evaluation should not be about a GRD in any case of cough, but it has to be evaluated by the ENT surgeon and respiratory physician for their common disorders from laryngitis to asthma or cough variant of asthma. So once they are not finding any cause, then definitely they need an evaluation by doing a gastroscopy. Never forget that alarming symptoms are very important. That is, first is dysphagia, significant weight loss, and hematemesis, unexplained anemia. So these symptoms are very important. Any patient who comes with a heartburn and regurgitation, every time we need to ask these questions, because if these symptoms are present, the patient needs evaluation on urgent basis. The diagnostic tests which are very helpful for the diagnosis of reflux disease. The first thing is, clinically, once the patient comes, who's a young patient who's coming to the outpatient, always never think of endoscopy. We can do PPI therapy for the 2 weeks. That is what is recommended. And if there is a positive response, then the patient, we can attribute it to the reflux disease. So drug trial itself for 2 weeks is an diagnostic modality for the reflux disease in young patients. The important thing is what is positive response. That is, if the patient complains that there is after the 2 weeks of therapy, 50% reduction in a heartburn and regurgitation, then that we consider it as an gastroesophageal reflux disease. This is a first thing we should do in an young patient, and that is an empirical trial of an acid suppression. The two another important tests are, one is ambulatory impedance pH monitoring, and second is gastroscopy. The barium esophagogram has been recently taken out as a diagnostic modality for the GRD. And the impedance pH monitoring, the new entity is a Bravo capsule, that is wireless capsule endoscopy, which is making the patients more comfortable, because keeping nasal catheter for 24 hours is always difficult. So Bravo capsule is coming up, and that as where we can monitor more than 24 hours, because the impedance pH monitoring is usually done for 24 hours. Bravo capsule we can go up to 4 days also. So this is a activity also, so that will be more realistic, since we are doing it for a longer duration of the time. The reflux, the events, correlation to the symptoms, we can better assessment will be there. As far as manometry is concerned, manometry is not used for the diagnosis of the GRD, but it is very helpful while placing the the distal end of the pH probe. And also, if you are thinking of any associated other motility disorders, as sir told now, so during that evaluation, the manometry will be helpful. So the impedance pH monitoring, the high resolution, as I told, is mainly useful for the pH placement, actually the pH catheter placement. And also we have to do it prior to the surgery, because we want that the patient should not have any esophageal motility disorder before we take him up for the surgery, even though there are a lot of changes in the guidelines. But prior to the surgery, it is mandatory to do the esophageal manometry in case of gastroesophageal reflux disease. So the impedance pH monitoring helps in the few things. One is the symptom correlation. As we know that during the mechanism, that one of the important component is an visceral hypersensitivity, and there is a lot of functional heartburn patients will be there. Even we are trying with the different multiple drugs, but the patient is still complaining of an heartburn. So it could be a functional heartburn. To identify those patients, one of the best tests will be the impedance pH monitor, because the symptom correlation we can do. Whenever the patient has got a reflux, the impedance pH monitor has got a mechanism where while during that time, we ask the patient, whenever he develops the symptoms, he can make a click actually, which will be noted in the report. So when he clicks, same time, we can see the intraesophageal pH drop actually. If it is coming less than 4, then okay, that the patient is symptomatic. Many a times the pH will be higher, 7, 8, and the patient still complains of, still he clicks and he perceives as a heartburn. So there is no correlation between the symptom and reflux rate. So that times we know that it is a functional heartburn. So we can clearly identify them, and those patients will never ever benefit from the PPI therapy. They benefit mainly from the pain modulation. So the common indications where we are doing the impedance pH is in case of non-esophageal reflux disease and hypersensitive esophagus and functional heartburn. And to clarify the role of acid and non-acid reflux in the etiology of esophagitis, that is mainly to look into the bile whether versus acid actually. Impedance will be very helpful in that. And the correlation between the symptoms and the acid and non-acid gastroesophageal reflux events, and how to determine the efficacy of the acid suppressive therapy also, this test will be helpful, where we can increase the dosage or decrease the or increase the dosage is required. Many times it happens that we are giving once a day, so probably they will do better with a twice a day therapy. So that can be assessed with the impedance pH monitor. So the Brevo capsule, as I told, it is endoscopically placed in the distal esophagus, no nasal catheter, and routine work can be done. And it can be kept for up to 4 days and no impedance. So since but the issue with this is we cannot go for if there is a reflux rate, what is the type of reflux rate, whether it is, the volume wise bile is there or not. So that cannot be assessed because impedance is not there. So the next important thing is very commonly done test, that is endoscopy in reflux in gastroesophageal reflux disease. So should every patient with a gastroesophageal reflux disease should undergo gastroscopy? Definitely no. The point is the ECG recommends that the first 8 weeks of therapy patient should be given. Patient who comes with the classical heartburn and the regurgitation, but in absence of the alarming symptoms. So once after the 8 week of therapy with the PPI, single dose, morning hours before meal, the patient, you go on tapering it. Either you can abruptly stop or taper it. And if the patient doesn't develop the symptoms, this patient does not require any gastroscopy. But if there are a recurrence of symptoms after the stoppage of medication, it warrants. So the second thing is atypical GRD symptoms. That is after, for example, the chronic cough is there, the patient with the other recurrent asthma, pneumonia, actually dental erosion, GRD after the other organs are ruled out, whether it is a lung or a throat or larynx from the expertise. The alarming symptoms, if the patient presents on a first visit only, he needs gastroscopy on immediate basis, as we discussed. That is dysphagia is there, odynophagia is there, involuntary weight loss, evidence of GI bleed, that is unexplained anemia, or you are evaluating for any other reason, you are finding that there is a esophageal stricture is there, or if there is any mass is there, then that patient need to be that patient should undergo the gastroscopy. In a patient who is having a Barrett's, the high risk factors for the Barrett's esophagus, male patient, more than 50 years, he's smoker, obese, having a hiatal hernia in a previous, endoscopy, or in any imaging actually. So those patients need to be subjected directly for the gastroscopy. And evaluation of the patients before and with the recurrent symptoms after endoscopic or surgical anti-reflux procedures. So what we look into the esophagus when we do a gastroscopy, that is mainly the reflux rate causing the erosions. And erosions we have graded as per the LA class, that is LA class A, where only less than 5 mm break is there, but it is on the mucosal fold. And LA B, class B has got a more than 5 mm break, and it is on the mucosal fold only, it is limited. And if it is in LA class C, where it is extending into the another mucosal fold involving less than 75% of the circumference, and LAD when involvement is more than 75% of the circumference. The LA class A, which is not very classical for the GRD, even it can be found in a normal patients. So it cannot be taken as an indicative of reflux disease. But B, C, D, if it is there, definitely that is a indicative of a gastroesophageal reflux disease. So once we diagnose, what options we have to treat them? So this has got four components now. The first is a lifestyle modification, drug therapy, then the endoscopic treatment and surgery. So this is the most important thing actually, the lifestyle modification. The first thing is elevating the head of the bed actually. This is very important, especially in a patients with the hiatus hernia. This is has got a greatest benefit in them. And losing weight if overweight. So optimizing weight is very important. That will definitely reduce the reflux disease, and at least 10% are going for their optimum weight for height. Third is restricting the alcohol smoking, and that both will alcohol and nicotine will reduce the LES pressure to the extent the caffeine and the tannic acid that is which is present in our tea also reduces the LES pressure. So they need to cut down their coffee, tea also to greater extent, but definitely the alcohol smoking they need to stop it. Making dietary changes, going for a small frequent meals and early dinner will be always helpful. And always remember, we need to ask every individual. There are few things which are common, like the spicy, oily, sour foods will definitely increase the acid output. We all know that. But there are food triggers which are very particular for an individual. So we need to ask for those food for the triggering foods, and we ask them to avoid for the whole life actually. But they will not be too much. So 1 or 2 or 3, but they need to avoid those food trigger. And refraining from lying down after meals and avoiding the bedtime snacks. So ideally the early dinner will be very helpful, at least 3 to 4 hours, which is almost 4 up to 4 hours is a gastric emptying time. So before that the patient should avoid lying down. So these lifestyle modifications are a rule for all the GRD patient, irrespective whether we give a drug therapy, go for surgery or an endoscopic therapy. But ideally, every patient these lifestyle modification he has to follow. The commonly what we always deal with is the symptomatic relief. Actually, the patient once they come to us, we try to give them a symptomatic relief. The common antacids what we use is they are mainly calcium and sodium carbonate. But the one issue with them will be actually post. But they still are they are recommended. They can be used. The one important thing what we are recently started using in last 1 decade is sodium alginate. Actually, sodium alginate, once it comes in contact with the acid, it forms a raft. Actually, it is a mechanical barrier which will prevent the reflux from the gastric to lower esophagus. So this acts very quickly, and that raft formation occurs in a few seconds to few minutes. So this can be used postprandially, because we discussed during the pathogenesis that the acid pocket which is formed is usually after taking a meal. Actually, postprandial, above the food content, there will be formation of the buffer zone, and that contains mainly the acid. So once this alginate comes in contact, it forms a mechanical barrier. So the sodium alginate is a very very important and gives a very quick relief to the patients. And this raft will there for 4 hours. So symptomatically it acts better than the age-old antacids. So the common drugs what we are using is a PPI. And esomeprazole, omeprazole, rabeprazole, we all regularly use these pantoprazole and lanso commonly. So what evidence says? The evidence is presently it is asking us to use it for the 2 weeks therapy is advocated. That is the first thing. And once a day therapy is advised. If the patient has got an extraesophageal symptoms, for example, bronchial asthma or chronic cough is there, erosions, dental erosions, those patients initially only the recommendation is to go for the BID therapy. Even in a patient with a reflux disease, we can increase if symptomatically there is a partial response with the once-a-day therapy. But once-a-day therapy, it should be initially tried. So how to choose the PPIs? As far as non-erosive esophagitis, see, the erosive esophagitis is seen in 15 to 20% patients. That is, once we do endoscopy, we are finding there are erosions. So the patients who are not having erosions are 80% and 20% are with the erosions. So patient where there are erosive esophagitis is there, they do very well with the esomeprazole as compared to other molecules. And in non-erosive esophagitis, there is no difference in PPI. So you can choose anyone. So majority, we can choose any one of these. And if one particular molecule patient is not doing well, we can change it and see, even that recommendation is there.
Anand,
Yeah.
we are running out of time.
Sure. Okay. So 8 weeks therapy is recommended, and always reduce and stop the PPI. And the chronic intermittent therapy, short term, we can use it after 8 weeks if the patient becomes symptomatic, or one or 2 days therapy that is on demand. Never forget the PPI side effects. The one important thing is while using the clopidogrel, try to avoid the esomeprazole because the CYP2C19 mechanism, because the drug induces its metabolism. So the newer drugs, that is a PCAB, I think now they are this molecule has a new horizon actually. There was a gap in when we find the PPI usage, that is mainly the nocturnal breakthrough was not there. Nocturnal breakthrough even after using the PPI. And second is we need to take the drug before meal. And third is that it takes longer time for a maximal action. So this has come, these three problems are overcome by the PCABs, that is a ionic binding potassium channel blockers actually. And the one important thing is they act for a longer time, and their effect is sustained for 24 hours. The intragastric pH will be more than 4 for most of the time in 24 hours. So nocturnal acid breakthrough is better, has come down. So in compared to all the things, all other PPAs, the PCABs score over actually are at least non-inferior. So presently the PCABs are recommended only in an investigated case of reflux disease, whether it is a gastric problems, whether it is ulcer disease to this thing. So presently it is recommended mainly in one important thing is H. pylori eradication, and the indications are coming out with the class C and class D esophagitis actually. In rest, I think it is still, we need more data. Endoscopic techniques which are recommended only after the surgery fails by the ACG, that is transoral incisionless fundoplication, that is TIF we call, by using the esophagus, and that's Muse, which will increase the lower esophageal, the muscle hypertrophy. It causes fundoplication. The transoral anterior fundoplication can be done with these machines. And the non-ablative, that is Stretta, where it produces a radio frequency ablation, and it will cause the lower esophageal muscle hypertrophy, and that will increase the lower esophageal pressure and prevent the reflux. And the Gerdex is one more this thing, but data is very not very encouraging. And the newer technique which we are now behind is ARMA, that is anti-reflux mucosal ablation, mucosectomy, and mucoplasty, where from the using an endoscopy by doing retroflexion, we are actually where you can see the in and around the lower esophageal sphincter, we can see in a retroflexion, and as they are the earliest pressure is weakened, so we can burn it 270 degrees and it will heal by stricture, and which will reduce the circumference, and in turn it increases the pressure. So the surgery presently indicated in cases with a class C and class D esophagitis and large hiatus hernia, that is more than 5 centimeter. Few studies say more than 7. And persistent or troublesome symptoms, if the patient is really symptomatic and it is really troubling, especially in an engaged patient, we can consider. The surgery of choice is Nissen's fundoplication, and it can be done either open surgery or laparoscopy. But the surgeon expertise is very much required, because the excess, if there is a wrapping is there, the patient will develop the dysphagia, which is very difficult to handle. So never forget the complications. Why we are treating the GERD not only for symptoms, mainly for prevention of the peptic stricture, Barrett's esophagus, and adenocarcinoma. So with this, I would like to end my talk regarding the recent update regarding GERD.
Thank you, sir. Thank you for the very narrative and informative talk on GERD. Once again, thanking. Any questions from the audience, I think will be answered.
Sure.
If no questions, means okay, thank you.
Yeah, sure.
Thank you, Dr. Anand, for that informative talk. I would like to call upon Dr. PLN Achar to felicitate the guests on stage.
ಇದು ಅವ್ರದ ಆಯ್ತು ನಿಂತ್ಕೊಳ್ಳಿ.
Thank you, sir. I would like to request Dr. Arvind CL to remain on stage for the next talk. The next talk, constipation, the most silent. It rules morning routines and ruins many moods. It's proof that even the gut has a personality, stubborn and sometimes sluggish. Behind every case lies a story of modern life. Too fast to eat right, too stressed to move, too dehydrated to move. And while we joke about it, we know it's not just about bowels, but balance. Today, I invite Dr. Amit Yelsangikar, a consultant medical gastroenterologist of Aster Hospital, Bangalore, to give us a talk on the dreaded yet misunderstood topic of chronic constipation. I would also like to invite the moderators, Dr. Madhusudan, Dr. Virupakshappa, Dr. Rakesh Kori, and Dr. Arvind CL on stage.
ಹಾಕಿದ್ದೀರಾ? ಬೇರೆ ಕಡೆ ಕೊಡಿ, ಬೇರೆ ಪೋರ್ಟಲ್. ಇದರಲ್ಲಿ ಇಂಟರ್ನೆಟ್ ಇದೆಯಾ? ಅಂದರೆ ಅಲ್ಲಿಂದ ಮೇಲಲ್ಲಿದೆ ಬಂದು ಎಲ್ಲ ನನ್ನ ಲ್ಯಾಪ್ಟಾಪ್. Very good afternoon to all of you. Thank you, Dr. Pradeep, for invitation. Just for my information, how many surgeons in the audience? Okay, we have some surgeons. How many physicians? And rest are general practitioners? Okay. Okay, this will make my job a little easier. So, thank you for the invitation again. Respect the talk. Can you just tell me how the pointer goes? Okay. Slide change ಆಗ್ತಾ ಇಲ್ಲ. So, my topic today is approach to chronic constipation. I'm sure there is no one in this audience who has not suffered from constipation at some point in their lives. I'm sure all of us have handled some patient who's had constipation at some point in their practice. So this is relevant to all of us. This is the outline of my talk. We'll start with some introduction to chronic constipation, look at some of the epidemiological features. See how we can classify this disorder, look at some of the newer modalities in the diagnosis of constipation, and how do we manage. So why is it important to talk about chronic constipation? It is important because all of us see this. It is so common in general practice. And not only is it common, it is a very distressing complaint for our patients. No one is happy with their bowel movements most of the time. Almost half of our patients, when we ask them, how's your bowel movements, they come out and say, not happy. So at some point of time, they are either unhappy, not having a regular bowel movement, having to use some medication or some lifestyle measure. So this is a distressing problem in general practice. And not only does this affect the quality of life, it also makes them come to the hospital, see doctors, it increases costs, and it causes a lot of anxiety and depression because of this. If you ask a person, ಇವತ್ತು ಊಟ ಮಾಡಿದ್ದೀರಾ? ಇಲ್ಲ, ಇವತ್ತು ಮೋಷನ್ ಆಗಿಲ್ಲ, ಸ್ವಲ್ಪ ಊಟ ಹೋಗ್ತಾ ಇಲ್ಲ. So everything is connected. The appetite, the food intake, their general outlook towards life is connected to the bowel movement. So it is important before we discuss what is chronic constipation to know what is not chronic constipation. So if someone has short-lasting symptoms, he went for a drive, went for a holiday, came back, and next week he says, bowel movement is not all right. That is not chronic constipation. That is just constipation that has been there for a day or two. It is based on the situation. Someone who's had a meal with a lot of meat, not enough fiber, maybe next 1 or 2 days, he may not have a regular bowel movement, or it may be very hard. So that again is not chronic constipation. It is another situation which presents with constipation. So this can be because of travel, it can be because of acute illness, surgery, especially post-surgical patients tend to develop a lot of constipation, maybe due to multiple reasons. And this again should not be confused with a chronic constipation. And usually all these are self-limited. They may require short-term therapy and are usually easy to manage. So what is chronic constipation? It is a persistent condition, lasts for more than 3 months. On more than 25% of the days, the person is having problems with their bowel movements. Either they don't have spontaneous bowel movements, or it reduced in number. Usually in the West, they say at least 3 bowel movements per week. But no one in India is happy with 3 bowel movements per week. Everyone wants at least 1 or 2 bowel movements for them to feel. So this is a cultural issue. This is not something that we can sort out between East and West and say, okay, in the West it is 3 days a week, so India also it has to be. No. This is a cultural thing, and we have to treat our patients as our patients. We can't show them the Rome criteria and say, oh, but you are having 3 times a week, that is good enough for me. No, it is not. So patient will not be happy unless they have a daily bowel movement, sometimes 2 times a day, and they feel satisfied. So it is not just that chronic constipation is just reduced number of bowel movements, but also associated symptoms. And what are these? Stool becomes hard in consistency. There is excessive prolonged straining. They say I'm sitting for 5 minutes, 10 minutes, straining, using a lot of force. I'm getting tired, but nothing is happening. So there may be many futile visits. They may go to the toilet, come out, not happen. There is this sense of incomplete evacuation. Doctor, motion aitu, but complete agila, matte hogbekaitu. Not satisfied. Some patients may have sensation of block. Motion bartade, ಹೋಗ್ಬೇಕು ಅನ್ಸ್ತದೆ, but ಕೆಳಗಡೆ ಬಂದು ಅಟ್ಟಿಸ್ಕೊಳ್ತಾ ಇದೆ. It is coming and getting blocked. Then what is the next? When it gets blocked, what does the patient do? He will either use the faucet or he will use his is again a feature of constipation. And there may be associated pain, bloating, feeling of gas, and these are associated symptoms, especially when they have what we call as irritable bowel syndrome associated with constipation. So it is not just the number of stools, it is also other associated symptoms like consistency, straining, and sense of evacuation. So when we come to the consistency, it is easy to explain to someone if you give them a visual graph, and they will also explain to you what their stool looks like. Nowadays, patients take photographs and they send you the photograph or they show it to you. Yesterday it was like this, today it is like this. Today it is like goat's pellets. Yesterday it was like sausage. It may sound silly, but it is very important because this correlates with the colonic motility. So someone who has poor colonic motility usually has the type 1 or type 2 stools, whereas those who have very rapid colonic motility have type 5, 6, and 7. So diarrhea-like consistency. So it's important to document what is the consistency of patient's stool, which helps in the management. So as I said, chronic constipation is very common in our practice. If we look at hospitalized patients or patients who come to the outpatient, almost 25% of patients will have constipation at some point in their lives. In a gastroenterology practice, it may go up. When we look at general population, we look at data from all over India, almost 10 to 15% of general population have experienced constipation. And it is more common in women, more common in elderly, although constipation is something that is seen at all ages, but as we grow older, the incidence of constipation goes up. There may be associated disorders like chronic disorders, diabetes, hypothyroidism, neurological conditions, which are again associated with chronic constipation. This, unfortunately, is an era of polypharmacy. If we see our patients, they will come with prescriptions which have at least 5 to 10 medicines. And a lot of these medicines are again responsible for the constipation. So it is important to know what is the drugs that the patient is taking. So are all constipation the same? You might have noticed that patient comes to you with constipation, you give some medication, either there is no response or there is poor response, or sometimes there is response but not sustained. So why is it that patients are not responding to treatment? It is because constipation is only a symptom, whereas the conditions are heterogeneous. There are various disorders which present with this symptom. So for that reason, the response to therapy also differs. So how do we classify? The classification of chronic constipation could be either primary, where we have different disorders like slow transit constipation, normal transit constipation, and then we have this peculiar disorder called dyssynergic defecation, also known as fecal evacuation disorder. The other condition that I alluded is patients who have irritable bowel syndrome associated with constipation, that is IBS-C, where they also have pain and bloating along with the constipation. The other condition is the secondary constipation. So primary constipation, we don't know the exact cause, whereas secondary constipation is always associated with a known cause for the constipation. So it is important to know whether the patient has secondary constipation, because this could very well be curable, treatable as well as curable. So which are the common conditions which cause chronic constipation? Some organic conditions, some very serious organic conditions like colorectal cancer, some inflammatory bowel disease, colonic strictures can lead to chronic constipation. Various endocrine or metabolic disorders like diabetes, hypothyroidism, hypercalcemia are known to cause or present with constipation. Sometimes the constipation may be the presenting symptom of these conditions. For example, hypercalcemia presents with constipation in many patients. In the elderly, neurological conditions like motor neuron disease, Parkinsonism, strokes, as well as myopathies can present with constipation. Conditions of the anorectal junction, for example, fissures, strictures, proctitis, again, can lead to constipation, especially when they are associated with anal spasm. Various drugs, most important of which are opioids. Today, tramadol is being used left, right, and center by most patients. Even it is available over the counter. And this is one of the most common drugs that we see that is associated with constipation. The other drugs like calcium channel blockers, iron preparations, anti-epileptic drugs, tricyclic antidepressants, benzodiazepines, again lead to a lot of constipation. A factor that has been given very less importance and probably we should give more importance to is the diet, especially a refined diet, a low fiber diet tends to be one of the hidden causes, especially patients who are they have more problems. Those with sedentary lifestyles, especially the software engineers, those who don't exercise, who don't have the kind of active lifestyle, again, are likely to have this problem. So when we come to primary constipation, the first disorder that we should know is slow transit, where the colonic motility is affected. And these patients present with a very poor urge. 2-3 days at a time, they don't get the urge to pass stool. And because of this, they have infrequent bowel movements. Once the stool takes a longer time in the colon, water is absorbed, so consistency becomes hard, so they have very hard stools. The second disorder is the dyssynergic defecation, which is a problem with the anorectal incoordination. And this is presenting with prolonged straining, prolonged evacuation time. Patient starts spending more than 10, 15, 20 minutes in the toilet, starts using their finger to bring out the stool, and at the end of it feels that defecation is not complete. So these are the classic symptoms of a defecatory disorder. So how do we approach this condition? How do we approach this problem for making the correct diagnosis? As you know, there are various problems. So if we don't make the correct diagnosis, we'll be using the same drug for everyone and obviously not getting the best results. So it is important that we start with a good clinical history. So in the history, it's important to know what is the duration of symptoms. A shorter duration, again, becomes unlikely that this is a chronic constipation. There may be a secondary cause or an organic problem. We have to document the number of bowel movements, the consistency of the stool, whether they are straining, whether they are using some digital maneuvers, what is the evacuation time, is there complete evacuation, and is there associated pain and bloating. As was discussed previously, the red flags in this condition are bleeding, weight loss, and this entity known as spurious diarrhea, where patient is passing loose stool but actually has obstruction. So this is something that is very dangerous, and you have to evaluate to find out if they have a colon cancer or an inflammatory bowel disease. Comorbid illnesses, we have to inquire about diabetes, hypothyroid, any neurological conditions, and what are the surgeries, especially spine surgeries. Patients with spinal surgeries, especially in childhood, for example, spina bifida and things like that, there may be associated constipation. And last but not the least, the history is not complete without knowing what the drugs the patient is on. Coming to the clinical examination, everyone should learn how to do a good rectal exam. Whether you're a physician or a surgeon or a general practitioner, you cannot get away without knowing how to do a rectal exam. So a simple rectal exam should be assessment of the anal tone, where we look at the external sphincter. What is the resting tone? Is there a spasm? Is it very flaccid? And then the next step would be to use the finger and ask the patient to squeeze. That means you ask the patient to contract the sphincter and see how much he's able to generate the force. And next, the third step would be you ask him to try and pass the finger out, like how he would pass motions, and look for the relaxation of the anal canal and the contraction of the rectal musculature. So this is a simple 3-step digital exam that everyone can do and will be able to manage in the bedside itself. So the simple basic investigations that we should be doing in patients with constipation would be a complete hemogram. Hemogram would tell us if there is anemia. One of the things that we pick up on a hemogram, a peripheral smear, is basophilic stippling, which happens due to lead toxicity, again can present only with constipation. Patients with diabetes, test is important, and estimation of calcium parathormone levels, because we can sometimes pick up this parathyroid adenomas, which can again present with hypercalcemia and constipation. But what are the diagnostic tests? Diagnostic tests are tests like colonoscopy, a colonic transit study, and anorectal manometry. Now we had Dr. Shiran telling us about esophageal manometry. A similar test is available for the anorectal junction, which tells us in a high resolution format the coordination between the rectum and the anal canal. And then we have specific tests like MR difficography for surgical patients. So as I said, if you have a red flag, you have an elderly patient, there is rectal bleeding, anemia, weight loss, and short duration of symptoms, we cannot not do a colonoscopy. The evaluation will always start with a colonoscopy. You exclude that there is an obstruction, a cancer, or an inflammatory bowel disease, and then the diagnosis goes further. Another condition that we can pick up on colonoscopy is this solitary rectal ulcer syndrome. Unfortunately, it's a misnomer. It's neither solitary, there may be multiple ulcers, and there may not be an ulcer at all. So there may be just redness, erythema, and this is due to trauma caused by the finger. So anyone who's used to using the finger to bring out the stool can present with this solitary rectal ulcer. So it is a form of a dyssynergic defecation. The other test that we look for to diagnose slow transit is what is called as a colonic transit study. Now there are some markers which are in the capsule. The patient swallows these markers and then does an X-ray after 36 hours or after 60 hours. And if these markers are retained, then we know that the colonic movements are significantly less. And that tells us that we need to augment this motility to give the patient symptomatic relief. Anorectal manometry is the best test to diagnose dyssynergic defecation. It is simple, it is rapid test. It takes about 5 to 10 minutes and it can be done at the bedside with the equipment. It is largely non-invasive and it helps us differentiate a dyssynergic defecation from the other types of constipation like slow transit or normal transit. And it is important to differentiate because the treatment of dyssynergic defecation is not medical therapy or drugs, but whereas a treatment modality called as biofeedback therapy. So biofeedback therapy can only be done once we diagnose dyssynergia. So anorectal manometry is important. So this is our setup in the motility lab where we use these catheters and it is connected to a balloon. We inflate the balloon in the rectum, find out the pressures, and then ask the patient to expel the balloon. So this is a normal manometry that you can see as the balloon is being expelled, the graph shows reduction in the pressures. Whereas a person who has dyssynergia, the balloon cannot be expelled. So there is absence of balloon expulsion, and then you can see that the very high pressures, what is the black color, there is a high pressure zone in the rectum, but the balloon is not coming out. The anal canal is not relaxing when the rectum is contracting. And based on this, we have various types of dyssynergic defecation based on whether the rectum is able to generate adequate pressure, whether the anal canal is able to relax adequately, whether there is an inadequate relaxation as well as inadequate contraction of the rectum. So all these different types of dyssynergic defecation can be diagnosed based on the manometry. So defecography is used by surgeons to diagnose what is called as a rectocele and sometimes a rectorectal intussusception. It is usually used before planning surgery. So treatment of chronic constipation starts with the lifestyle measures. We have to give importance to the dietary fiber, the exercise, as well as hydration, at least 1.5 to 2 liters of water intake. Fiber has to be at least 25-30 grams of fiber every day. There are various pharmacological methods that can be used, including increasing fiber as well as some other drugs. Behavioral therapy, as I mentioned, biofeedback therapy can be used for patients with dyssynergic defecation. So one of the main things that we should remember is the drugs which are causing constipation need to be avoided. So we have to again go back to the drug history and recommend that drugs either be substituted or changed to something else. And it goes without saying that optimizing diabetes management as well as hypothyroid management goes a long way in management of the constipation. The other thing that is not given much importance is toilet manners. We have people taking their telephones, newspapers, iPad to the toilet. That should be stopped. Second thing, the position of the person during defecation. Normally, a lot of people are using the Western style toilet, which is not the ideal position. It makes the anorectal angle more acute. So Indian style toilet is preferable, but if they have a Western style toilet, they can use a footstool under their feet, which increases the height by at least 6 to 12 inches. And this again helps to improve the evacuation. So when it comes to pharmacological therapy, the main goals are to have a regular normal bowel movement, reduce the hardness of the stool, and improve the quality of life. So we have various drugs starting from simple therapy like fiber supplements is a goal. Mild drugs like osmotic laxatives, lactulose, polyethylene glycol, stimulant laxatives like bisacodyl, what is known as Dulcolax, and colonic prokinetics like prucalopride, as well as secretagogues, which make the colon and small bowel secrete more fluid. Now, these are newer drugs like linaclotide and plecanide. All these drugs have their benefits and side effects, and they are preferable in some conditions and not preferable in some other conditions. So the algorithm is, if you have an increased problem with chronic constipation, then the mildest treatment is the fiber. If the fiber doesn't work, then next we use the osmotic laxatives, and then go on to the newer drugs like linaclotide, plecanide, as well as prucalopride. In case there is a suspicion of dyssynergic defecation, we refer for anorectal manometry and biofeedback therapy. So this is how we do the biofeedback therapy. There is a commode in the department where we make the patient expel, and he's getting a live feedback correctly or not. So this generally takes about 30 to 45 minutes. We do about 3 sessions a week, and then once in 3 weeks, and then once in 3 months, depending on the requirement. So we have guidelines from our own society which tell us how to evaluate patients, and these are available online for free. So these are some of the practice tips that I recommend for all patients. If you have short duration of symptoms or situational, just go for a contact laxative like Dulcoflex. If there is fecal impaction, especially hospitalized patients, look to give them paraffin to liquefy the stool and then use polyethylene glycol. Those with mild symptoms or who have associated liver disease, we may use lactulose. Lactulose should be avoided in someone who has uncontrolled diabetes. It tends to increase the blood sugar levels. Slow transit constipation, we use linaclotide, lubiprostone, prucalopride. Those who have IBS with constipation, again, we try to use polyethylene glycol. If it doesn't work, then linaclotide. Those who have fecal evacuation disorders, the treatment of choice is biofeedback, biofeedback, and biofeedback. Thank you.
Hello. Any questions from the audience? No questions. Thank you very much, sir. Thank you very much, sir, for your wonder.
Thank you, Dr. Amit. I would now like to call upon Dr. Ramakrishna HK to felicitate the guests. Thank you, speaker, and thank you to the moderators. Next up, we have a topic that has a history. In 1960s, there was a scientist named Dr. Baruch Bloomberg who discovered a strange antigen in the blood of an Australian aborigine, what we now know as the hepatitis B virus. This single finding would go on to save millions, giving the world a vaccine that could prevent cancer. And yet, the story isn't over. Hepatitis B still lives quietly in millions and a silent companion, slowly etching its mark on the liver. It lives in mothers unknowingly to children, workers who miss checkups, and communities where stigma outweighs awareness. The good news is we know now more than ever. We can detect, treat, and prevent. Hepatitis B is no longer about chronicity but continuity of care, compassion, and commitment. Without further ado, I invite upon the exceptional Dr. Satsangi. He is a senior consultant hepatologist and liver transplant physician at Apollo Comprehensive Liver Care. It is my honor to invite you, Dr. Satsangi, to give an overview about chronic hepatitis.
Sorry.
I would like to call upon the moderators, Dr. Gopal, Dr. Sudhendra, Dr. Manu Maganur, and Dr. Indumati on stage. I would also like to call upon Dr. Amit on stage.
Thanks a lot, Dr. Pradeep, for the kind invite. So the topic given to me is a very important and I think a very common topic in day-to-day practice, which is on Hep B. A very precise question asked to me when to start, when to stop. In a recent gastroenterology forum, I had discussed on this. It was a 45-minute session where in-depth part of each and every guideline were discussed. But the point here is not to confuse. 5 days back, we had the latest guidelines from the AASLD, and I'll be speaking more on that so that it becomes less confusing and more from a clinical standpoint. Before understanding Hep B treatment when to start, the most important point of discussion is what is normal ALT. We all know that in some labs it'll be mentioned 60, some will mention 50, some will mention 40. So the American group says that for men it is 35, for females it is 25. The EASL, the European Society, sticks to 40. But there is a study from India which actually looked on in healthy men and healthy women, what is the cutoff. So it's surprising. The cutoff actually is at 28 for men and 19 for women. Again, indicating that if you probably see a patient of Hep B with an ALT of 40, or even usually if you see a ALT of 40, that probably might not be normal. So that's the reason at this point in time, probably the guidelines will change and future we will have lower ALT cutoffs. But for now, the EASL context says 40. And as I told you, the ASLD still sticks on to 35 and 25. The most important point in Hep B treatment is going to be you are going to aim for functional cure, wherein you want your patient to lose the HbAg 24 weeks of therapy. Now, important would be certain definitions and certain terminologies which you commonly refer to. The one which is called as the immune tolerant phase. So what is immune tolerant phase? Where the DNA is skyrocketing high, more than 10 to the power 7 log values. The ALT is normal and the E antigen is positive. So this is the typical immune tolerant phase wherein always the guidelines have recommended us that you shouldn't be treating because the body is not reacting to it and there is no scarring or no inflammation happening. But is there any update in this? I'll speak on that. Talk about inactive stage first. So inactive would be a contrary to immune tolerant wherein you have not only the ALT normal, but even the DNA is quite less. So the cutoff is less than 2000. So that is inactive. So the active is somewhere in between. So this is where in E antigen positive disease, the DNA cutoff is mentioned at 20,000. The ALT should be more than 2 times upper limit of normal. So that would be 70 for men and 50 for females. In an E antigen negative, the ALT cutoffs remain the same, wherein you want to start treatment, but the DNA cutoffs go down to only 2000. So E antigen negative disease, 2000 cutoff, and E antigen positive disease, it is 20,000 cutoff. We spoke about the terminology of functional cure. So non-cirrhotic hepatitis B, cirrhotic is quite easy, which I'll tell, but non-cirrhotic, all the guidelines very clearly are having a clarity that you should have 3 parameters. You should have some cutoff understanding on DNA. You can't just start at any DNA. The ALT values need to be abnormal. That is very important. And for some reason, if you're doing a biopsy, there should be histological evidence of severe inflammation or significant fibrosis. Now, the ASLD and the Asia Pacific guidelines, which I spoke recently about, would tell that for E antigen AG positive disease, it is 20,000. Look at that for the E antigen negative disease. So it is 2000 only. The abnormal ALT values, so the ASLD and APASL tell that wait for 2 times, whereas the EASL is much more lenient. Anything more than upper limit of normal. So if you are considering 35 is upper limit of normal, even if 36 is considered abnormal from the EASL group. So they are much more lenient in advising for antiviral. Histological disease, you're talking about having moderate necroinflammation or anything F2 or more fibrosis based on the Metavir scoring system. Now, very important about immune tolerant phase. So the considered treatment in individuals more than 30 with persistently normal ALT and high DNA values regardless of fibrosis stage. So what is now happening is, again, EASL is becoming more and more lenient, the European guidelines, that immune tolerant, but now the age is crossing 30. There might be a situation where ALT still is normal, but the patient can have histological progression, which is why now more and more guidelines are going on slowly towards telling that immune tolerant also should be treated. ASLD, however, differs on this. It doesn't say 30. 30 is too young. It says wait for 40 years. So if you're waiting for 40 years, or you're getting a fibroscan values, which we'll talk about in my next talk. But fibroscan values, if the LSM values are more than 8, indicating anything F2 or more than F2 fibrosis, even if the ALT values are normal in immune tolerant phase, you need to treat these patients. Cirrhosis, more or less all the guidelines are quite unified that if you have a cirrhotic, any detectable DNA you would want to treat. A Basel says wait for 2000. I would still say all the guidelines still are pushing towards any detectable DNA, treat it. Decompensated, again, same, any detectable DNA, treat. So cirrhosis, compensated, decompensated, quite saying that you can start the values. If it's any detectable, you can start the values. Now, a very important point, when to stop. So this is where the latest ASLD guidelines is giving some new points. Earlier, it used to say that if you are actually having an E antigen positive patient, when the E antigen is becoming negative and HBe antibody is becoming positive, for 1 year it is remaining positive, and 2 consecutive years the DNA is remaining negative, you can consider stopping treatment. This was the earlier statement. And then the new statement, they pull off. They say that ASLD doesn't recommend stopping treatment, even if that rule is met. Why? Because now they want all the criteria to be met. So these were the guidelines came up around 5 days back, which tell about that you should have no history of advanced fibrosis on the fibroscan. Obviously, cirrhosis, you would not be stopping. This criteria still is there that you need to have E antigen becoming negative and anti-HB positive for more than 1 year, undetectable DNA for 2 years. But what they have added is this now, that you need to have a quantitative HbSAg value, which is less than 100. Because they have noted that if this is not met, the moment you pull off the therapy, if the quantitative HbSAg is more than 100, even if the DNA is negative, the patient can have a flare and a rebound. And that is why they want even this to be met, only then you can stop. Now, for some reason, you decide to stop. Say at 3 years, 4 years, you met all the criteria. How do you follow up these patients? This is also new guidance which has come, that every 1 to 3 months, you have to check for first 6 months, and then subsequently you can go lax at around 3 to 6 months for the next 6 to 12 months. At any point in time, if the DNA crosses 4 logs, you need to start the treatment independent of the ALT values. So even if the ALT is normal, but the DNA is crossing 10,000, start the treatment. ALT more than 5 times, obviously. Bilirubin more than 2.5, obviously. Any hepatic decompensation, obviously, you have to start treatment. Here, they've also given this personal desire to restart. This is very common. The patient comes with a very panicky sort of a sensation that I have a DNA high. Will I spread it to my partner? All these things. Again, the guidelines are telling that it is in the clinician's choice that you can go ahead and start the treatment. In pregnancy, so imagine that your patient who's already a Hep B patient has become pregnant. Again, a latest guideline. If the patient is on entecavir, don't keep her on entecavir. Please move on. Now, TAF also data has come, the newer molecule, which is tenofovir alphenamide. The maximum robust data is for the TDF, the earlier molecule. But now, the guidelines recommend that you can use either TAF or TDF. So if they are on ETV, please move on to TAF or TDF. Now, imagine that if the patient is not on treatment, then you are waiting for 28 weeks. At 28 weeks, if the DNA value is more than 200,000, that is where you would want to start the patient on TAF or TDF. And when would you want to stop it? Either at delivery or 12 weeks postpartum, you want to stop. And when you stop, you have to be careful. Again, follow up 1 monthly for at least 3 months after stopping the drug, that whether they're developing any flare or not. I just thought it's very important to talk about this guideline, which is the WHO guidelines. This just changes too many things. They are the most lenient guidelines which has come for Hep B, probably saying that you have to treat everybody. So if you just see this, the number 1, irrespective of the ALT, irrespective of the DNA, if your patient has F2 or more than F2 fibrosis, you treat the patient. They say the DNA more than 2000, any ALT above the upper limit of normal, you treat the patient. And look at this one. The most interesting part was where you have any comorbidities. And in the comorbidity, they have also mentioned diabetes and MASLD, fatty liver. It is so common to have a Hep B patient just have a diagnosis of some grade 1 fatty liver. They say that you don't want to take a risk. Now the patient has another disease which can cause liver damage. Why do you want to keep the DNA unchecked? So they are going so liberal that any other comorbidity you would want to treat the patient. So whether you choose your TAF or TDF or ETV, which is completely okay, any one of the three is okay. What about acute Hep B? That's a common question again. So all the three guidelines, important point is that those who have severe protracted acute hepatitis B have to be treated. Any acute liver failure, that is INR more than 1.5, altered mentation, you have to treat. But otherwise, the bilirubin criteria is 3, INR more than 1.5, development of encephalopathy or ascites, you treat. So in this AVH setting of hepatitis B, that is without underlying chronic liver disease, you still treat. So coming to conclusion, most important is aim for functional cure. That is the reason ASLD now says that you can continue the antiviral drug till the patient loses HbSAg, or adding on the criteria that if the quantitative HbSAg values are less than 100, along with the other parameters, only then you can stop it. And the reason why this is probably happening is because of easier accessibility to drugs. The cost is quite low. It is extremely safe, we all know. And more data is coming on this, on non-invasive estimation of liver fibrosis. So we are picking up those patients with LSM of 8, 9, some hidden fibrosis. Probably that is fatty liver which is doing that. That is not the point at this point in time. Any liver disease which is going on, you need to tackle the DNA so that you can get the DNA low, so that at least Hep B doesn't progress. And we all know that the side effects of these drugs are quite less. You can choose freely among any of these three drugs. The only thing is they say that TAF is better if you have any underlying kidney ailment, or in osteoporosis, TAF is better. So these are two conditions wherein you would choose TAF. In pregnancy, you don't want to choose entecavir. You would predominantly go towards TAF or TDF. It's up to you. Thank you. So yeah, I think we did discuss this sometime back in one of our hepatology meets. The important point is that if you do that, most of the people don't understand the importance of these drugs. They'll take the drug and they'll probably stop it in between, and the compliance becomes an issue, and that's where you get viral resistance. So I think we need to have some cutoffs which we need to follow. I do agree that with massive epidemic going on, when you have one disease which can cause progressive liver damage, would you want to let a patient have some DNA positivity which can add on? Because there's no data that Hep B DNA positivity along with MASLD, would the outcome be different? We don't have any data at this point in time, but I think that is what the next future is going to be, that these drugs are so cheap. And I think probably in the next 10 years, we are going to go to that every patient has to be treated. So the first thing would be on APRI score. I didn't touch base too much on it because I'm going to talk about that on my next slide, in my next talk. APRI score is a non-invasive measurement to check for fibrosis. So if the APRI score is completely normal, less than 1.3, that indicates that probably your patient has no significant fibrosis. That is very easy because it is just age, AST, ALT, and platelet, very, very simply available, and you can just put it in your calculator, you'll get the answer for that. But if we have the a technology available, getting a fibro scan done and having an LSM less than 8 will put you at a very safe side that your patient doesn't have any underlying severe fibrosis going on. Because though ALT values can be normal, there can still be fibrosis progressing in these patients, whether it is because of fatty liver or Hep B. Fibrosis can progress even with a normal ALT.
So drug resistance to antivirals, is there any mechanism to detect? How do you proceed when you find that halfway through you find a resistance?
Yeah.
When to switch?
So I think in that we are going to be very lucky. Probably in the last decade, I have not even seen a single patient. Neither during my tenure at PG, I could find any patient who had developed a resistance to any of these drugs. The genetic barrier of resistance is very, very high for these drugs. There has been some reports with entecavir. So again, these guidelines lay out, ASLD also lays out a guideline on how to handle that. So they say that if you have resistance with entecavir, please move on to TAF or TDF and it should work. And if you have any resistance with TAF or TDF, please move on to entecavir. And they just wind it up with one paragraph, that's it. Yeah, so there is some data on that. So we have a lot of scenarios wherein the anti-HBs doesn't become positive. But what my suggestion would be at least to wait for 1 year after the SAG loss. And if in 1 year the anti-HBs is not becoming positive, then probably give a complete 3-dose vaccination schedule. Yeah. So the guidelines recommend once in 6 months, wherein you would want to check your an LFT and also a viral load. And probably you can do a non-invasive assessment of fibrosis every 1 year. Yeah, so India, INASL also has its own guidelines. So at this point of time, even they are not very aggressively recommending it for more than upper limit of normal ALT. Even they're asking us to wait for 2 times upper limit of normal. But this is going to change for certain because there is good data from India coming that the ALT values are really not 40, which is normal. It's actually much lower than that. So probably it will change. Just like for Hep C, we had a good scheme wherein all these SOFO, Velpa was given for free initially. SOFO and LEDI was given for free. Maybe that can also happen with Hep B. So Hep B and Hep C co-infection. So again, a good point. So whether your patient is having a Hep B HCV or a Hep B HIV, every patient needs to be treated, and you cannot pull off the drug in such patients, especially with HIV. Even if all the criteria are met, if the patient has HIV co-infection, never pull off the drug for Hep B. Thank you.
Thank you, sir. I request the moderators to stay for the next talk. Pregnancy and the liver, two worlds entwined in the rhythm of creation. As life begins to grow, the liver bears the quiet weight of transformation, enzymes shifting, balance tested by the tides of hormones and hope. Sometimes this harmony falters, cholestasis itches, enzymes rise. A song of nurture becomes a whisper of warning. Yet, even in fragility, there is resilience, a reminder that medicine, like motherhood, is an act of vigilance and love. For within every case of liver disease in pregnancy beats the courage of 2 hearts and the strength of one. Without any further ado, I invite on stage Dr. Mallikarjun Sakpal, consultant hepatobiliary and transplant physician, Aster Hospital, Bangalore, for a talk on pregnancy and liver disease.
Pregnancy and liver disease. And thank you, Pradeep and his team for giving this opportunity. So I'm going to talk on pregnancy and liver disease. It's a huge topic and very difficult to cover in 15 minutes. I'll try to be brief as much as possible and try to finish in 15 minutes. So you know that there are the prevalence of the liver disease are increasing. So as in pregnant women, there is increase in prevalence of these liver diseases to the tune of around 3%. And there are conditions which there are specific disease which happen during pregnancy, and as well as you can see the pregnant patient who having underlying liver disease also becoming pregnant and developing various complications. If you look at there are certain physiological changes do happen during pregnancy. So I will not go into the depth. There will be slight changes in the alkaline phosphatase do happen. It will go up in certain patients. Alpha fetoprotein may rise. Bilirubin, either it will remain normal or slightly decrease. However, AST-ALT will not change, and any change in this you should always consider abnormal. When you examine them, some of the changes related to liver disease can be seen in this group of pregnant ladies, like palmar erythema, spider angioma, or hyperdynamic circulation. You should not confuse that with the liver disease. So we classify liver diseases in pregnancy as those are specific happens when the lady becomes pregnant. So these are the 4 diseases which you commonly encounter. That is like hyperemesis gravidarum, ICP, then hypertension related, everyone, and sometimes liver rupture, and one specific is acute fatty liver of pregnancy, which is a dreaded complications. And the patient who have underlying already liver disease, they become pregnant, various viral diseases, and even CLD patient can become pregnant. So that starts with hyperemesis gravidarum. You can commonly encounter. This is a severe form of nausea and vomiting in pregnancy, leads to dehydration, electrolyte imbalance, and some patient will lose weight, and affects around 0.3 to 2% of pregnancies. So causes not clearly known, and one of the etiology has been implicated is HCG, and more common in patients with multiple pregnancies or molar pregnancies, or if they have past history. So you can up to 50% of patients, some LFT abnormalities even detect. When they have severe, can develop also organ dysfunction. Treatment is very simple, just rehydrate in them, and even just like thiamine and B6 supplementation will help in majority patient. Some of the ladies, the pregnant ladies, may require antiemetics, and prognosis is usually good. By second trimester it will disappear, and there is no long-term consequence on the liver. This is a very interesting, which we commonly encounter and difficult to handle in some cases, that is called ICP. So usually it is characterized by pruritus, in the raised bile acids, and jaundice. Again, the etiology is not so clear. Some implicate because of the hormones and including genetic and environmental factors. Presentation, usually that start with only pruritus, and usually
There is a car blocking a lot of the other cars. KA20MA0259. Please move it immediately. I repeat, KA20MA0259.
So usually they present with symptoms related to like cholestatic jaundice, like pruritus, and more so usually it start around the end of the second or usually third trimester. So how to diagnose this patient? Apart from LFT, you can do a serum bile acids. If bile acids are more than 19, that is sufficient to diagnose that patient has ICP. So apart from the LFT, what other things to be focused when the lady comes with these pruritus? Because they have a high risk of developing diabetes, always do OGTT. Second is, and they can urine analysis, because pre-eclampsia is also accompanying in them, and because it is a cholestatic jaundice, there is abnormalities of you can get prolonged INR and bleeding manifestation. Do PT-INR and get one ultrasound to rule out extrahepatic. Most commonly what you see is CBD stones. So you need to rule out those things, and fetal monitoring as well required, and liver biopsy is not recommended for the diagnosis. And if there is atypical presentation, please rule out viral and autoimmune diseases in these patients. So management, majority of 75 to 80% will respond to UDCA, and whenever required beyond UDCA, you can safely use antihistamines. And beyond that, we don't have much data, but you can use drugs like rifampicin, cholestyramine, or even sertraline. Regular monitoring when to do the delivery at what time, I will tell you in the next slide. So because the fetus is at risk of preterm or fetal distress, even stillbirth high in this group of patients. So this is a simple guidelines, what everyone needs to know it. So monitor the bile acids every 2 weekly or 4 weekly, because depend upon the need. If it is less than 40, you just follow up with them, and they have priority, simple use UDCA. When the bile acid levels increases beyond 40, so we need to be careful and clearly monitoring LFT along with PT-INR. And once they achieve where you can salvage the fetus beyond 30 to 34 weeks, please go for the delivery. If when the very severe, that is called bile acid more than 100, you have to go for as early as fetal delivery once you are able to achieve and maintain the neonate in the post-delivery phase. So very severe is more than 100. Do not wait for the long time. Induce as early as possible once you are able to manage the baby after the delivery. Other disorders, preeclampsia and HELP syndromes. I'm not going to much talk on this. This is a multi-system disorder characterized by hypertension and proteinuria, seen in around 3 to 5% of all pregnancies. Usually presents with pain, headache, visual disturbance, sometimes hyperreflexia. And when there is severe preeclampsia, it can leads to seizure, what you call eclampsia, and can leads to a end organ damage like liver, kidneys, and even brain. So HELP is nothing but is another severe form of this eclampsia. So where there will be hemolysis, elevated liver enzymes, along with thrombocytopenia, can occur around 10 to 20% of women with preeclampsia. Symptoms, again, pain, abdomen, nausea, vomiting, headache. When severe, there will be a bleeding, and jaundice in severe cases can also develop. How you will diagnose? Based on the clinical plus raised abnormal enzymes like EST, ALT, low platelet, and there is a signs of hemolysis on the peripheral smear, or you can do investigation. So the management, again, that's as early as possible delivery when you are able to manage. And again, medical management, you all know better than me, use safer antihypertensive drugs like labetalol, nifedipine, or magnesium sulfate, or use corticosteroid if there is worsening eclampsia is happening, and for fetal lung maturity, and go for early delivery, because there is a high risk of preterm, low birth, even sometimes stillbirths are happening. Other rare entity I have not come across, if anybody has seen, there is some incidences of liver rupture, hematoma is developing. Again, happen in more patients with preeclampsia, eclampsia, or HELP syndrome, and or in AFLP. And usually mortality is very high, 50%, and clinical presentation will be pain, abdomen, followed by fevers, or sometimes hypotension, shock, usually they will end up in ICUs. Again, you can see on the LFT abnormalities, the liver enzymes will be in the thousands. So diagnosis is the CT or MRI, whichever possible, and based on the symptoms and presentation, best is conservative, because you know that fetus is there, if possible embolize and stabilize and go for the delivery. If not, sometimes we need to surgically pack the liver, or some people end up, if they're presenting with already liver failure, so priority is the save the mother and go for the liver transplantation if possible. Other serious entity which have come across and need to be careful is acute fatty liver of pregnancy. So this affects in 1 in 20,000 pregnancy. Basically, there is a link to defect in the mitochondrial fatty acid oxidation defect in the neonate or the fetus. So that is called LCA deficiency in the fetus, which can transfer toxic fatty acids to mother. It happens more common in patients with teen pregnancy or nulliparity. So symptoms usually happens in third trimester, or even during sometime you can these develop after the immediate means 1 or 2 days during after the delivery also. There is symptoms are not so specific in this disease, usually nausea, vomiting, pain. Whenever there is a severe, they can have symptoms related to liver failure like jaundice, encephalopathy, and mild ascites. Diagnosis, again, there more than 6 these parameters are there, you can diagnose what is called 7C criteria, but these are, most of them are sensitive but not specific. You can see majority of the symptoms will be there in any pregnant lady, and it's very difficult to diagnose. So it needs to be very careful follow-up with this whenever you are suspecting these patients. So again, the management is again immediate delivery as early as possible when you diagnosis, because there is high mortality in this group of the pregnant ladies. Because of now advanced management, ICU care, the mortality initially it was considered to be 80 to 90%. Now the mortality is dropped to around 10 or less than 10%, where it's because we have good ICU care management of liver failure. So now coming to the other diseases which can develop, which can we see, and the patient is having already ongoing liver disease and they become pregnant. One of the common is young, like autoimmune diseases is common in young girls, and they get married and they become pregnant. So they can have underlying cirrhosis. So what will be the impact of this cirrhosis on the pregnancy? So you can see there will be overall reduced fertility, but although when they become pregnant, there is an increased risk of complications like spontaneous abortions or increased overall there is a maternal mortality because underlying cirrhosis. One of the dreaded complication which can happen in this patient is varicose bleed, seen up to the 25% of patients with cirrhotic pregnancies. And most often this seen during the second trimester or during the labor and carries very high mortality around 50%. So how to prevent? As you know that if you are following the patients the cirrhotic and they are planning for pregnancy, do regular screening for varices, and you have to do banding and so ablate the varices as early as possible. If they become with the pregnancy already and safe to do the pregnancy is usually second trimester. If they are high risk, please you can carry on with the banding, or you can start a secondary prophylaxis with beta blocker in this. Mode of delivery usually has vaginal delivery and not much difference, but vaginal delivery is better, but avoid excessive straining during labor. And assisted delivery will help in because it avoids the too much strain during the delivery. Cesarean section, what you need to, sometime abdominal wall varices will be there, that you need to be careful about during the cesarean. Otherwise, outcome is not much difference. Hepatitis B, already we spoke, Sandeep has told about the monitoring in this group of patients. So what is important is when they become second to third trimester, underlying hepatitis B is there. Please monitor DNA levels. When they cross more than 10 raised to 5, you can start on the tenofovir to avoid the risk to the fetus. And subsequently after the delivery, there is already you have to immunize the baby, and that protocol is there with everyone. So what is this? Once you start, at least continue the therapy for 3 months after the delivery, and you can withdraw the therapy after that. There is no contraindication for breast feeding during the these therapy or whenever patient has hepatitis B. Hepatitis C, just you do a routine screening, however, we don't treat with the available drugs because you know that is a slow disease and impact on the liver is very slow. That's why we just monitor them. We can treat after the delivery because newer drugs are available, safely can be used. So no need to worry. So you have to treat them after the delivery. And there is no contraindication for, again, breastfeeding. Autoimmune hepatitis is quite little bit is difficult to manage because there is overall when you come the autoimmune lady become pregnant, there is a risk to a baby as well as mother, but it is comparable to other autoimmune disorders. There is a risk. What happens with the flare of the autoimmune hepatitis is common, more so during the after the delivery. So risk is varies between 20 to 50%. So less during the pregnancy, but during the perinatal period, there is a high risk of flare. So how to manage? The safe drugs we have, azathioprine, should be continued during pregnancy also, or you can use after the delivery also. And whenever there is a flare happen, you can use steroids depending upon the requirement. As I told, there is a high risk of decompensation, liver failure, and once they come with liver failure, you have to manage as per the ALF protocols. Some few words in liver transplant related and pregnancy. You know that we are doing transplant even in the children's young girls with acute liver failure. So after the transplant also they can become pregnancy. But what is important is they are at incidence, increased risk of preeclampsia, infections, diabetes, hypertension, and some of they are at risk of, because there is a changes in the drug distribution, there is a chance of liver rejection is also there. You have to keep in mind in those things. So what are the safe immunosuppression we can continue during when the transplant lady becomes pregnant is you can use azathioprine, tacrolimus, and cyclosporin. Avoid that keep in mind. And so mode of delivery also has no impact, and the outcomes are usually better. So in the peripartum period also you can continue the same immunosuppression, and there is no contraindication for the continuation of the these immunosuppression. Some of the diseases you can during pregnancy, like acute viral hepatitis, A, E, and some even you can do HSV. I'm not going to the much details. Earlier, what I would like to highlight is earlier you used to see a lot of hepatitis E related ALF during pregnancy. I think we have not come across this recent 5 years. I have not seen any case, but some of sporadic you can see. But however, we don't have any particular management still for the hepatitis E management. You have to manage like acute liver failure in any other situation. HSV also sometimes these pregnant lady do develop, and we have acyclovir safely can be used in this group. Other group of diseases which we can encounter in the pregnancy is like Budd-Chiari syndrome, because they are at risk of they are prothrombotic. Usually pregnancy is a prothrombotic condition. They may develop de novo, means new onset Budd-Chiari syndrome, or if they have underlying Budd-Chiari, there is a also worsening is also possible. You have to keep monitoring them. So overall, there is outcomes are much better nowadays because you availability of the drugs, anticoagulation we can use, regularly monitoring, and we have various intervention modalities where we can manage them safely and we can save these mothers. This is some last slides. Some of the drugs which are safely used in liver disease with pregnancy. You get this available online. I'm not going into the details. In case of like ICP, which a few highlights you can use safely: UDCA, rifampicin, and cholesterol safely used. And other things is in whenever have a variceal bleed, propranolol can be safely used, but don't use terlipressin. Instead of that, if the patient lady comes with upper GI bleed, use octreotide or somatostatin. Don't use terlipressin. And in the antivirals, if you are using, so best is tenofovir. We have a good data. Other drugs should not be used. And in immunosuppressions, avoid MMF. You can use azathioprine. Thank you.
Thank you, doctor. That was a wonderful discussion on pregnancy with the liver diseases. Any questions from the audience? Excuse me.
Yeah, fatty liver, acute fatty liver on pregnancy. What is the outcome in your
No,
clinical
that's again
practice?
the the diagnosis is very crucial during this, and it is a very rapidly progressive, and usually they mimic they present with like acute liver failure, and like ICU facilities are so well known, and managing this ALF is probably easier nowadays. Earlier mortality used to be more than 50 to 80%. Now it is come down to less than 10%, and wherever possible you have to shift them to transplant centers. We keep them preparing for the transplant and go for the delivery. And if sometimes we can the delivery happens and some very few of them still progress to liver failure, and we can go for the transplant.
What is the fetal outcome with respect to?
No,
patient
again
has-
it is, yeah. So how when you identify liver failure, stillbirth is high there in this group of patients.
Thank you. Any other questions?
Excuse me, sir. We have a pregnant lady of 5 months of pregnant woman with pruritus, significant pruritus. The ultrasound wise, we ruled out the liver pathology like any obstructing features. Those things has been taken care. But persisting pruritus, only thing strong history was jaundice in the last pregnancy. We have tried all the antihistamines and ursodeoxycholic, those also tried. But still significant pruritus. Is there any other medication can we try?
Yeah. So as I told, there's some other drugs we can use, but there is no much data. But rifampicin we used safely, cholestyramine, and you can even some SSRI like sertraline also can be used. The 3 drugs you can use further.
Thank you, sir. I request the moderators to stay for one last talk. The liver, a quietest worker, the keeper of balance and excess. But in an age of abundance, it bears the weight of our choices, of hurried meals, of sleepless nights, and silent stress. This is the story of fatty liver, a gentle warning of a tired liver asking to be saved. Lead hepatologist, Manipal Hospital, Old Airport Road, Bangalore, for a deep dive into the evaluation and treatment of fatty liver disease.
close one. Just put a wrong one. Just argue it. Open it. Good afternoon once again. So the next talk given to me is on fatty liver disease. Again, a huge spectrum in itself and extremely difficult to cover in 15 minutes, but I'll try to summarize it, and at several stages, I'll try to compress the slide in probably one important takeaway point. So we know that I keep changing these slides regularly. So earlier it was around 35%. Now I've made it 38% based on the latest data from the latest article. So now the global prevalence of MASLD is increasing rapidly. So now you have 38% of incidence. The lean MASLD also is increasing. So in India, reports are of as high as 25%. So lean MASLD is where you have BMI of less than 23 and still the patient has fatty liver disease. The risk of the steatohepatitis part of MASLD increases with male sex, age more than 45 years, and presence of multiple subfractions of the metabolic dysfunction parameters, which we will be talking about. So earlier, we know that the definition of NAFLD was that you shouldn't be consuming significant alcohol consumption. If you are consuming significant, then you can't call it as NAFLD. How can that be possible? And that is where a lot of problems started coming, that a person is obese, he has metabolic dysfunction parameters, but the person also consumes alcohol. So where would you place this patient? In ALD or in non-alcoholic fatty liver disease? So that is where the importance of the newer definition came, and we had to rule out a lot of other causes before calling it as NAFLD. Just to typify that, I'll give two quick examples to understand a routine patient. So this was a real-world patient of a female who had a breast CA, underwent mastectomy, and subsequently was placed on tamoxifen. And when she came back, she had elevated liver enzymes. She also was a diabetic and had a visceral obesity with an increased waist circumference, BCAA negative. So what do we call it? Now you have a drug which can cause fatty liver, but the patient also has metabolic dysfunction. So that becomes a confusion again. So NAFLD or drug-induced. That's the reason why the new definition is needed. Second guy, a middle-aged man, again, BMI was elevated, metabolic dysfunction, diabetes, hypertension present, is consuming 90 ml of whiskey, so around 30 grams of alcohol per day, elevated liver enzymes. So what do we call it now? We'll call it ALD or we call it as NAFLD. So this is where the problem came, and that metabolic dysfunction associated steatotic liver disease, wherein typically the first question you have to ask yourself is, out of the 5 metabolic dysfunction parameters, does the patient at least have one, which we're going to talk about? But if the answer to that is yes, and if there's no other cause of steatosis, only then you call it as MASLD. If there's any other cause, then you label it as, for example, if it's alcohol, you label it something called as MET-ALD, that is metabolic dysfunction, and ALD. And if you have none, and if you have any other cause of steatosis, you typically label it as drug-induced steatotic liver disease. And this is what we were talking about, wherein you're talking about a BMI exceeding 23 is something significant, but most important is waist circumference. So for an Indian perspective, the male waist circumference cutoff is 90, and for women, it is 80. It is unlike the Western counterparts. Impaired fasting glucose or diabetes, hypertension, that is blood pressure more than 130/85, triglyceride more than 150, HDL, which is either less than 50 in females or less than 40 in men. So even one of these 5 parameters is present in your patient, that means he has the cardiometabolic risk factors as positive. So this is how you have a terminology now. So if you have no other reason, you typically call it as MASLD. And then you have this category called MET ALD, wherein based on how much the person is consuming, if the person is consuming, say, 30 grams per day, like the second patient we spoke about, you're going to be call it as MASLD predominant MET ALD. So the definition is MET ALD, but he's a MASLD predominant MET ALD because he's consuming only 30 grams. Now imagine if the same patient would have been consuming 60 grams per day, you call it ALD predominant MET ALD. That's how you give a terminology. The important point is that MASLD is not one disease. It always comes in clusters, and most often you have to find out the other clusters associated. The commonest thing which I think is missed out is PCOD. Tons of females have it. Many of them actually have fatty liver also, and obstructive sleep apnea. People complain of early morning tiredness. They're not able to exercise. They binge eat, and they are not tested for obstructive sleep apnea. So this is another very common entity. So spectrum of MASLD, we have plain steatosis, we have MASH, which is basically a histological diagnosis. So if your pathologist tells you that if you have any one of these three, that is ballooning of hepatocytes, or the pink deposits called Mallory hyaline, or any fibrosis. Now this point you have to remember, fibrosis. Every patient we cannot do a biopsy. That is where if your patient has fibrosis on non-invasive testing, only NASH can cause fibrosis. That's how indirectly, without doing a biopsy, you can figure out that whether your patient of MASLD has underlying MASH or not. If fibrosis is there, 100% this guy has gone into MASH. MASH-related cirrhosis, MASH-related HCC. Not boring you with too much of pathophysiology, but tons of new information has come into this field. Basically, your good adipocytes turn bad, and because of that, there's a lot of free fatty acid influx into the liver cells. Mainly, we are talking about lysophosphatidic acid and diacylglycerol. Now, what happens is that these FFAs trigger a very interesting pathophysiology called as pyroptosis. All of you would have heard about apoptosis, but there's something called pyroptosis, which is an inflammatory type of cell death. Again, probably how it works, maybe over tea we can discuss, but I think this is out of the scope for current discussion. Whenever you have these syndromes going on, you have inflammation happening in the liver, and at this point, there's a lot of genetic predisposition. You have ApoC3, you have PNPLA3 gene mutations in Indian subcontinent, which can lead to fatty liver. So many people have fatty liver. Why only few patients are going into MASH? So that means there's something connected to their genetic or gut microbiome, which is putting the second hit and converting the plain MASL into MSH. An important point is that normal ALT, it's very, very common for people to see fatty liver, a report of ALT normal, that means I am safe. That is completely wrong now. So if you have fatty liver, and even if you have normal ALT, even no designated cutoffs, because there's a lot of confusion, as I told in my previous session. Usually anything more than 25 for females, more than 35 for men is right now considered significant. An important thing is when you find fatty liver, please ask for the routine tests, including hemogram, LFTs, viral markers, the metabolic profiling, including the lipid profile, TSH, A1Cs, the imaging, and fibroscan if it's available. And this is where we were talking about that. Imagine that in a setup, you don't have a fibroscan or a machine where you're not able to rely on. There you can simply use FIB4 scoring, that is age, AST, ALT, platelet. If the value, as I spoke about in the last talk, is less than 1.3, be convinced that there is nothing going wrong. You can call the patient every 2 years, ask them to just go on with good lifestyle, no medicines are needed. If the value is more than 2.6, significant that maybe the patient has underlying significant fibrosis, and this patient has to be referred out. Now, if it is between 1.3 to 2.6, that is where you have to send the patient for another non-invasive testing, which is a fibroscan. And if the value is more than a cutoff of 8, that means maybe there is a metavir F2 or more than F2 fibrosis. And if you have fibrosis, ALT normal, still the patient has underlying histological MASH. That is the point. So fibroscan, Dr. Pradeep specially requested me to talk a little on this. You're seeing 2 points over here. One is the CAP score, one is the LSM over here. LSM means liver stiffness measurement. So CAP is basically the amount of steatosis. 230 to 260 is S1 steatosis, 260 to 290 is S2, and anything more than 290 would be S3 or grade 3 fatty liver. And a value anything less than 8, you're really not too worried. There is no significant fibrosis going on. But if the value is more than 8, there might be F2 fibrosis going on in your patient. And this is how you grade it. The problem with FibroScan is there is tons of discordance, tons and tons of discordance, which I'm going to talk on. And that is the reason you have a further better technology, which has now come up called MR elastography, which actually has a much higher aurochs in picking up those patients of F2, F3 fibrosis, which FibroScan probably cannot. There was one study which actually showed us 43% discordance between FibroScan and MR elastography. That is the problem. But the important point from this slide I wanted to communicate was the BMI. So if your patient's BMI is more than 30, that is where you have to suspect that probably the FibroScan is going to be wrong. And it might falsely tell you a high LSM, and that is where you probably need to depend on some other non-invasive modality. So one of the patient came to me with LSM 11.8. Now, obviously, we would categorize him in F2, F3 fibrosis. Look at that. MR elastography, same day, absolutely no fibrosis. So the importance of discordance, just that we have drugs now doesn't mean we are going to start drugs. Lean mass LD, BMI less than 23, you have that. Very good study from PGI, a very recent data basically, suggesting that the most important phenotype in lean mass LD, that is BMI less than 23, is central obesity. So the waist circumference, if it is more than 90 for men and more than 80 for women, that's a single most important predictor that this patient is going to land up with fibrosis. Adjusting for all the confounding metabolic dysfunction parameters, central obesity is the most important in lean fatty liver disease. Switching gears to treatment. So the most important is going to be lifestyle. We know that. And again, now we also know that you're not going to only talk about fat restriction. You're only going to talk about calorie restriction. So whether, because it's very common, a patient comes and says that I don't have a non-vegetarian diet. I'm only a vegetarian. I don't eat outside food. How did I get fatty liver? That is because of the rice consumption probably. So it is the carbohydrate load which you're giving to your body along with your fat load. So basically the calorie restriction is the most important restriction you're going to guide for your patients. So calorie deficit diet is what you're going to talk, and at least 45 minutes per day of exercise, at least 5 to 6 days a week is what all the guidelines actually recommend. And what is the weight loss you're going to ask for your patient? So if you are going to attain a 10% weight loss from baseline, you're going to attain fibrosis regression. So always try to ask them to get a 10% weight loss. But I think the most important goal point is going to be maintain that weight. People lose that and immediately they gain back, and that is not going to make any difference for them. So simple recommendation, whatever calories they're consuming, say they're consuming 2,500, you have to restrict that by 500, so make it 2,000, and moderate intensity exercise. Very, very simple. I see extremely strict diets being given to patients and they can't sustain that. You just follow that for a period of 1 year and then people screw up again. So there's no point. You have to actually give them something which we can carry on for a longer period of time. We all had vitamin E and pioglitazone, just showing one landmark trial, which is the PIVENS data, which showed that both vitamin E and pioglitazone did good job in MASH resolution. That is, the ballooning improved, the inflammation came down, but fibrosis did not improve. So the most important parameter, which is fibrosis, did not improve in the PIVENS trial. Again, another question is, what if the patient already developed cirrhosis? Is there a drug which we can give? So there is some data which was given in compensated cirrhotics. Vitamin E in compensated cirrhotics reduced their decompensation rate and improved their transplant. We all know that pioglitazone has come into a lot of bad light because of the weight gain it causes, edema, and some osteoporosis it causes. There is some risk of increased bladder cancer, but it was very, very minor data. Lot of drugs have come up in the spectrum of MASH. Again, due to lack of time, I'll not go too much into detail, and I'll talk about the important drugs which are available. This one, which is very, very commonly available, which is the PPAR, gamma and alpha agonist, which is the saroglitazar. And that is now freely available in India because all the data showed that it is working on all the pathways, not only as an anti-fibrotic, but also for the MASH resolution pathway. And from India, we got the Evidences 2 and Evidences 3 trial, which was a very good database showing that saroglitazar did wonders in causing MASH resolution. So in the initial database for saroglitazar, 4 mg of saroglitazar actually showed that not only the liver fat content was coming down, adiponectin levels were getting better, HOMA-IR was reducing, triglyceride was reducing. This was subsequent another study which actually showed that in patients who had fatty liver disease, just look at the values. The triglyceride at baseline was 359, coming down to 130. So the triglyceride reduction, and look at the values of LSM. So in the beginning, it was around 9 kPa, coming down to 6 kPa over a period of only 12 weeks of therapy. This database showing those patients who have cirrhosis, can you give saroglitazar? So there is no much data, but this group actually included pains of cirrhosis. They did not find any side effect. Doesn't mean F4 can reverse to F3. with saroglitazar. It just means that you can safely use it in F4, and that's what this data shows. This is probably going to be the torchbearer for the next decade, the beautiful drugs, which is the GLP-1 RAs, which is doing wonders in MASH management. We know that GLP-RAs don't have an intrahepatic mechanism of action. In our pathophysiology side, we understood about the free fatty acid flux into the liver. And that is what reduces with the help of the GLP-RAs, whether we talk about SEMA or whether we talk about tirzepatide. So basically, it reduces your gastric emptying and basically was a satiety, lot of hormonal changes with which your intake goes down and your body weight goes down. This was the initial database from the LEAN trial, which is on liraglutide, showing significant 39% MASH resolution, but again, no improvement in fibrosis from the LEAN trial. This was the most important data which came up, the ESSENCE study, based on which the FDA approved this drug, which is semaglutide. And in this drug, this is how semaglutide was given. Started off at only 0.25 mg weekly once, slowly being escalated to 2.4 mg. So not in a hurry, but every 2 to 4 weeks, they were getting escalated. And what did it show? 62.9% MASH resolution and a 36.8% fibrosis reduction in the F2, F3 fibrosis stage. So again, doing wonders. We all know about the problem with GLP-RAs, that it causes nausea, vomiting, GI side effects. Most important point is going to be start at a low dose, go slow, and then try to educate your patient that only when they're hungry, they have to take small quantities. Semaglutide used in cirrhosis, this was a study from Rohit Lumba's group. Sadly, in F4 fibrosis is not showing benefit. That means F2, F3 fibrosis, you have the window open. The moment it goes to F4 fibrosis or cirrhosis, SEMA stops working in this group. Tirzepatide, again, a beautiful drug. This is a co-agonist of not only GLP, but also GIP. Some database show that it has a much more waist circumference and weight loss property when compared to semaglutide. And this also showed a very good resolution of steatohepatitis and also fibrosis reduction. A lot of new drugs are coming into the pipeline, like survodutide and retatrutide. Again, not going into too much of details, but just telling that this is probably going to be the next frontline because of good improvement, not only in fatty liver, but the commonest cause of death in fatty liver is cardiac. And it causes 20% major adverse cardiovascular event reduction with either tirzepatide or semaglutide. Dapagliflozin, we all know the SGLT2 inhibitors. One very recent data which actually showed that when you're giving dapagliflozin 10 mg, it is causing, again, significant number of MASH resolution and also fibrosis reduction. All these drugs can be even given in non-diabetic individuals. Resmetirom, the other drug which came up into the pipeline, FDA approved again. It's a thyroid hormone beta agonist, again available now in India. The alpha is where the side effects would come, that is your heart and your skeletal muscles. Thyroid beta receptors are only in the liver. NAFLD is usually related as a hepatic hypothyroidism. So you want to stimulate that, and that causes a defattening in the liver and has a very, very good trial which shows that a good resolution of around 25.9% of MASH resolution, and also significant number of patients had fibrosis reduction. You can see the dosage. Usually you would want to give it in patients less than 100 kg, 80 mg, and more than 100 kg, you would want to go to 100 mg once daily. Side effects, the only one side effect to remember mainly is some diarrhea, which can happen with resmetirom. So usually start at a low. So you have resmetirom with an intrahepatic mechanism, and you have GLP-1, which is an extrahepatic. So probably future is going to be that. Just a last slide on bariatric. It is still not yet out because does wonders. Again, with GLP-1 RAs now coming up, which is the newer one, which is retatrutide, causing 25% of weight loss. Where is bariatric going to stand? We'll only get to know over the next decade. But yes, bariatric does wonders. You can see fibrosis reduction is in as much as 66% of patients with a good bariatric procedure. Coming back to our case 1, case 2, the first case, if you remember, patient had metabolic dysfunction from because she was taking tamoxifen and also had diabetes. So what do you call this particular patient? So again, if you see, the patient did have cardiometabolic risk factors and also had other causes of steatosis. So this is a combined phenotype wherein you label it as MASLD and tamoxifen related steatotic liver disease. Case 2, this is again a gentleman with metabolic dysfunction consuming 30 grams per day of alcohol. So what do you call it? Again here, if you again go back to our definition, he was here. So this guy is MASLD predominant met ALD, and this is how you would terminology your patients. Thank you.
Thank you, doctor.
So it was a very nice talk. So like you gave an example, a patient came with asymptomatic OTPT elevation with a significant family history of cirrhosis causing death. Now OTBT was elevated on profile, GP210 was positive. He was also matching in some of the metabolic parameters. So in such a scenario, will you take it as MASH and treat MASH with linagliptin? With or take it as other associated thing and treat? How to decide on this?
So I think that's a very interesting question. The first point you told, the autoantibody was GP210.
Yes.
GP210 has a high sensitivity for PBC.
Yes.
Usually PBC only in the very early stages has a hepatitic picture. You can have OTPT going up, not GGT in the early phase even of PBC. So at this is a typical patient wherein you should ideally get a biopsy done to see what the inflammation is being caused by. If it's a completely different, it's a biliary origin, or it is because of a Mallory hyaline or a ballooning of hepatocytes because of steatosis. And based on that, this is typical case wherein the patient should get a biopsy.
So the thing is, the patient is not visible. Like I took an opinion, he was started on Linvas 4 mg,
Yeah.
and the response was good. So
I'll again add another point over there. The problem here is that Saroclitazar has come up with a very good database for PBC as well. Even in PBC, you're going to have a response from Saroclitazar. So it's very difficult to tell whether the Saroclitazar is benefiting your fatty liver component or PBC component. The data is not completely out yet, but there's initial database for that.
Excuse me, sir. You said ALT is not a direct indicator for the progression of the fatty liver. But the problem is, if you get an ultrasound keep for a fatty liver progression, because that is an observer dependent, the fatty liver 1, 2, 3, 4, it's difficult. So is there any other option so we can watch for the progress of the fatty liver?
So we are not talking here about the grade of fatty liver. That is not the point. Grade 1 can become grade 2. You can have a patient of grade 3 fatty liver with no MASH. You can have a grade 1 fatty liver with MASH. The point is not serially looking at the MASLD based on the grade of fatty liver, but the metabolic dysfunction parameters. So if your patient out of 5 parameters has the metabolic dysfunction parameters present and the APRI score is increasing, that would be a much more important parameter that fibrosis is progressing rather than just a sole looking at the ALT value.
Thank you, sir.
clinical examination, which is very important, and to be a good clinician. So selected a few symptoms from upper GI, HPB, lower GI, and few general symptoms, and also the common signs and the abdomen examination. We'll focus on this. Straight away, I will start with the dysphagia. This has been already covered by the first speaker. This is 60. I will give brief snippets also so that it makes interesting for audience. 65-year-old female with progressive dysphagia for solids and liquids with weight loss and vomiting, thin built. So obvious diagnosis here will be CA esophagus, but for surprisingly, on endoscopy, there was no mucosal lesion. It was a tight OG junction. That's the diagnosis of achalasia cardia, confirmed by manometry and even CT scan to rule out any secondary pseudoachalasia also. So this patient underwent a laparoscopic Heller's cardiomyotomy. Dysphagia is a very accurate symptom, almost in 60 to 70% of the patients when they say there is some positive finding in them. And to surprise you, it will be surprising to know that the most difficult substance to swallow is often the water actually. So we also should look for the neurological in case there is a negative endoscopy or any diagnostic tests. Other causes for dysphagia are the post-cricoid web, very common in patients who have anemia. Stricture esophagus, when there is a long-standing reflux, they develop the web or a stricture which leads to dysphagia. And the very common cause in northern part of Karnataka at least is CA esophagus. The various symptoms which we need to evaluate, this has been already covered, so I'll skip this. The next symptom is the vomiting. This is a 25-year-old male patient, came with the right lumbar pain and a bilious vomiting with a very soft abdomen. Ultrasound showed actually cholelithiasis and he was referred for laparoscopic cholecystectomy specifically. But something was missed. I did an endoscopy which showed that there was a lot of bile in the stomach and the D1, D2 was dilated. So I was thinking of a SMA syndrome in this patient, got a CT scan done, but surprisingly it was actually a intestinal malrotation. So this patient underwent a laparoscopic LAD procedure with cholecystectomy. So symptom, obviously what the patient comes, just because somebody has referred to you for something, we also have to look for the symptoms which whether they correlate to the diagnosis or not. This is the second patient who is a 18-year-old female with acute onset of bilious vomiting, vomits after taking food immediately. There is no other complaints, very thin built, abdomen was soft. So in patient will require a duodenojejinostomy. This was another patient, 54-year-old, who was abusing steroids for a very long time, more than 5 to 6 years. So he had developed Addison's disease and he had stopped this on his own about 6 months back. Then he started developing a vomiting. So clinical history is very important. Another patient with a endoscopy. This is a very young fellow, but he had a CA stomach, diagnosed on endoscopy, required a distal gastrectomy. This is a 80-year-old female who had kept this treasure hidden from her relatives also, even children also. She had a long-standing intestinal obstruction. So this required again a laparotomy and mesh plasty. So vomiting, what is the color of the vomiters, whether it is watery, food, bilious, blood, or feculent, and associated symptoms of abdomen pain or a weight loss. Coming to the next symptom is the abdomen pain. Most often, where exactly? The first question should be, what is the site of the pain? In patients with upper GI problem, usually it will be the epigastric. In the mid GI, that is mid-gut issues, it will be in the periumbilical region. And the lower gut, it will be in the hypogastric region. And you need to ask the next question is the scale, how severe the pain is. And also, is there any referral pain, radiation of pain, and character of the pain, whether it is colicky, burning kind of a pain. So these will help in making a diagnosis. Some patients have aggravating factors like food aggravates in patients with gastritis or gastric ulcer or pancreatitis or even a chronic mesenteric ischemia. But the food again relieves in patients with a duodenal ulcer. Associated symptoms like vomiting or abdominal distension also very important. So if there is any change in the pattern of the symptoms, either the initial diagnosis was wrong or that complications have developed. So you need to revisit your diagnosis. Some patients develop excruciating pain, which is poorly relieved by opioids, analgesia. Then it suggests that there might be some vascular events. So you need to look for either a mesenteric ischemia or even an aneurysm. Patient who has developed a hypotension, tachycardia, definitely they have some kind of a bleeding or a sepsis. This was a patient, very young female, who had only right hypochondriac pain, nothing else. Ultrasound showed only dilated CBD. MRCP was very classical. There was a choledochal cyst. You can see the dilated CBD from the hilum up to the terminal part, and even a dilated PD also. So this patient requires a choledochal cyst excision with a hepaticojejunostomy. Another patient, this was a very elderly patient who only had pain and nothing else. Abdomen was very soft. His symptoms and signs were totally not relating. So only a CT scan suggested that there was a mesenteric ischemia, acute thrombosis in the jejunal part of the bowel. So he had to undergo a resection anastomosis. So next red flag symptom will be jaundice. This is a patient, 55-year-old male, who had only itching for 1 month, no other complaints. On examination, there was a mild deranged LFT. Ultrasound showed that there was a mildly dilated IHBRD and common hepatic duct. MRCP suggested there was a hilar cholangiocarcinoma. You might have seen this classical clinical picture of a jaundice. The color eye, whether it is the lemon yellow, it usually indicates a medical jaundice. If it is orange yellow, it could be hepatic cholestasis. In patients who have very deep jaundice, that is usually greenish yellow, it could be a obstructive jaundice. You might have also seen the various kind of people, they undergo these kind of local therapies for this. This indicates that they have already tried all different forms of treatment and now come to you. So you need to give importance to that and look for associated complaints, like whether there is a fever or pain abdomen indicates there might be cholangitis, or associated GI bleed in patients with CLD, chronic liver disease. Weight loss might indicate a malignancy. So also take history of whether they are taking any Ayurvedic medications, or history of alcohol, or history of hepatitis B, C, or there was a previous history of a cholecystectomy. The next important red flag symptom will be, I keep asking this question for almost all the patients, whether they have a loss of appetite or a loss of weight. This was one patient who had loss of appetite and weight loss for more than 1 month, but there are no other symptoms. He also had loss of interest in work and insomnia. Clinically, nothing. Endoscopy revealed erosive gastritis and H. pylori positive. Again, ultrasound and other imaging modalities were normal. Blood test, hemoglobin was normal, but his iron profile came to be very low iron ferritin levels, iron levels. This indicated that there was an iron deficiency, but without anemia. So there are stages of iron deficiency even before the patient actually develops anemia. It could be iron deficiency without anemia. So you need to aware. The vomiting, patients sometimes they just come with vomiting and loose stools. To make vomiting, diarrhea, to make that, you can ask them for the weight loss. If there is a significant weight loss, usually more than 5% or 10% in the preceding 3 to 6 months, it will be significant. Some patients complain of loss of taste. It could be because of zinc or vitamin B12 deficiency. Patients with early satiety, it could be something in the stomach. Get an endoscopy, it will rule out. So the next red flag symptom will be a GI bleed. Hematemesis, melena, hematochezia, and bleeding PR. Blood in vomitus, whether it is fresh or coffee brown, usually indicates it's an upper GI bleed. There are a lot of causes. The more common is the chronic liver disease, varices, or NSAID induced. The melena can be because of the upper GI or mid GI, where there is a black tarry stools with foul odor. This could be from the duodenum, jejunum, ileum, or up to the cecum also. So the common causes are again inflammatory bowel disease, sometimes Meckel's, or even angiodysplasia in elderly patients. Hematochezia indicates that there is a fresh blood mixed in the stools. It could be from the colon or more commonly from the rectum. It could be again inflammatory bowel disease, diverticular, or even sometimes malignancy. Bleeding per rectum, very commonly seen by the general practitioners. It could be because of the hemorrhoids or fissure in ano, blood staining the stools, or sometimes blood mixed in the stools, or after passing the motions. So whenever patient comes to with GI bleed, especially upper GI bleed, you don't have much time. So all the three, the clinical history taking, examination, and even management can go on simultaneously in your emergency room. So ask the relevant questions, and at the same time keep having a look at the monitor and get your assistant or a sister to put a line, get a hemoglobin blood group immediately. So blood loss severity, if it is less than 10%, is usually minor, but when there is more than 20% blood loss, it indicates very severe blood loss. Obscure bleed is when there is obvious bleed, but the source is not known. Most often it is from the small bowel. Occult bleed is when there is a fecal occult blood test positive, the patient has anemia, but you are not able to find any source from the routine endoscopy tests. Mortality risk is very high in patients with GI bleed. Almost 1 in 3 patients with variceal bleed might not reach the hospital section. So common clinical test, you might have to look at the CBC. If there is a low platelet count, definitely it indicates portal hypertension. So better is to get a endoscopy in these patients. There are various scoring systems which can be used in your clinical practice. The commonly used is the Rockwell score, where age, blood pressure, comorbidity, diagnosis, and evidence of bleeding. But this is post endoscopy. The next red flag symptoms will be the altered bowel habits. Altered means there is something which has changed, the frequency and the consistency. So it could be diarrhea, constipation, or alternating diarrhea with constipation or incontinence. Constipation has already been covered in detail. Diarrhea, whether it is associated with food or there is any travel history recently. Is there a frequency in the night? That indicates again something alarming. Associated with pus, mucus, or blood needs to be evaluated with the endoscopy. Urgency indicates that there is something in the rectum which needs to be looked at. Sometimes even drugs, patient is taking a long-term domperidone along with rabiprazole or pantoprazole, that itself can cause diarrhea. And patients with diabetes on metformin for a long time because of lactic acidosis can cause a diarrhea. Alternating diarrhea with constipation indicates that it could be early morning spurious diarrhea, most probably a rectal or a sigmoid growth, so need to have a sigmoidoscopy done in these patients. And if there is any previous history of pregnancy, episiotomy, and then followed by that there is an incontinence of anal, it could be a rectovaginal fistula. It's always better to keep this Bristol stool form scale in your image in your OPD so that the patient can exactly say what kind of a stools. The type 1 and 2 indicates the constipation. Type 3 to 4 is actually a normal kind of a stools. 5 to 7 is a diarrhea. The other significant symptoms will be from the proctology, usually the anal canal. These are the 4 main kinds of anal disorders very commonly seen. It's very easy to diagnose based constipation and there is a bleeding. If there is swelling and pain, it indicates there is an external thrombosis, or it could be even a perianal abscess also. But perianal abscess patients have associated fever and there will be very severe continuous pain for last 2-3 days. A painless bleeding is usually from the internal hemorrhoids, whereas a fissure will have a painful defecation associated always with constipation. A fistula in ano is when they have already had an abscess and it has ruptured to form a fistula. So that history will again clearly tell you. This was actually a patient who had undergone 3 to 4 surgeries for hemorrhoids. So, but it was actually anal melanoma. History will not be complete unless you actually go into the drug history of the patient and also the past history, whether they have undergone any surgeries, family history of any tuberculosis, cancer, and associated comorbidities. And in a young female, always ask for pregnancy. Coming to the general examination, this is the next part of the talk, that is the signs, which are the red flag signs. I always start with the oral examination for almost all the patients, and then the vitals, which are always examined by the sister before they actually enter into the OPD. But the weight, like already the previous speaker has spoken a lot about fatty liver. So weight again is important. More than BMI, it is the waist to height circumference which is more important. And this was a recent study by ICMR studying the Indian obesity, which is the cause for metabolic syndrome. They said that only roti and rice is the main cause and culprit. Coming to the general examination, you always have to examine from head to toe. Look for whether there is any hair loss, especially in patients with CLD. Look for icterus, pallor, and the skin tone, tenor, whether there is any dehydration signs, and also signs of chronic liver disease like palmar erythema, spider nevi, patients having gynecomastia or abdomen distension, testicular atrophy, so pedal edema. All these are signs which you need to have a look. Carnet sign is one when you have to differentiate between the abdomen wall pain and the intra-abdominal visceral pain. So you ask a patient to lift the leg or lift his head. If the pain persists, then it indicates that it will be from the muscles and not from the viscera. If it disappears, it is from the viscera. So the next thing is have a look at the umbilicus, whether there is any hernia or sometimes sinus. This was one patient with a nodule in the umbilicus. Sorry, this is the patient with a hernia who had a strangulated inguinal hernia. Though it looked very benign, he had to undergo a resection anastomosis with an onlay mesh plasty. The other patient, which the umbilical nodule is actually did an excision biopsy of this. It came surprisingly as a papillary carcinoma of thyroid. A PET CT revealed that patient had an ovarian malignancy associated with thyroid also. So she underwent both the surgery and she's fine now. Only the nodule from the umbilicus actually helped in detecting this early. So coming to abdomen examination, you have to have a focused look for various organs. You already know the anatomy, so focus on that. The one thing I will specifically mention is the Murphy's sign, which is very typical, very likelihood ratio is very high with the acute calculus cholecystitis. The next is the McBurney's sign. And we all are know about this Courvoisier's sign, which was a very common question in our exams and all. Any patient with painless jaundice, if there is an enlarged gallbladder, it is not because of stones. It could be a malignancy hidden. This patient actually had come with only pain, and on examination, there was a left hypochondriac mass. So on CT scan, it revealed that there was a jejunal diverticular perforation also. Another patient, this is a female patient who had undergone a hysterectomy 5 days prior, and a drain was removed. That was the port site for the morcellator. So it is a quite wide open. On examination, there was actually a bowel loop coming and sitting inside, which had already caused a ischemic because of the 2-day-old symptoms. So she again had to undergo a resection anastomosis. And I request almost all the physicians that learn to do a proctology examination in your day-to-day practice. You can at least do an inspection that will help in diagnosing majority of these perianal problems, whether it is a fistula or an abscess or a fissure, acute fissure, or even a hemorrhoids. So recently, I think now most of this is the traditional way of doing a clinical examination, where you take a history, then do an examination, then order a blood test. But now patients are having mobiles. They try to do online consultations where the clinical examination part is actually deleted. So I don't know how the days to come are, but clinical examination is an art, and we should all try to do it regularly in our day-to-day practice. Thank you. I remember my teacher saying that you always remember not to forget that whenever you are examining the patient is also examining you. So that is very important to keep in mind. So thanks. Thank you for the opportunity.
It was a very elaborative and interesting, non-boring clinical scenarios.
Thank you.
Very, very good presentation, sir. Thank you so much. It's a very informative, sir.
Thank you, sir. I would like to call upon Dr. K.R. Rao to felicitate the speaker as well as the moderators. Endoscopy is where curiosity meets courage, a journey into the body's hidden corridors. What was once beneath the skin and silence is now a landscape we can explore with light. Each scope passed through the lumen is not just a procedure, but a conversation between medicine and the human body, between disease and discovery. To elaborate further on this marvel, I call upon yet another visionary, Dr. Ravindra B.S. To call upon the moderators, Dr. Timaraj and Dr. Suresh BP. I would also like to call upon Dr. Satish PC.
Subodha team and Pradeep in particular for organizing this wonderful a rapid fire gastroenterology meeting which you are all enjoying. Let me just greetings from our hospital and my place where I work. The learning objectives are three things. What are the emergencies in gastroenterology? When do you need a gastroenterologist? And what is new in endoscopy? I think these are the three things which we'll learn. I think we all know GI bleed is the commonest emergency. I just want anybody who has not seen a GI bleed, please raise the hands. Anybody has not seen a GI bleed? I presume everybody has seen a GI bleed. And then second important thing which will immediately kill the patient is cholangitis. Somebody has got a gallstone and he has got jaundice and he has got fever. And if you go on treating like a dengue, malaria, next 48 to 72 hours, he will be dead. That's why gallstone, fever and jaundice, please always remember this is not UDLIV treatment. This is a treatment which needs something endoscopically. And third important thing is foreign bodies. Foreign bodies, many times we feel that it's a small thing, but foreign bodies can create a problem. And then of course, perforations are also now, initially it was managed by surgeons. Some of the perforations are managed by gastroenterologists without surgery now. Now let us, I will put these two cases so that I will ask all of you. There is a diabetic patient who is 30-year-old male. He has come to your clinic or your nursing home with melena, hematemesis. Platelet count is 70,000 and hemoglobin is 7. On the other hand, one more patient has come to you who is diabetic 30 years. Recent fever, he has taken some injections for fever, melena, hematemesis. Hemoglobin is 6, platelet is 2 lakh. First case, what is this? Ulcer bleed or variceal bleed? How many for ulcer bleed? Please raise the hands. First case. Diabetes, melena, platelet count of 70,000. Ulcer bleed or variceal bleed? Variceal bleed. I think everybody are very clear. Very simple test will differentiate whether it is a variceal bleed or ulcer bleed. Any GI bleed comes, do a CBC. If platelet count is below 1 lakh, think that this is not a ulcer bleed most of the times. It is usually variceal bleed. That's a very important thing. A simple CBC will tell you how to differentiate. Second, ulcer bleed or variceal bleed. Platelet count is 2 lakhs. Ulcer or variceal? Ulcer. I think my work is done. I think the first case is variceal bleed. Second case is ulcer bleed. Very simple. Whenever there is a bleeding, do a simple CBC. Platelet count less than 1 lakh. Think that it is variceal bleed. Normal platelet count. Think that it is something related to ulcers. Very simple. Now, this is how we do. And then what immediately at your nursing home or whatever the place where you are working, what you should do, put 2 IV lines which are green in color so that it is a large bore IV line. And then oxygen. Second important thing is give blood only if the hemoglobin is below 8. Not somebody's hemoglobin is 10. If somebody's hemoglobin is 10, you give blood, he will bleed more. That's why below 8 is indication to indication to give a blood. Bleeding is not an indication. Hemoglobin below 8 is an indication. And then always better not a whole blood. PCV is a better modality. And then what are the drugs we should be giving? I think pantoprazole 40 milligram bolus followed by 8 milligram per hour for all ulcer bleeds. This everybody can do. And then very simple drug everybody should have is this terlipressin and octreotide in your nursing homes. If there is a low platelet and then splenomegaly our Pradeep, just start him on a terlipressin, and our Pradeep will be very happy because he can do endoscopy easily. Otherwise, there will be a lot of blood in the stomach. That's why when endoscopy, very important thing, low platelet is cirrhosis, normal platelet is ulcer. An ulcer, you give pantoprazole 40 milligram or 80 milligram bolus followed by 8 milligram per hour. Low platelet cirrhosis, give him terlipressin, and then endoscopy has to be done in next 12 hours, not immediately. Many physicians, they feel endoscopy, if the patient has come to the emergency, they will say, doctor, immediately do endoscopy. That is wrong, because patient is not stabilized. Give all these things and then send to the gastroenterologist. That's what we should do. See, if there is a variceal bleed, this is what we do. I think most of you, can you switch off this? This is a banding, what we do. This is how we put rubber bands. And then this is a rubber band which is being placed. This is esophageal varices which is being managed. This is a very serious bleeding. This is a variceal bleeding, fundal varix bleeding, very severe bleed. Patient is massively bleeding. Then we put glue and injection. This we used to do long back. Nowadays, this modality is slowly going away. What we do is, this is one more case wherein, see this, very massive bleed and nothing can be seen left side. Now, please remember, it is not the cardiologists who also have stent. We have got bleeding stents. Immediately, we can put a bleeding stent and then we can stop. See, this is a patient, nothing can be seen. Endoscopy, we could not see anything. In that situation, this was one of the first cases we did in Karnataka way back in 2013-14. I think Adarsh is here. This was one of our first cases wherein we placed a metal stent into the bleeding and then bleeding was immediately stopped. This is a GI bleed which was stopped by a metal stent, and then this patient later on underwent a TIPS, later on underwent a liver transplant as well. All the people who have done transplant, they have, all of us have worked together. See, this is a beautiful case where a massive bleed who would have died. Just like cardiologists, we can place a stent that is known as a bleeding stent, and then we can stop the bleeding. And then now this new thing has come. Now this is our intervention radiologist. You have to be friend with everybody. You have to be friend with radiologist. You have to be friend with surgeon. Friend with everybody. So this is one of the first cases where we did. My colleague Adarsh also is here. We did the first EUS guided coiling, wherein we put coils and glues. The patient is massively bleeding, and then this is a fundal varix. First case, we asked our intervention radiologist to help, wherein he's actually putting the coils into the fundal varix. And then see, this patient is in a very bad situation. Blood is going on. Nothing can be seen. Through endoscope, we are doing, this is known as an endoscopic ultrasound guided. We are putting coil and glue into the fundal varix and bleeding was stopped. This is how we manage variceal bleeding. And then see this, now the bleeding is stopped. See, this is how we put coils. We put coil inside the varix. And then this is how the bleeding is now completely stopped. On the left-hand side, you see, there is no bleeding. Patient, even without vision, with endoscopic ultrasound, we can stop bleeding. Now, this is a big problem. This is a duodenal varix. Very recently, we had this case. Patient had a duodenal varix, then wherein we could go in, and then we put a coil. See this? Into the duodenum, we have gone. Just like an intervention radiologist, you can do a coil, and then we have put glue into that. And then a duodenal varix was managed without surgery, just like an intervention radiologist by endoscopist in the endoscopy room. This is how a duodenal varix being managed. And now this is the regular thing what we do, ulcer bleed. I think this is how we do adrenaline injection. We give adrenaline, diluted adrenaline all around. And on the left-hand side, we have this heater probe. So we apply heater probe on the ulcer point, which is there, which is the bleeding point. And then we stop bleeding. This is the traditional method what we do. Whenever there is a bleeding, always use two technologies. Use injection and then use thermal ablation or a clip. See, this is how we do a clip. So already we have put injection, adrenaline. Now we will clip the whole ulcer. See this? We are clipping the whole ulcer, and then the entire ulcer is getting blocked and the entire ulcer is getting stopped. And this is a new technology. Just put hemospray powder onto the varix, onto the ulcer, bleeding will stop. This is a simple hemospray powder what we use in duodenal ulcer and gastric ulcer, and the bleeding stops. And then this is one interesting case we had, that is a bleeding from the small intestine. And then this is that time we had this enteroscope that is known as a spiral enteroscope. We entered into the small intestine, and then we are using laser APC, organ plasma coagulation, and then we are stopping the bleeding. See these all bleeding spots, we are coagulating, and then we are stopping the bleeding. This way bleeding is getting managed. Suppose we cannot manage, then should we send it to surgery or should it be managed by a radiologist? I think now all my friends are there, surgeons are there. They don't want to do any surgery on a bleeding patient. They want a clean patient. This patient, bleeding never stopped. Then we called our intervention radiologist and then they did an embolization. See this? This is an embolization which has been done on this and then patient's bleeding stopped. This is an angioembolization being done. And then do we need surgery in GI bleed cases? Yes, in very, very small percentage. I think our Dr. Neil is there, Srishal is there. They might have been operating many cases before, but nowadays maybe in a year they operate maybe 1 or 2 cases or 2-3 cases. Otherwise, GI bleed is managed in the endoscopy room 90%, 5% by the radiologist, maybe 1 to 2% by the surgeons. That's why the first call for a bleeding is a endoscopy. That's what is required in most of the cases. Now let us come to the second deadly case which you don't properly treat, patient is going to die. That is a 50-year-old male patient, gallstone, and then patient comes to your nursing home, jaundice, fever, abdominal pain. Please don't treat them with Udiliv and antibiotics. Ceftriaxone is not the treatment here. Any gallstone patient comes with abdominal pain, fever, please think that this patient has probably got a CBD stone and he's developed a cholangitis. Don't treat with ceftriaxone and Udiliv. Don't delay the patient. Otherwise, 48 hours later, he will be dead. That's why this patient needs a good endoscopy management. This is a patient with cholangitis. I think this is where our Pradeep will help you. This is what we should do as physicians. Before sending, you should put them on fluids, at least 75 ml per hour. Piperacillin tazobactam. If the patient is very sick, put them on meropenem, at least 1 dose, and refer to the gastroenterology center where they are doing. This is how we do an CBD stone removal. See, this is how we go into the bile duct. This is the ampulla. We are passing a guide wire into the ampulla. We are cutting the ampulla, and then we will put a balloon, and then we'll remove all these stones. Next 24 hours, patient is sitting because you have treated the stones. You just give ceftriaxone, Udiliv, patient is by this time you would be dead. That's why please remember one important thing: gallstone, abdominal pain, fever. Please think of cholangitis. If you don't treat, then patient will be dead in 48 to 72 hours. That's a very important message which you should always be thinking. If stone is large, do we need surgery? I think now any stone which is large can be treated by endoscopy, except our endoscope should go. That's the only indication. See, this is one of the cases. This is a new method. This is known as spyglass, wherein we can enter inside the bile duct. See, this is a very thin endoscope, just like a ureteroscope. You can enter. See, this is how we enter into the bile duct. See, this is a bile duct. We are entering from this is the ERCP scope, and from the ERCP scope, this spyglass will enter, and then even a large stone, we can just go in and then we can visualize. See, this is how we do a procedure. See, this is one of the cases. We are entering inside the bile duct. This is a stone which is there inside the bile duct, and then we'll just break the stones. No stone is big now. No surgery for any big stones. Most of the stones can be managed endoscopically, almost 95%. That's why CBD stone management has become totally endoscopic, almost, except our endoscope doesn't go. That is an indication for surgery. Otherwise, it is managed endoscopically. See this large stone getting broken and then made into pieces, and then we are removing the stones. See, the entire bile duct is clean. We are very clear that this stone has been removed. And then this is how a large stone is managed. And then let me just, another couple of slides. Foreign body, which is dangerous? Coin, pencil, or a button battery. Which is dangerous? Yes. I think this is very, very important. If a button battery is there, immediately battery is sticking, and then the esophagus is totally ulcerated, and then if it is kept for some more days, esophagus will open, and then you can see the aorta, you can see the heart. That's what it is. That's why any button battery, immediately it has to be removed. This is a button battery which is struck, almost corroding the esophagus, 360-degree corrosion. This has to be removed immediately. And then this is what we see. Pencils, very common that we can do. But one more thing is this one. This is also dangerous. What is this? Denture. I think this is a very problematic thing. We just remove it. And then, but many times dentures have created problems for even gastroenterologists because that will tear our esophagus. Many times esophageal perforations are also happened. And this is one of the very interesting case which I would like to show you. What is this? Anybody can say in the audience, what is this? Yeah, somebody is right. It's a blade. Can somebody tell how the patient has taken? This was a very interesting case we had. Patient had come with blades ingestion. Can anybody say how the blade has been taken? I'll tell you later. See, first we tried to remove it, but the blade got cut in the cricopharynx, and then it started cutting in the cricopharynx. We were not able to remove it. And then what we thought, we tried a basket to remove, but even that didn't work. Even basket got cut. And then finally, at that time, we had a double balloon. And then what we did is, with this double balloon over tube, we pulled this blade inside. Can somebody say the brand of the blade? Supermax. Yeah. I think this is what is the thing. And we thought that we have done a great job. And then next day, we thought we have done a great job. But unfortunately, when we took an X-ray and a CT scan, there were some more blades in the colon and small intestine. And then we went with a double balloon, and then we pulled out some of these things. And then balloons with only the difficult part was the anus. It got stuck in the anus. And then there were a lot of cuts in the anus. And then we removed blades from the anus. This is a very interesting case we had. This is the entire team which we removed this. And finally, this is one more thing now we can do. Even if there is a perforation, if there is a stomach perforation, colon perforation, what we used to do, first call used to go to the surgeons. Now surgeons will call us. If there is a perforation in the stomach during surgery and then post-surgery, then what we can do is, there is a new method, very simple method. Anybody can do this. This is a very simple method. There is a clip which has come that is known as an Ovasco clip. You go in wherever there is, this is especially sent by surgeons. See, this is a post-surgery perforation. And then what we are doing is, the perforation we are closing with an Ovasco clip so that patient doesn't need one more surgery. That's beautiful of this endoscopic method. Even perforations, what we had thought was all perforations are surgery, some of the perforations we can also manage. And finally, one new advance, and then we'll stop. This was an interesting case of a GA bleed. And then everybody thinks that capsule is the most difficult procedure. I think capsule is the easiest procedure. That's how we do. We give a capsule. See this lady very laughing. Only endoscopy patient is laughing this capsule endoscopy. See, this is how a capsule endoscopy is given. The patient takes a capsule. And then I showed you the capsule will give an image like this. This is how an image is. This is showing bleeding. At that point of time, we had an enteroscope that is known as a spiral enteroscope. Entire from mouth to anus, we could finish in 30 minutes. This was one of our first cases. This is also one of the first cases of Karnataka, wherein entire enteroscope, entire pan enteroscopy from mouth to anus, 45 minutes we had seen. This was one patient from North Karnataka only. We had lot of ulcers in the small bowel, and this turned out to be a vasculitis of the small bowel, and this patient was treated with steroids and she became better. And finally, we are also entering into endoscopy, please, bariatric endoscopy also. Now, because tirzepatide has come, 30% weight loss will happen with tirzepatide, and then you just do put a balloon, your weight loss is to the tune of 40%, no surgery required. And then you can also suture the stomach with a ESG procedure, weight loss to the tune of 40%. One injection, one surgery, no surgery, patient will lose 40% of the weight. I think that's what is the thing. Thank you very much for your kind attention. I think only two things you have to remember from my talk is low platelet needs terlipressin or octreotide. Normal platelet, fever, abdominal pain. This is not ceftriaxone and Udiliv. This patient needs a ERCP. Please remember this. These two important messages we should always remember. And button battery, you have to be very quick in removing. That's a very, very important thing.
Thank you, sir. Very nice presentation. What are the emergencies when you have to do? Which are the emergencies you have to do endoscopy nicely? You told to everyone. Any questions from the audience? Sir? You can ask.
Yeah, this is a question for all of you. Anybody has a guess how the patient has taken the blades? Yes, Pradeep has an experience. See, he was an engineer and a dentist's brother. He had stuffed all the pieces of this inside a banana, and then he had swallowed that. And some of this got cut here. They were stuck in the esophagus, some were in the small bowel, and many of them, they came to ileum and then they struck. And then we did a CT, and then we removed. And then finally at the anus, lot of fissures happened, because when we tried to remove, lot of fissures were there at the anus. No, it was a love breakup and then it was suicidal. Yeah. Thank you.
Thank you, sir. I would like the moderators to stay for the next round as well. I would invite Dr. Ravi Kiran to join the moderators as well. When the fire within begins to burn its own walls, the pancreas weeps in pain. A storm of enzymes unleashed, life's own healer turned to bane. When I first learned about the pancreas in my first year of MBBS, I was in complete awe. It was able to break down complex molecules of food and at the same time control the blood sugar levels by its endocrine functions. And yet, internship showed me how the malfunctioning of this very organ can leave a patient bedridden, unstable, and desperate. I once again call our illustrious Dr. Shirane Shetty, Professor and Head of Gastroenterology and Hepatology, to tell us all about recurrent acute pancreatitis.
Can you just do this? Yeah, warm greetings from Kasturba Medical College, Manipal, and once again thanking the organizers and Dr. Pradeep for this fantastic meeting, and also Dr. Ravindra for, I think, beautiful previous talk. So let me start this talk on a topic called recurrent acute pancreatitis. Before that, we need to understand how exactly acute pancreatitis work and what exactly we mean conceptually recurrent acute pancreatitis. So you need this pancreas is an enigmatic organ in our body. So most of the clinicians or surgeons, we come across this entity, but however, sometimes few of these patients we lose in our clinical practice because we still don't know what exactly drives the mortality in some of these patients. And some of this time, most of the time, these are all self-limiting, and when we manage conservatively, 90 to 95% of the patients do very well. So let's start with the case. So my topic is recurrent acute pancreatitis. Itself tells that there is recurrent event or recurrent attack on pancreas. That's the repeated episodes of pancreatitis. So this is a middle-aged man, comes with an abdominal pain, typical of pancreatitis, with all the biochemical parameters suggestive of pancreatitis, all the etiological work negative, improves, comes back after 6 months with the similar episodes. He was previously treated as acid peptic disease or gastritis, which many of the times we do because some of these pancreatitis are mild. So they just come with abdominal pain or vomiting. They get relieved with PPI, assuming that it's acid peptic disease, but it is not. So as a clinician or as a doctor, what's important is assessing the symptom. A person cannot keep coming for gastritis. So that's the message. So anything, an abdominal pain, vomiting with something, you suspect, you need to investigate them, because if you prevent further attacks, you can prevent them from developing chronic damage, what we call as chronic pancreatitis. So the definition is very important. You have a patient of abdominal pain. Typically, you need to ask history, very typical of pancreatic pain. Send a biochemical parameters, 3 times elevation, and then imaging. The imaging can be just a simple ultrasonography. You don't have to do a cross-sectional imaging here. You can just do a basic, simple ultrasonography. If you have a pain and biochemical parameters, that's enough for diagnosing as acute pancreatitis. Now, you need to prognosticate, try to find the etiology. So let's come to the terminology called as RAP, what we call as recurrent acute. So you have acute pancreatitis, resolves completely. In between, next 3 months, he gets another attack without knowing etiology or an unknown etiology. So now this is very important for a clinician point of view to prevent further attacks. That's something the role of your, as a clinical acumen, and also how to investigate and what are the investigating tools we have in 2025. So epidemiology, this is increasing because of lifestyle, most of the drugs, alcohol, toxin, gallstones. We are seeing more and more pancreatitis, and over that, we are seeing more and more recurrent acute attacks. If you look at the diagram, so there is an acute attack on pancreas. So that's acute pancreatitis. You treat them, they improve. But what happens next? There is a small subset of patients who can go on to become a recurrent acute despite treating, or 10% of them become a chronic pancreatitis. So that's important because you're losing chronic pancreatitis at the risk for diabetes, malignancy. So acute pancreatitis, the first important thing is identifying the cause if possible. So that's important so that you can prevent them from developing chronic pancreatitis. So this is an algorithm. You have a first attack on pancreatitis, that's a sentinel attack. What happens when you have an attack? There's an inflammatory mediators, all those attack, like what happens in any wound. So inflammation happening in the pancreas. You try to resolve that. If you know the insult, you try to prevent that insult so that the further damage is prevented. But on the other hand, you have no idea what's happening. There is an ongoing insult. Patient might be asymptomatic. So that leads to recurrent and then to chronic pancreatitis, which is a little bit dangerous. So this is a beautiful slide. You have acute pancreatitis. So in our practice, in your practice, what you see, most of them are gallstone, toxin, what we say alcohol related. These are the common causes, at least in country like India, alcohol, gallstone. The third important thing is toxins. Most of the drugs, we forget to ask patients, what is you on? Many times they are drugs, anti-epileptic drugs. Any drugs can cause pancreatitis. So you need to take a drug history. Spend a minute on a patient. So ask, what is his drug history when you have a patient of pancreatitis? So that's the thing. And the other thing is idiopathic. In 20%, even at our level, it's difficult to find out the exact cause, what's causing pancreatitis, and where gastroenterologist gets reference for what you call as idiopathic or idiopathic recurrent pancreatitis. This is the same diagram what I've written in the theory. So you have, earlier we should do an ERCP. ERCP is an invasive procedure. We don't do for diagnostic purpose. So ERCP, the first diagram is the acute. So the duct, pancreatic duct, you can see. The second is the subtle changes. On the last thing, you can see the chronic, where the dilated duct is there. And what you do in 2025 is an endoscopic ultrasound, which is very handy. It's an endoscope with an ultrasound, which tells about the pancreas parenchyma, tells about the pancreatic duct, calcification, some structural abnormality. Why it's important? Doing this test will identify the cause so that you can prevent it. So these are few of the causes you should remember. Other than the regular big gallstones or toxin or alcohol, what we see is microlithiasis, pancreatic divisum, trauma. In India, still parasitic infection. So sometimes roundworm can block the duct, can cause. The toxin, what we forget is the triglycerides, hypertriglyceridemia, hypercalcemia, medications, then connective tissue disease. Sometimes I think with now more and more connective tissue disease, we need to always remember one of the cause for pancreatitis is connective tissue disease. Then the genetics. We have a lot of genetics like hereditary pancreatitis, SPINK mutations, and some genetic mutations associated with pancreatitis are seen. So toxin, alcohol, still the more common in India. So try to find out the history. If you can convince the patient that this acute pancreatitis, you're going to develop chronic. If he stops, 90% chances that he doesn't develop chronic pancreatitis. Otherwise, it's very difficult that, the recurrent acute can be prevented by absolute stopping of this toxin, that is mainly alcohol. Biliary, most of us do an ultrasound. You get a gallstone. The best thing is to knock it down, send it to a surgeon, do a cholecystectomy. The insult is done. But the problem comes here when you have a smaller sludge or a stone, when it's not seen evident on the ultrasonography. So what you do that, you have a smaller calculi, you need to do an endoscopic ultrasound or sometime an MRCP, which tells that there is a sludge or a small stone in the bile duct. Because here in this group of patients, the liver function tends to be normal. But however, he keeps getting recurrent attacks. So these are the tests which are handy when you have a recurrent acute pancreatitis. These are ultrasound images where you can see distended gallbladder on ultrasound appeared as only distended, normal. When you do an endoscopic ultrasound, lot of sludge, small calculi, or what we call as microlithiasis, one of the common causes we miss in clinical practice, but easiest to treat. You just treat pancreatitis, send it to surgeon, remove the gallbladder, no more further attack. So identifying is a little bit difficult. You need to find out. When you have ruled out other causes, come to the toxin. The simplest test what we can do is a serum triglyceride level. Sometimes we can, rarely, this is not very common, but however in practice we see hypertriglyceridemia related pancreatitis, which can be managed conservatively. We have medications to treat that, treat appropriately, but diagnosis is very important. Drug induced, missed even at tertiary center. We forget because in this era, we're always writing investigations. We don't talk to a patient. Talking history will relieve, will give us some more clue that what can be the etiology. Taking a detailed history and examination will give us a clue that what can it be the pancreatitis. This is something rare. Sometimes the cyst, anatomy, smaller cyst can compress the duct and cause pancreatitis, but these are picked up on the cross-sectional imaging. So what is cross-section? The longer, like either it's a cross-section is CT scan or an MRI. Otherwise, you have an endoscopic ultrasound, which is not very much available. I think most of the gastroenterologists now do have endoscopic ultrasound in their practice. So that's something handy when you have a patient of a recurrent acute pancreatitis or an unexplained abdominal pain. The other causes you should not forget is the elderly people coming with recurrent pancreatitis. You give analgesic, you send them home. But however, there is a small tumor sitting in the ampullary region or in the uncinate process, which are nearly missed on a CT scan. So best thing is ask them to come back, ask a GI reference. Maybe he can do an EUS endoscopic ultrasound and pick up a smaller tumor of less than 1 centimeter, which can be the cause for an obstructive type of pancreatitis in an elderly group of people. So another anatomical issue is one is we see in pancreatic divisum. I think this I'm not getting into the detail. Embryologically, dorsal and ventral duct are there. So when there is a malformation or a malunion of this duct, you might develop a pancreatic divisum. However, pancreatic divisum is not the sole reason for it. It can have an associated factor. So you have a pancreatic divisum and MRCP. Don't be happy that that's the only reason, but that's a contributing factor. So you can still have another insult going on in a patient, whether it's a toxin or a genetic mutation, which can be the cause for his recurrent acute pancreatitis. But however, if you have a pancreatic divisum, there are some endoscopic therapy which can relieve his pain or which can relieve his further insult. So these are some of the rare things which comes at the bottom end. When you have other causes ruled out, you have sphincter Oddi dysfunction, different types are there. These are basically the pressure things at the sphincter which blocks the pancreatic the ductal sphincter, but normal on EUS or an MRCP. So this looks normal, but however, patient do have an obstructive symptom like sudden biliary pain, some altered LFT. When you do imaging, it is normal. So you always suspect one of those entity called as sphincter of Oddi dysfunction. Other anatomical abnormalities, I think surgery colleagues will be saying that there is a dilated bile duct, cholelacol cyst, or an anomalous communication. They are rare, but they are definitely the cause for pancreatitis or a recurrent pancreatitis. Genetic factors, definitely with new tests available, a lot of genetic tests are done, but currently as a clinical practice, don't subject them for any of them. You can tell that if the patient asks what might be the cause, if the other causes are ruled out, you might have a genetic cause. If they insist or the patient is young patient, there is a family history, we have a test or laboratory test which can check SPINK or a CFTR mutations. There are facilities available, but however, treatment options. You can only prognosticate or you can tell the patient that this might be the cause for your recurrent acute pancreatitis. However, they are going to be developing chronic pancreatitis. You need to prime them. Their treatment doesn't train despite you have a SPINK or a CFTR mutation. The approach now, you have a diagnosis of recurrent acute pancreatitis. You have found some cause, you have not found a cause, then it becomes idiopathic. So how do you approach? Basic history, examination, simple tests, biochemical, lipids, and calcium you should not miss. Basic abdominal imaging, and then you have not found the cause, go for a higher imaging. Basically, MRCP will tell you the ductal anatomy and also tells about the parenchyma. Otherwise, if there's no MRCP available, a cross-sectional CT is good enough. The next level of test will be your endoscopic ultrasound, because most of the GI guys do that. And simple, when patient is not having an acute episode, do an endoscopic ultrasound to find out microlithiasis, obstruction, or ductal anatomy, also to find out early chronic pancreatitis changes. Special tests like manometry, even we don't do at Manipal. Genetic test we do on select patients. If you think that there's young people, family history, recurrent attack, we run a couple of mutations at Manipal so that we can tell them that you have a cause for this is the cause for your acute pancreatitis. So this is the test, the busy table, ultrasound, EUS, biochemical parameters, then rare last will be your genetic test. So EUS has got a great role because I said you can tell the anatomy, you can tell the ductal structures, you can tell the gallbladder, you can pick up small calculi. The other important advantage of an endoscopic ultrasound is you can pick up early small tumors, whether it is less than 1 centimeter or maybe 1 to 1, even less than 1 centimeter can be picked up at a very strategic location so that you can send the patient for a cure. So that's the beauty of this instrument, what we call as endoscopic ultrasound. This is an EUS picture which shows sludge. The patient was treated with abdominal pain with recurrent painkillers, thinking idiopathic. However, there was a sludge. So patient was subjected for cholecystectomy and there's no further episodes of recurrent acute pancreatitis seen. So EUS also can tell us about the pancreatic parenchyma, chronic pancreatitis changes, ductal anatomy, and also the calcification. So MRCP I already told tells about the pancreatobiliary ducts, helps in diagnosing pancreatic divisum, strictures, anomalous pancreatobiliary union can be found out with MRCP. So genetic tests we don't recommend, but however, when you have a doubt, a young patient, family history, hereditary pancreatitis, pancreatic cancer, you can just send them for SPINK or CFTR mutations, which I think most of the few of the tertiary center do, or sometimes it's done on a research purposes. So this is your level of investigation. Level 1, kindly do a liver function test within 48 hours. Serum calcium, triglyceride level, and a basic ultrasound. That will be a level 1. When you don't have an answer, always go to level 2, which is your cross-sectional imaging or an endoscopic ultrasound. Level 3, I don't recommend, but that's for the tertiary level. When you still don't have a cause, we need to do some next level of investigations. When you find out, I think the next talk is on acute pancreatitis. I will not tell you how to manage that, but quickly classify severity. When you have pancreatitis, please classify severity. Management, there's no specific drug. Remember that. Conservative management, hydration, analgesic, nutrition, antibiotic appropriate uses, and drainage. Fluids, I think my next speaker will be talking on how exactly you give pancreatitis fluids in pancreatitis. What are the WHO or what is the criteria or what are the grading, or how do you grade pain and how do you treat that with analgesia is something very important for clinicians. When do you start feeding? One thing important is don't keep anybody nil per mouth. When the patient feels hungry or when there's no vomiting, you can start feeding so that it prevents the translocation of bacteria and prevents further pancreatic infection. That's something we should remember. The algorithm in ER is conservative, fluid management, nutrition, appropriate antibiotics when it's infected, not in the first week of pancreatitis. So let's come back to our topic, recurrent acute pancreatitis. The algorithm is the patient alcoholic or smoker? Yes, then you have a cause. Try to do a cross-sectional imaging. Stop the acute insult like alcohol and follow him up for the next 3 to 6 months. If there is no, do a liver function test, find out any other cause, is biliary or not. If there is stone, I think Dr. Ravindra said, if there is a gallstone or a bile duct stone, you need to subject them for an ERCP so that he doesn't develop further biliary pancreatitis. If it is no, then we call as a non-alcoholic, non-biliary recurrent pancreatitis. Here, you need to do the next level of test, cross-sectional imaging. MRCP is better. And next, MRCP plus. It's not or. It's an MRCP plus EUS because they supplement each other so that you get more information on the ductal anatomy and also on the smaller tumors. Then appropriately, if there is gallstone, send them to surgeon. Endotherapy when there is pancreatic divisum or a pancreatic stricture, hex stricture, or there is something like anomalous choledochole seal, you can subject them for an endotherapy. Tumor, directly you have to refer to surgery before the patient develops metastasis. The last thing is sphincterophore manometry. We don't do, very few centers in India do. Genetic testing is not done frequently, so the treatment doesn't change on the last group. However, identifying the cause is very important so that you can subject the patient for an initial management, prevent further attack, so the chance of developing chronic pancreatitis can be reduced to less than 5%. So this is the final algorithm, how exactly you finish. So you have a cause, try to treat the cause. Not I don't tell it's non-invasive, it's a semi-invasive test, very economical in India, can be done. MRCP, when you suspect there's an anatomical thing, you always use MRCP plus US. Genetic testing is not clinically indicated. Thank you for patience hearing.
Very nice and informative talk, sir. The floor is open for questions.
That's what, sir. They are becomes an idiopathic recurrent pancreatitis. Either they might be carrying some of these genetic mutations, maybe SPINK or CFTR, or they might have an incomplete divisum. So there's a combination of this. Rarely we see even gallstone or microlithiasis in pediatrics. In India, very rarely we see roundworm obstructing the duct, which can be causing the recurrent pancreatitis. But nowadays we are seeing more and more idiopathic. That's 10 to 15% has still, they come under idiopathic recurrent or idiopathic acute pancreatitis, which are non-biliary or non-alcohol or non-toxin.
Sir, any patient with, excuse me, sir, any
Hi.
patient with occult bile stone disease, should we consider treating with UDCA first, then followed by surgery, or it's straightforward?
No, if they have acute if they have a what we call as biliary pancreatitis, they have to be subjected for surgery, because the response of ursodeoxycholic acid is not that. It's not more than 30 to 40%.
And when do you suspect the sphincter of Oddi dysfunction? Because when no known cause is detected on the available tests, should we still consider doing biliary sphincterotomy, or?
Yeah, there's a very beautiful question. So first is, when do you suspect biliary sphincter of Oddi dysfunction? One is, there are 3 classifications. When you have a very typical pain of pancreatitis, you do a pancreatic imaging whether duct is dilated or not, and also you see whether he has pancreatitis. That is type 1, and there they do very well with sphincterotomy. Okay, you don't have to do, because manometry is not very available and it's an invasive test. So you have a clinical suspicion and you say that, okay, it's type 1 with all the evidence, you are justified to send him to a gastroenterologist to do a pancreatic sphincterotomy. The second one is where you have abdominal pain, no much imaging, the duct is not dilated, plus and minus, they might not really respond well. The third one is a very difficult format, what we see in clinical practice. In my practice at Manipal, we get a lot of pain, a lot of people from peripheries with abdominal pain, pancreatitis treated, comes with very typical of pancreatic pain, enzymes are fine, I do an MRCP and EUS, the duct is fine. So now worrying. So they keep getting recurrent pancreatitis. So their endotherapy really doesn't work. Earlier, we have some data from Manipal where for pediatric and for young people with recurrent pancreatitis, normal ductal anatomy, we have stented them. Very partially they've responded. Many of them didn't respond, so we have to remove the stent. But recent data doesn't advocate us to do stenting or ERCP in such group of patients. I would recommend only type 1 and 2.
Dual stenting.
Yeah, pancreatic stenting.
Thank you, sir.
Sir, how do you manage familial hypertriglyceridemia who presented with a recurrent acute pancreatitis?
So if the triglyceride is more than 1000 or above 500, to prevent, you have to give fenofibrates. That is one. For acute severe pancreatitis, if it is mild to moderate, conservative, or you can do insulin dextrose drip. One is there's a diffusion of triglycerides, so it helps. The other thing is, if it's very severe, you can send them for one session of dialysis where there is plasmapheresis sort of. We do plasmapheresis so that it prevents further damage if there is an ongoing inflammation. Many times we can manage with mild, we get mild to moderate, there is no organ damage, we can plan with drip as well as therapy. But however, you can have to use this plasmapheresis if it is required, which will be great that, it will be actually, if there's that this patient is developing renal failure or ARDS.
Thank you, sir.
Thank you, sir. I would like to call upon Dr. Guru Channav to felicitate the dignitaries on the day. I request all the doctors to give a visit to Senate Hall 1 to see all the pharma stalls. We will be starting the inauguration programs shortly. I request all the doctors to be here for that. There was a time in history when the world believed that stomach ulcers were caused by a feisty diet and a broken heart. It was not until an unexpected man with an unwavering spirit named Barry J. Marshall swallowed a beaker of bacteria that caused that the world believed that bacteria could not only live in acid but also cause the wretched stomach ulcers that plagued the world. From then on, our understanding of the gastrointestinal tract has evolved beyond acid and ulcers into microbiomes, motility, molecular medicine, and minimally invasive surgery. And yet, at its heart, it remains a tryst into human curiosity, the desire to understand what happens when the simple act of eating or swallowing becomes a source of suffering. Today, we gather at this CME surrounded by brilliant minds of medicine, surgery, and allied specialties to discuss, debate, and deepen our understanding on the simple heartburn to the age old connection between heart, soul, and gut. Now, I call upon our esteemed guests for a formal opening of this event by a lamp lighting ceremony. I would like Dr. S.B. Hegde, Dr. Arvind CL, Dr. Pradeep Kumar, and Dr. Arjun Rao on the stage for the lamp lighting ceremony.
Arjun Rao also.
I now call upon our esteemed guests for a formal opening of this event by a lamp lighting ceremony. Has been awe is how doctors are able to simply heal with the power of their words. It's a language that transcends every world. I call upon Dr. Pradeep Kumar, one such magician, to welcome you all to this August gathering.
Good evening and warm welcome to all the esteemed doctors, colleagues, and dear friends present here to attend Sigecon 2025, the regional conference on gastroenterology and hepatology. So I'm very grateful to one and all who made to this conference within short notice of 3 weeks. It all happened because of the bonding, affection, and faith you have on our hospital. So in one of the hospital meeting, when we were discussing when we completed 7 years of our hospital, so suggestion was like always we call all our seniors, colleagues and friends for a get together and having dinner or food. So this time we suggestions to include the academic activities also. At that point, we decided to do a half-day CME program. So mainly to concentrate on common diseases we encounter in day-to-day practices. So when we decided that, we contacted all the stalwarts in gastroenterology of our state, starting from our Ravindra sir, Dr. Shiran Shetty, Amit, Dr. Sandeep Satsangi, Dr. Malikan Sakpal, Sri Shail, Dr. Anand, and Dr. Pradeep Krishna, and Dr. Hemant, Dr. Neil Shetty, and Dr. Rajay Gowda, and Dr. Pramod, all are readily agreed, and Dr. Hemant, they all agreed and they accepted invitation. They are all here to give the talk on various topics in which they are authority. So when we decided to call the chief guest for our function, the first thing came to my mind is Dr. S.B. Hegde sir. So because when I came to Shimoga in 2008, sir was the first person I met in the medicine department. And at that point of time, sir was heading the Department of Medicine. So after that, I went and approached sir to give me opportunity to work with him for in his clinic. But after he readily agreed for that. But because sir is always an inspiration to us to work hard, to practice ethically, and also sir is very eager and always eager to learn and teach juniors and guide us. So I requested Dr. Sir to this event. He readily agreed for that. So I welcome Dr. S.B. Hegde sir for this inaugural ceremony. So when we requested Ravindra sir to give a talk on these things, he not only gave idea of talks and also give how to conduct this CME and what are the things we need to give more importance. So he always backbone to any procedures we do in our hospital. Always any academic activities, service always supports us. So I welcome Dr. Ravindra to this inauguration ceremonies. I also welcome Dr. Virupakshappa sir, the Dean of Shimoga Medical College for this inaugural ceremony. I welcome Dr. Arvind CL to really accepted to chair this 2 sessions, and also he encouraged the pages and other his colleagues to attend this event. Welcome you sir for this event. Last but not the least, Dr. Arjun, you always backbone to our hospital when you are doing a difficult procedures. When in my absence, he also manages my hospital. And also, whenever there is a difficulties, he will be with me always. So I welcome Dr. Arjun for this event. Finally, I request all of you to enjoy experience or hospitality and academics. And I welcome once again for this event. Thank you.
Thank you, sir, for that warm welcome. Today, we count ourselves fortunate, for in this room, wisdom itself has chosen to gather. Our chief guest, Dr. Hegde, is between us today. I would like to introduce him to all of you. Dr. Hegde completed his MBBS from MMC in the year 1968. He finished his general medicine from BJ Medical College, Ahmedabad in 1972, followed by Comfort Fellowship of Indian College of Cardiology in the year 1995, and finally conferred the Fellowship of the Royal College of Edinburgh in 1998. Over the years, he worked for the NHS in the UK, followed by being the professor at Adi Chunchandagiri Medical College, Belloor till 1999. He was also the professor and HOD of medicine since Shimoga till 2008. He currently works as a physician in Hegde Health Complex in Shimoga. Apart from this, he also has authored 2 books, Live in Style and Iduve Jeevana, which gives information about a healthy lifestyle. He has also begun Malnad Heart Foundation and authored numerous research papers and articles. We are overjoyed, humbled to have you here amongst us, sir. I would now like to call upon our guests to whom we will felicitate our senior members M.K. Bhatt and Dr. Syed Hassan.
You request sir to speak a few words. He can take it, sir.
After this, no?
After this.
Dr. M.K. Bhatt. In 1974, Dr. M.K. Bhatt completed his MBBS from KIMS Hubli, post which he began working for the general population of Soraba. In 1980, he was appointed the District Divisional Commander of Shimoga. For 10 years, he was the president of Kannada Sahitya Parishad Soraba. Over his wonderful years, he conducted over 300 camps focused on diabetic care. He has been the creator of the health magazines with information about well-being and common ailments. He has spent a large amount of his valuable time teaching at schools. For his colorful career, he has been awarded various awards like the Rashtriya Seva Prashasti, Janas Seva Prashasti, Vishwakarma Kala Prashasti, and on the 1st of July 2020, on the occasion of Doctor's Day, he was the recipient of the prestigious Dr. B.C. Roy Award. Along with an exceptional record in his professional life, he happens to be a dedicated family man, father to 3 boys, Ranganath, Vikas, and Vinay. We are humbled to have you, sir. I request Dr. Ravindra to felicitate our guests. Dr. Syed Hasham. For over 50 years, His extensive work with patients and precision of care provided to them has made him an asset in the medical community in Soraba. We thank you, sir, for your gracious presence. On words.
Good evening, everyone. I'm really overwhelmed. Dignitaries on the dais and Dr. Pradeep, Dr. Arjun, and all other staff members of Sushoda Gastroenterology Unit Hospital. First of all, I must really congratulate Dr. Pradeep for having started this as a precedent. Such a wonderful the CME, it looked more like a conference at the end of the day. I wish every institution of Shumaga would follow the same suit, and I congratulate and compliment. And I also actually was really pleased about the selection of the topics which the galaxy of speakers, learned speakers have selected, which is of actually clinical relevance, and it is of immense help and useful for all the practicing physicians, common physicians like me. So I'm most grateful to all the speakers. And last but not the least, it's actually the delegates who really are responsible for the success of any event, CME events. I'm really nice to see that good interaction which has been happening with the delegates and the speakers. So before I wrap up, I just have to say and make an announcement, really. So this year's KPCon 2026 will be conducted here, held in Shimoga. And our team is really working hard to make it is a grand success, a real, very good scientific feast. I request all of you to come and join, register yourself, and then join us, join your hands with us. Thank you very much. Take care. Nice evening.
Thank you, sir, for your words. I would now like to call upon Dr. Arjun Rao for the vote of thanks.
Hello. Good evening, respected dignitaries, esteemed guests, colleagues, and my dear friends. On behalf of the organizing committee of Sigecon 2025, it is my proud privilege to propose the vote of thanks. First and foremost, I extend our heartfelt gratitude to our chief guest, Dr. Shrikant Hegde sir, for gracing us with his presence, inspiring words, and for officially inaugurating this conference. Your insights have set a meaningful tone to our conference, sir. Our sincere thanks to all the eminent people on the dais and off the dais, and the speakers and the faculty who have traveled from near and far to share their vast knowledge of expertise in the field of surgical and medical gastroenterology. We eagerly look forward for your thought-provoking sessions that will enrich our understanding and practice. I have to give a special word of appreciation to our organizing team, including Mr. Sunil, Mr. Krishnamurthy, Mr. Basavaraj, Ms. Shobha, Mr. Gopinath, and Ms. Hina, and Mantra Event Management, who have worked tirelessly for weeks to make this conference a success, from planning logistics to scientific content, hospitality, and technical arrangements. We are equally grateful for our sponsors and partners whose generous support has made this event possible, and to the media representatives for helping us reach for wider audience. To all the delegates and participants, thank you for your enthusiasm and presence. Your participation adds immense value to the academic gathering. Finally, I extend my gratitude to the management of staff of the venue and supporting institutions for their seamless coordination and hospitality. As we move ahead into the scientific sessions, let us continue the spirit of learning, collaboration, and innovation that defines our medical fraternity. Thank you.
Thank you, sir. Now we shall move on to our next talk. Acute pancreatitis is the sudden cry of an organ pushed beyond its limit. The pancreas, silent in health, erupts in inflammation when its own enzymes turn inward, digesting what they were meant to protect. What begins as pain radiating to the back can swiftly become a storm affecting every system. Yet, with timely care, balance returns, a reminder that even in crisis, the body can seek harmony, and medicine is the role where it can find its way back. I now invite Dr. Adarsh CK, Senior Consultant, Medical Gastroenterologist, Glengale Hospital, Bangalore. I would like to invite Dr. Lakshmi Narayan KS, Dr. Ramakrishna, and Dr. Vishwanath B to be the moderators for this session.
At the outset, I would like to thank Pradeep and his team for giving me opportunity. So I wish him all the best. Management of acute pancreatitis. Yeah, this is one of the common medical emergencies we do see in our daily routine. So we all know pancreatitis. I think even one of the talk is already done. Recurrent acute pancreatitis is inflammation of pancreas. We broadly classify into acute and chronic. Acute, which lasts for a few days, and chronic usually develops over few months to few years. So we have various pathogenic mechanisms in acute pancreatitis. So usually the end result of whatever causes is activated enzymes which causes intestinal inflammation, proteolysis, fat necrosis, and hemorrhage. So these are the usual way of pathophysiology. Majority of the time what we see is acute pancreatitis is mild, and 30% of the time we do see severe acute pancreatitis.
So why is managing acute pancreatitis important? Because mortality in severe acute pancreatitis is nearly 30%. If there is organ failure, they have worse prognosis. If there is infected pancreatic necrosis, the mortality is even worse, and complications can have significant morbidity and mortality. So early recognition and preventing severity is the key in management. So this is what happens in pancreatitis. In first 1 week, usually there is a lot of systemic inflammatory response. And after 1 week, at the end of 1 week, the organ dysfunction develops. So we should act before organ dysfunction develops. That is the most important thing from this slide. So most of the recommendations I have taken from this year's guidelines, which is International Association of Pancreatology, also endorsed by American Pancreatic Association, European, as well as Indian Pancreas Club. So let me take to a case scenario, 45-year-old alcoholic who comes with epigastric abdominal pain for 7 days. It's just epigastric, non-radiating, no vomiting. Examination, patient has epigastric tenderness. His amylase is 111, upper limit is 100. His lipase is 234, upper limit is 180. So what is the diagnosis? You want any other investigation, or can we diagnose pancreatitis with this, or any other diagnosis? Pancreatitis. So how many of you think it is pancreatitis? So very few. So basically, amylase lipase just elevation doesn't mean anything. It should be 3 times elevated. That is the most important thing. So the diagnosis of acute pancreatitis is established by 2 of the following 3 criteria. 1, abdominal pain consistent with the disease, that is epigastric, sometimes can be radiating to pain, back, moderate to severe intensity. And amylase or lipase more than 3 times upper limit of normal. This is one thing we see outside many times. With mild elevation, they brand them as acute pancreatitis, and every time patient comes, he'll be branded as acute pancreatitis forever. So that is one mistake we always do. So it should be 3 times elevation. Or another finding is characteristic findings on imaging, which can be ultrasound or CT or MRI. So 2 of the 3 establishes the diagnosis of acute pancreatitis. So again, now patient has got acute pancreatitis. So how many of you want to get CT done? So now the question is, should we get CT done in every patient? So what is the role of CT or MRI? So CT, if you know patient has acute pancreatitis and hemodynamically stable, there is no indication for CT scan. Yes, it is pancreatitis, it's probably mild, you can manage them conservatively. So only when the diagnosis is not clear, sometimes patient has out of proportion pain. Amylase is elevated, but the amylase can be elevated even in mesenteric ischemia. So if you are suspecting mesenteric ischemia or some acute emergency, then you can get CT done, or not just because to confirm acute pancreatitis, or who fail to improve in 72 hours, or there is initial improvement in the rapid worsening. So even if you want to get CT done, when do you want to get it done? As soon as patient comes with pain, do you want to get CT done in pancreatitis, or what is the timing of CT scan? So again, usually we should wait for at least 72 hours if you are looking for severity of pancreatitis, because for the necrosis to set in radiologically, it takes 72 hours. This is one example I have kept. So this is a CT scan. Pointer is not working. Pointer. So pointer. So here you can see on day 1, the pancreas is enhancing easily, normally. So if you have done the CT on day 1, it shows it as mild acute pancreatitis. At the day 3, in the same patient, you can see there is necrosis. Pointer. So the arrow marks show necrosis, which is not seen on day 1. So if you do early, it will underestimate the severity of pancreatitis. So this is how acute interstitial pancreatitis or mild pancreatitis looks. You can see the pancreas is uniformly enhancing, and around that there is inflammation, whereas in the lower down, the whole pancreas is necrosed. In the sense, there is no enhancement. Absence of enhancement indicates necrosis. So on CT scan, there are various scoring systems. So this is called CT severity index. From 0 to 10, depending on the inflammation as well as the necrosis. You combine the 2, you get a CT severity score. So lower the score, lower the risk of complications and mortality. If you see 7 to 10 CT severity score, the mortality is more than 15%. So CT will prognosticate whether the patient has mild or severe acute pancreatitis. Coming to the causes, there is various lists. However, the most 2 common causes are alcohol and gallstone. if those things are negative, then you have to look at other things like hypertriglyceridemia, drugs which can cause, is there any trauma? We should look at autoimmune pancreatitis, especially in middle-aged persons, and no other risk factors. Again, infectious diseases, hypercalcemia, anatomical things like Dr. Shiran was telling in recurrent acute pancreatitis. So we have to look at other lists. So what does the recommendations tell? Basically, ultrasound should be performed in all patients with acute pancreatitis, not CT scan. In absence of gallstones or history of alcohol, you can look at triglyceride or calcium. In an elderly patient, yes, you should always look at probability of pancreatic malignancy as well. And usually patient with idiopathic pancreatitis or recurrent, this is when patient should be referred to a gastroenterologist to look for further management. Genetic testing, if at all there is family history on a very young patient or less than 30-year-old, we can look at genetic testing. So coming to the management again. So first, as soon as patient comes, hemodynamic status should be assessed and resuscitation has to be done. Patients with already with organ failure like AKI or respiratory failure should be admitted in ICU. So can we predict severity in acute pancreatitis as soon as they come? Very difficult to predict. There is no reliable way. However, SIRS, that is systemic inflammatory response response, has some high sensitivity. Patients with persistent SIRS for more than 48 hours with high CRP, it can predict severe acute pancreatitis. Again, there are various scoring systems, BISAP score, Apache score, Ranson score. However, SIRS has the best thing, and other things are hematocrit more than 40 and raising blood urea nitrogen, creatinine. So these are the common, there are so many lists. However, this is a SIRS is one thing which you have to remember, and CRP. So this is how we classify on the right side. On the left side, you can see mild acute pancreatitis. They don't have organ failure or no local complications. Moderate has local complications or transient organ failure, and severe has persistent organ failure for more than 48 hours. So what is this local complication? That is pancreatic fluid collection, peripancreatic or peripancreatic necrosis, or pseudocyst walled off necrosis. These are called local complications. And organ failures include respiratory failure, renal failure, and cardiovascular failure, depending on the scores. So initial management, I don't know, that's blocking, I don't know. RCT, there was a randomized control trial which compared aggressive fluid therapy. Previously, what was told, we have to manage with aggressive fluid hydration. So there was a study which compared aggressive fluid therapy, that is 20 ml per kg bolus, followed by 3 ml per kg per hour, versus non-aggressive fluid management, that is 1.5 ml per kg per hour. And if there is a hypotension or something, then give 10 ml per kg bolus. However, the study was stopped prematurely as it showed that aggressive fluid therapy had more fluid overload patients and no significant difference in primary efficacy. So non-aggressive fluid therapy is the treatment of choice. So early fluid resuscitation is regarded as the initial fundamental treatment. Moderate, not aggressive. Previously was aggressive, now it's moderate fluid infusion at the rate of 1.5 ml per kg per hour is recommended. Fluid bolus is recommended only if there is hypotension. So which fluid to be used? Again, we see many prescriptions mentioning DNS, NS, RL, plasma-lite. What is the ideal fluid? PGs? So it's the RL, lactated ringer solution. This is the ideal fluid. However, in presence of hypercalcemia, you can use saline. So that is because NS can cause hyperchloremic metabolic acidosis, which can again worsen pancreatic inflammation. And also lactate in RL is metabolized to bicarbonate, which maintains the pH. So RL also has got anti-inflammatory effect and prevents hyperchloremia. So RL is the idealistic solution for management of acute pancreatitis. So monitoring is what are our targets of fluid therapy? How long to give? Sometimes patients comes after 5 days. There is no point in giving aggressive or moderate fluid hydration at that time. It's first 72 hours which is important. Afterwards, hydration doesn't matter. So the targets are, MAP should be maintained between 65 to 85. Urine output of 0.5 ml per kg per hour. Blood urea nitrogen of less than 20, hematocrit of less than 44. These are the targets. And invasive monitoring should be done if there is any organ failure or other things. Analgesics, again, we can either use opioids. These are the preferred analgesics, especially in a GI setup, or even NSAIDs can be used for pain relief. What is the role of ERCP in acute pancreatitis? Recently, Dr. Ravinda was telling about emergency ERCP in cholangitis. Yeah, again, if there is a biliary acute pancreatitis, unless there is cholangitis, there is no emergency to go ahead with ERCP. And if at all there is a doubt whether there is a stone or not, you should do EUS or MRCP depending on the local availability rather than doing a diagnostic ERCP, which nowadays is almost obsolete. So patients comes with pancreatitis. So which antibiotic do you use, or do you use antibiotic at all? No antibiotic. Good. So there is no role of prophylactic antibiotics. It should be given only if there is extra pancreatic infection. So there is no pancreatic infection within first 1 week. Pancreatic infections develop in late 3rd week or later than that. So usually, if there is extra pancreatic infection like cholangitis, catheter-acquired infections, or bacteremia, UTI, pneumonia, thrombophlebitis, these patients you can give antibiotics. However, per se pancreatitis, there is no role of antibiotics. Even if the patient has severe acute pancreatitis, there is no role of severe acute pancreatitis, there is no role of antibiotics. Even if there is tachycardia, don't give, because that is usually SIRS response, systemic inflammatory response. Don't give antibiotic. Necrosis, we should use the antibiotic which penetrates into the pancreas, not just any other antibiotic. The preferred one are carbapenems like meropenem, imipinepilum, cilastatin, quinolones, or metronidazole. These are the preferred antibiotics. So patient with infected pancreatic necrosis. How do we know infected pancreatic necrosis? You can see those red arrows. So there is necrosis and some air bubbles. So those patients have infected pancreatic necrosis, or clinically you should suspect. Just because it is tachycardia or leukocytosis, we should not start. So, and routine use of FNA just to confirm the diagnosis whether it's infected, there is no role. So elevated CRP, WBC, or procalcitonin alone should not be used as biomarker. So we should always look clinically or radiologically. Again, antifungals, just because you are given antibiotic, the patient is not improving, you should not use unless you're exhausted of other things and you have other culture positive or other things. Many times people also use probiotics. Again, there is no role of probiotic in managing acute pancreatitis. Nutrition, when to start? Again, this is a very important thing. Patient with acute pancreatitis, most of the time we see patient is on Riles tube, CRTA. Patient is NPO for 4 days, 5 days. So how long should we keep them NPO? So basically, like in mild acute pancreatitis, oral feeding should be initiated earlier the better, earliest. If there is no nausea, vomiting, and once abdominal pain is resolved, even on day 1, please start nutrition. There is no point in doing pancreatic rest or anything. There is no role. In fact, early nutrition is going to decrease the morbidity and mortality. And we can either start with liquid diet or low fat diet. There is not much difference. Again, you always start with liquid diet and these things. Yes, that is a thing, but there is no role. Again, in severe acute pancreatitis, enteral nutrition is recommended to prevent infectious complication. If patient is not tolerating, you can give nasogastric or nasojejunal feeds. Again, difference between NG versus NJ, there are many studies from AIIMS, St. John's, and multiple places. There is no difference. Previously, people used to think you would do NJ, there is pancreatic rest, so it will improve. Absolutely no. Unless there is a duodenal obstruction or patient has a refractory vomiting, there is no point in giving NJ feeds. NG is good enough. Parenteral nutrition, unless enteral route is not available or not tolerated or is not adequately taking orally, only then give parenteral nutrition. Otherwise, there is no role. Again, indications for interventions in acute pancreatitis, unless there is an infected pancreatic necrosis or infected necrosis and not doing well with antibiotics, only then intervene. Also, even if there is a sterile walled off necrosis, if they have recurrent abdominal pain, or there is biliary or luminal obstruction or nutritional failure, even without signs of infection, we should do intervention. So we should not just because there is a pseudocyst of 6 centimeter, we should not intervene. It should all depend on the symptoms. So the mantra in managing, especially necrotizing pancreatitis, is delay, drain, and debride. Previously, people used to do direct surgical necrosectomy. I think Dr. Neil is here with us and Shri Shai. So they agree. Nowadays, the thing is we always try to manage conservatively, delay, because there should be good wall formation. Early surgical necrosectomy has got very high morbidity and mortality. Delay, that is wait for at least 3 or 4 weeks for the collection to become walled off or mature. Or the first thing is, so if they have, again, drain the necrosis or infection, either transluminal by endoscopy or percutaneous if possible.
and debrided only if none of them help, and minimally invasive endoscopic or surgical management again. So role of surgery in acute pancreatitis. In mild acute pancreatitis, that is biliary pancreatitis, gallbladder cholecystectomy can be done just before discharge. In severe acute pancreatitis, because of biliary causes, they can wait till the pancreatic inflammation subsides. So newer drugs in acute pancreatitis, again, people have been using all these things: ulinastatin, gabaxate, somatostatin, octreotide, PAF antagonists. However, as per the evidence, there is no evidence for these things. These are all or placebo things. There is no role as per the recommendation. Coming to last few slides, management of late complications. What are the late complications? That is pseudocyst, walled-off pancreatic necrosis, GA bleed can be early also, and pancreatic ascites and pleural effusion. So pseudocyst, the management depends on the symptom, not the size. Previously, when we were undergraduate, we were still taught more than 6 centimeter, either you should usually drain. However, even if it's 10 centimeter, if patient doesn't have any symptom, we don't do anything. It's a symptom. Modality, pseudocyst can be drained either endoscopically, percutaneous, or surgical. However, this is how the pseudocyst looks on CT scan. It's a clear fluid. And this is what we usually do, endoscopic ultrasound guidance. So this is a pseudocyst you can see. First, we put a Doppler, US guided, to make sure that there are no vessels. So this is then it's been punctured. So once we puncture, we draw the fluid, send it for analysis, including culture. At the same time, put guide wire. Once we put the guide wire, we put a cystotome, and here you can see the CRE balloon being inflated. So in the cystogastrostomy site, you inflate the CRE balloon. This is how we do endoscopic cystogastrostomy. And then once you dilate to almost 1 centimeter or something like that, then you place 2 stents. This is the first stent being placed. And then we place another stent. Usually we place 2 plastic stents. So this is if the collection is liquidy, that is cirrhosis, everything will come with the plastic stent. However, if there is necrosis, these stents will not help. So this is other, and we usually place a stent. So when do we think of percutaneous or surgical drainage of pseudocysts? So when the pseudocyst is in the paracolic gutter or it's away from the stomach or duodenal wall, however, it has got high morbidity compared to endoscopic method. But if it is not accessible endoscopically, we have to look at surgical option or percutaneous option. Coming to the walled-off pancreatic necrosis, what happens in pseudocyst? Pseudocyst, the fluid is like water. In WOPN or walled-off pancreatic necrosis, it's a thick fluid or sometimes necrotic debris. Again, the drainage depends on the symptom, not the size. So unless patient has symptom, there is no need to drain. Modality is similar to thing. So this is one of the patients with necrosis, and you can see some air bubbles as well. So previously it was open necrosectomy. Now it is minimally invasive intervention. So this is what we do. Instead of putting a plastic stent, we can place a metal stent. So you can see in the diagram. So there is a metal stent between the stomach and the WOPN. And later through the metal stent, go into the necrotic cavity and remove the necrotic debris. However, this is not one time. You may have to go recurrently into the necrotic cavity and keep doing necrosectomy until it is clear. But yes, it is minimally invasive. So this is another patient which necrosectomy was done. And this is now something new, which is called hot axios or lumen opposing metal stent. You can see this is a US guided. Here it's a metal stent. You can see the sheath coming out and the puncture. So here, once we puncture, you directly put the metal stent. In the previously, we were puncturing, dilating into the 1 centimeter and then placing plastic stent. Here you can directly put the metal stent. So you just insert it, and then you have distal flange is deployed. So this opening will be there in the within the necrotic cavity, and another end will be in the stomach. So here, thick necrotic material will come, as well as you can go in and do necrosectomy. So this is, I think Neil Shetty will be speaking on percutaneous and surgical approach. So surgical necrosectomy is the last option. However, it's more complete and one-time compared to other modalities with higher morbidity and mortality. Coming to the last thing, GI bleed in pancreatitis can be due to multiple causes: NSAIDs, retching causing malarious lesion, hemosuccus pancreaticus, splenic vein thrombosis leading to fundal varices. This is one patient with hemosuccus pancreaticus. You can see blood coming through the pancreatic duct, through the ampulla. That was because of the splenic artery pseudoaneurysm. So the treatment here is interventional angioembolization of the splenic artery pseudoaneurysm. Pancreatic pleural effusion or ascites, whenever there is a pleural effusion and it is not, all pleural effusion is not due to tuberculosis in India. If the person is not responding, please do look at pancreatic causes, and also include pancreatic fluid, pleural fluid or ascitic fluid amylase as a routine in your fluid analysis. That is going to help. So what we did was just placed a pancreatic stent, and then it all disappeared. To summarize, acute pancreatitis is a medical emergency. Early moderate fluid resuscitation with RL, 1.5 ml per kg per hour, and early enteral nutrition. These are the only two things which are going to decrease the infectious complications, morbidity, and mortality, not the new drugs. There is no role of prophylactic antibiotics, both in mild as well as in severe, acute, or necrotizing pancreatitis. Consider contrast enhanced CT only if there is clinical diagnosis is in doubt or in severe acute pancreatitis to prognosticate. Delay, drain, and debride is the mantra for managing necrotizing pancreatitis. Endoscopic guided procedures are helpful in managing complications of acute pancreatitis, and intervention radiology and surgical options are considered in select group of patients. Thank you.
Any questions from the audience? Sir, when we were PGs, we used to tell in mild as well as severe pancreatitis, you cannot change the mortality because in mild case anyway, nothing is required. Severe cases, whatever you do, patient will die.
No,
mortality doesn't change. Only moderate cases with good management, you can change the mortality. What is the current standard?
Our aim is to prevent severe acute pancreatitis. So yes, even if they develop severe, decrease the morbidity by giving adequate fluid hydration. What happens is when the early first 3 days, when you don't give them adequate fluid, that is when the pancreatic inflammation increases and the complications happen. And also early enteral nutrition. This is the most important thing which can decrease the infectious complications as well as morbidity and mortality. As we told, once patient is pain-free, say even in day 1, you can start them orally. There is no need to keep them NPO or CRTA for 3 days, 4 days. So previously there was a concept of pancreatic rest. You give rest to the pancreas. So you be nil orally, give rest, then inflammation subsides, then we start orally. Now the victim is early enteral nutrition. So.
Are there any data to show that you can really prevent this severity?
Yes, definitely. I mean, it's not about severity, it's about the complications.
Complications.
So you can predict severity by various methods, but definitely you can prevent the complications of any pancreatitis.
What is the role of PPIs in this?
PPIs has no role. Again, it may increase the worsen infectious complications because it decreases the acid in the stomach. So that is one thing. Again, I want to tell all patients you need not give PPI. Yes, if you are giving NSAIDs instead of opioids and you want to cover it with PPI, maybe fine. Otherwise, just because patient has pain, there is no role of PPI. Or when the diagnosis is in doubt, you don't know whether it's ulcer. Yes, it's justified. Otherwise, there is no roles.
Patients with comorbidities like diabetes, hypertension, IHT, with acute pancreatitis, the role of this medication, will it change? Or what is going to be the outcome when these patients have comorbidities?
See, outcome in the sense if they have cardiac failure or CKD, you cannot give aggressive fluid or even moderate fluid. That time, it should be goal-directed therapy. You have to look at IVC collapsing, all those things, and you should be cautious in giving fluids. Otherwise, in general, you should be you should look at all the parameters and give adequate fluids.
Diabetic patients with obese patient, how do they respond compared to a
See, they are all adverse prognostic factors. Yes, they are at higher chances of developing severe acute pancreatitis or other complications, but management will not change.
It will be the same.
Yes.
Sir.
Yeah, same thing. Yes, sir. We always think octreotide decreases inflammation. However, as per the data, there is no scientific evidence to suggest octreotide in every acute pancreatitis. Yes, in pancreatic ascites and other complications, there is some role. But in acute pancreatitis per se, there is no role of octreotide or somatostatin.
So last question. You had taken this patient on 7th day. Whatever you presented, that 45-year-old man, if I'm not wrong, serum amylase start decreasing by then and lipase rises. It's in between. Still you want to wait, have a 3 times rise, or can you?
So that's a very good question. You are right. Usually amylase starts first and comes down first. Lipase usually starts later and comes down later. That is the reason we always do both amylase and lipase. And up to 7 days, usually these enzymes are elevated. And yes, along with that, if there is sonology or other imaging evidence, then we think it is pancreatitis. Otherwise, just because, okay, this is fine. But otherwise, most of the time, we always see patients being branded as acute pancreatitis just because amylase and lipase, even if 1.1 time, 1.5 times, 2 times elevated, we should not brand them. That is the basic message I wanted to.
In a biliary pancreatitis with obstruction, and it is a severe pancreatitis. So when to intervene, and any other option other than ERCP?
Yeah, this is a very good question. There are various meta-analyses, randomized control trials. They have shown that there is no difference between emergency less than 24 hours versus later than 24 hours unless there is cholangitis. But in our practice, yes, earlier it is better. If they are fit for ERCP, we do go ahead with ERCP if there is a evidence of bile duct stone. Otherwise, if there is doubt, sometimes whenever there is pancreatitis, that means the stone has already come to the ampulla. So majority of the times when there is biliary pancreatitis, stone will not be there in bile duct. So we always do an endoscopic ultrasound, or if not available in other centers, they can do MRCP and make sure that there is no stone. Just because there is pancreatitis and LFT is deranged, it doesn't mean that there is a stone. In fact, we have done more. We have abandoned many ERCPs
Imaging is
because
showing
of US.
stone, sir. That is the
Yeah,
confusion.
if the
Even
imaging,
with organ failure, it's a severe one. So
yes,
when
you
to
go ahead
intervene?
with ERCP, but there is no difference between urgent versus non-urgent. But usually we do earlier, it is better. But as per the studies, yes, there is no difference whether you have to do within 24 hours or after 24 hours.
Thank you.
Thank you.
Most challenging part in managing acute pancreatitis is the pain management. It's a pain management. You have anything like what if?
Sir, due to
Yeah,
constraints in the time, please, we'll stop this
Thank
topic
you.
and we'll discuss during the dinner time.
So thank you.
Thank you, sir. I would like to call upon Dr. Arjun Rao to felicitate the speaker. I request the moderators to remain for the next talk. I call upon Dr. Satish HR to join the moderator table. Pain is the language between body and practitioner. Eliciting it and relieving it are the priorities of any man trying to decode the clinical secret to give us an overview of the complications and their management in acute pancreatitis.
So a very good evening. I'd like to thank Dr. Pradeep and Susha, the hospitals, for this opportunity to present here. We've had a lot of very interesting talks today. You've had a lot of eminent people who have given you insights into liver, into luminal GI, and now we're coming into the pancreas segment. So basically, I'm a surgeon. So you're going to look at it from my world now. Till now, you've seen how we diagnose. Till now, you've seen what are the medicines. But I'm going to show you stuff which is seen in the operation theater. So it's much better to see rather than to learn by going through theory. So I'm going to present a case to you. 32-year-old man, he was referred to me from a hospital outside with a diagnosis of acute necrotizing pancreatitis. Now he is 4th day post-onset, which means from the onset of the pain. So in pancreas, there are a few things which are very, very important. When you take a history, you need to find out when did the pain start, not when he was hospitalized. Hospitalization has nothing to do with pancreatitis. When did his pain start? Your clock starts ticking from the onset of the pain. So this man is 4 days post-onset. He's already in multi-organ dysfunction mods. So he has ARDS, respiratory failure. He's already on the ventilator. He has acute renal failure. He's already on dialysis. He's hypotensive and he's on multiple pressors. So now you've got 3 organs down within 4 days. So this gentleman automatically goes to the ICU. Slowly he improves over the next 10 days. And what we have done to improve him, that Dr. Adarsh has just spoken to you. In the course of his treatment in the ICU, he develops pulmonary thromboembolism. He has extensive venous thrombosis. We have to have a dialysis catheter. We're having trouble trying to put it in because he's thrombosing. He's deteriorating. His counts are going up. So we do what is known as a step-up approach. I'll come to this later. But anyway, you're going to drain this necrotic pancreas because you need to try and salvage this gentleman. He's not improving. 4 weeks down the line, the ICU team has kept him going. And now we have come to the point where we can do something surgical. So we're going to do a laparoscopic pancreatic necrosectomy. So this is a typical CT of what you would see in a necrotizing pancreatitis. What you're seeing here is we put an NJ for his feeding. This is a percutaneous drain. You can see a Malicot catheter in a large cavity. The cavity has got multiple gas pockets. So this is typically how it looks like in necrotizing pancreatitis. So this gentleman has now come to the OT. He's on 2 inotropes. He's got pulmonary thromboembolism. I've stopped off his heparin a couple of hours before his surgery. And this is how it looks at laparoscopy. So I'm doing transperitoneal laparoscopy. I'm not doing retroperitoscopic procedure. So what you saw there was the saponification. Now I'm looking towards the head end of the patient from the umbilicus. I'm lifting up the colon and I'm trying to get to the lesser sac through the mesocolon. So here I've made a hole in the mesocolon and now we are draining some fluid. So initially you're seeing something very, very purulent. And now this is the cavity. This is what you saw on the CT scan. This is what pancreatic necrosis looks like. So what you need to understand is it's not just pus. This is dead tissue which does not have egress. It cannot drain. This is tissue which is being activated by pancreatic enzymes. So pancreatitis is basically trypsin activation intracellular inside the acinar cell, which is causing damage. That damage also has a profound element of ischemia. Tissues die fast, they become necrotic, and it's like servicing a car, but you cannot switch off the engine. You have to service the car while the engine is running. So you've got ongoing 2 types of inflammation. You have the local inflammation because of the SIRS response, and then you will come into a second phase where you end up with infection. So this is a double hit for the patient. So this is what typical necrotic pancreas looks like. Coca-Cola colored, black, dirty, and you're working in a cavity where the walls are blood vessels. So you're on the splenic artery, you're on the splenic vein, you've got the entire pancreaticoduodenal plexus of vessels, you've got the vessels going to the colon, and next to you, you have the colon, above you, you have the stomach, to the left, you have the duodenum. So this is a very hostile work environment for us. So while this is going on, what is going through your mind? There are a few things which we have learned in surgery over time. One is, don't go in early. Other is, be very judicious and you're playing for a long game. So this is a cavity. You can see the drain which is there, which I placed earlier. I've done a necrosectomy. I've put in 2 drains. This is a necrosectomy which I have done through the umbilicus, through the peritoneum. I've come from the infracolic compartment and I've gone up to the pancreas. Nowadays, what I tend to do is I try to go through the stomach. So I like to do a transgastric necrosectomy nowadays. So after the procedure is done, I've placed the drains and we would irrigate that cavity. Cavity, we put in IV fluid, we do it under vision. We know how much IV fluid went in, we know how much IV fluid came out. You make sure it doesn't collect in the abdomen. You keep irrigating every day, and here you will see all the muck and the stuff coming out. So this is the surgical aspect of acute pancreatitis. This is an important slide for you to remember. Whenever somebody has pancreatitis, and Adarsh has explained to us clearly how we diagnose pancreatitis, 80% of the time it's mild, couple of days of pain and they go home. 20% of the time they can end up in what you saw. That is for every attack of pancreatitis. It's not just the first one. If a person had recurrent acute pancreatitis, the first attack, no pain, I mean, he went home, second attack, he went home, third attack, he could come into this. So if you have anybody with pancreatitis, you're going to keep this in mind. Each attack, 80-20. So there's a lot of talk on how do we reduce severity. The Japanese groups, they all infuse protease inhibitors through the regional arteries, like for example, through the celiac artery. Most of the Japanese groups do this. None of us follow this. These are the things that they think would reduce the severity. So what we have realized in pancreatitis is, it is the organ dysfunction which is the severity. So a lot of things happen. So when you read literature, especially for the PGs, you have to look at what you're reading. So there was a conference in Atlanta. Prior to that, there was a lot of work by a person by name Bradley. There was a lot of confusion in how we report pancreas. What is a collection? What is necrosis? What is abscess? So they've defined it according to the time of onset, and they defined it as location as well as the presence or absence of necrosis. The only take home here is, if a person quickly goes into organ dysfunction, we are in trouble. So mild pancreatitis mortality should technically be less than 1%. Severe pancreatitis mortality is variable, 8% to 39%, depending on various other factors. Organ failure is the single most determinant of mortality. Pancreatic necrosis, couple of things are there. 15 to 20% of them will develop necrosis. In this, approximately 30% of them will go into infection. So pancreatic necrosis can remain solid. It can liquefy over time. It can remain sterile throughout. It can get secondarily infected. It can persist, or it can spontaneously disappear. 30% of necrotizing pancreatitis will develop secondary infection. So what Adarsh told you is very important. Many people will see acute severe pancreatitis. They'll see one CT severity report. That CT severity report is nonsense. What you have to see is, I've seen so many plain CTs where they say that there's a CTSI of 10. To diagnose pancreatitis, you should have absence of enhancement. Without enhancement, it's called necrosis. If you haven't given contrast, there's no question of non-enhancement. So you have to see who is reported, what is the background, what are we dealing with, because most of these people will be in renal dysfunction. You wouldn't have a contrast CT. So you really don't know unless you're seeing gas in the pancreas or stuff like that. So when you have secondary pancreatic necrosis and you start off, let's say, piperacillin tazobactam in the first week, you are adversely affecting the outcome of that patient. This is probably due to we don't know what we're doing or ignorance, whatever, but it has serious impact. Now, the picture which I showed you was, he started on day 4, but I took him to surgery after the 4th week. That is 1 month. Think about it, 1 month in the ICU. On any corporate hospital, you're talking upwards of 10 lakhs. So survival is equal to your ability to pay also in this disease, because it's expensive. If we run out of antibiotics in the first, second week, because ideally the antibiotic of choice for me is always imipenem cilastatin, good pancreatic penetration. But if I lose carbapenems in the beginning, I'm losing the fight before it's even started. So like others said, there are 2 phases to this. There is the inflammatory phase, which is called the SIRS phase, and then there is the CARS phase, the counter-inflammatory response. Organ failure usually occurs within the first week. Organ failure usually occurs in about 40% of acute severes. Mortality is about 30% in this group. The second phase is the CARS phase. So this is the second leap in the graph over there. So all pancreatitis will cause some inflammation. That inflammation is acute pancreatic or peripancreatic necrosis. So Atlanta has defined as any collection in the pancreas or extra pancreatic is also part of your disease burden. So sometimes you can have extra pancreatic necrosis. Difficult to say whether that really adds to the disease severity, but these are the terminologies that we use. When it is within 4 weeks, within the first month, fluid alone is called as acute pancreatic or peripancreatic fluid. If there's no enhancement, it's called an acute necrotic collection. Typically, necrotic collections are irregular. You don't have a good wall. Once you go beyond 4 weeks, acute pancreatic collections fluid can become pseudocysts or they can disappear. Or if necrosis persists and it gets nicely walled off, you can have it as a WOPN, walled off pancreatic necrosis. So this is the terminology which we'll be using throughout. All of these fluids, all of these necrosis, all of these collections can be sterile, can be infected. So the burden of finding out is up to you, depending on the clinical scenario, the counts, whatever you're facing, procalcitonin, whatever. This gives you an idea. So infected pancreatic necrosis is the most serious problem that we have to deal with. This, over the past 20 to 30 years, the number has been always 30% of all acute severes. So when you look at acute severe, 20% of any acute pancreatitis can become acute severe. In this, probably around 30% will go into necrosis. In this, probably another 30% will get infected. So as you go, you will have a subset who are very, very sick. The peak incidence of necrosis with infection is usually in the 2nd to 3rd week. Typically, you would suspect it when you've treated the patient well, but he's not doing well. His sepsis is getting worse. New onset sepsis. You treated it. You thought clinical deterioration, which you cannot explain. Usually, the CT will show you a lot of gas pockets in the collection. So what time has taught us is open necrosectomy has a very high morbidity and mortality. So the whole point is, if you know that it's going to be highly morbid and highly going to cause a lot of death, what do you need to do? Newer approaches. So what have we learned? Delay your intervention. Try to do something else. So the mantra for us is delay, debride, and drain and debride. But how did we reach this point? In literature, there are certain papers which will change your daily practice. Like, for example, carcinoma rectum. Should we give radiation or not? There was a very, very big paper which told us you do neoadjuvant radiation, you reduce recurrences by 20%. It doesn't change your overall life, but it reduces the local recurrence. So now we as surgeons hate radiation, but we are forced to do it. So this paper was a Panther trial by the Dutch Pancreatitis Study Group. And this was quite some time back, probably 2012, where they looked at how to manage necrotizing pancreatitis. So after this, there were further other papers, like for example, you have the endoscopic versus surgical step up. You have also the extension tension trial. These all gave you an idea of how to manage what. So literature for us makes a big difference. So looking at this literature, we realized open necrosectomy is not what we want to do. We want to delay the intervention as much as possible. We want to use some adjunct treatments to help us while we delay this. At the same time, we're going to change our thinking process. So now, what I deal with acute infected necrotizing pancreatitis now becomes multidisciplinary. If the patient goes to the ICU and they've already put him on carbapenems in the first week, by the time I get to surgery, it's multi-drug resistant. There's nothing I can do. So they have to be on with us. Medical gastro has to be on with us. IR team has to be on with us. Surgeons have to be together. So when do we operate? IPN, anybody with sepsis, not responding, and percutaneous drainage is not helping you. Whenever there is a sterile necrosis, but you have other complications like gastric outlet obstruction, duodenal obstruction, whatever, or you have a walled off pancreatic necrosis late in the course, but still you're having sepsis. Other reasons for operating in acute severe pancreatitis would be perforation, bleed, abdominal compartment syndrome, ischemia, and pancreatic ductal disruption causing a disconnected duct syndrome. So now, how would we deal with this patient? We don't want to do open necrosectomy. So we have something which is known as percutaneous interventions. That is, you put in a drain. Or you can try what is known as minimally invasive procedures, or you go for endoscopy. So PCD is what? Put in a drain. So what you're seeing here is you can see a nice tube which is coming there into the necrotic cavity. Just putting the drain is not enough. Somebody has to put the drain, and then you have to wash it, irrigate it, upsize it, make sure it doesn't get blocked. So there's a lot of intense kind of work which needs to be done in this to keep this possible. So invariably you end up putting one drain, two drains, counter drain, upsizing drains, which means your radiology team has to be with you in this. So what we have found is, at least in the Panther trial, 35% of people who are managed with drain alone did not require further interventions. So this is something which you can consider for a patient who's acute severe, who's not doing well. You need to get some time, drain them. So this is how a typical drain looks. The upper picture shows you where the drain was placed. And then later I had used these drains while I'd done surgery for a pancreatic necrosectomy. So what are the minimally invasive techniques we can use? What I showed you was laparoscopic transperitoneal. The other thing you can do is from the retroperitoneum, approach from the left side, get access through CT guidance, use that access track to put in either a nephroscope, a laparoscope, or any kind of videoscope, get in there and debride it. Either some groups, they use literally sponge forceps. Others, they put in two kind of laparoscopic ports and they use an instrument to debride that. So that is known as VAD, video-assisted retroperitoneal debridement. The other way, Dr. Adarsh had shown you a nice video. This is endoscopic management of WPNs. Here, what you're doing is, you've got the stomach anteriorly, you've got the necrotic cavity posteriorly. You need to keep it open, but you need to have a decent size. So we have what are known as lumen opposing stents. So these are lamb stents. So you can do blood vessels in your way, get in, drain, put in a stent, leave it, that's called transluminal drainage, or come back after some time, balloon dilate your stent, go back in, do a necrosectomy through endoscopy. So this is what Adarsh had shown us earlier. This is something that we had done recently. Patient with a large WPN. He was probably about 4 or 5 weeks down onset, alcoholic. So this is what your lumen opposing stent looks like. It's like a dumbbell on both sides. So the dumbbell on the opposite side keeps the cavity open. And then probably about 3 or 4 weeks later, we could have dilated this and then gone and done a necrosectomy through this. Now, the problem here is your stent alone is like 2.5 lakhs. So this has a serious cost implication. And if you see here, we had a very good technical result because you can see the lumen opposing stent. It's going through the distal stomach, coming into the cavity, and you have very little collection left. So this is a very good technical result, but you can't offer this to everybody because it's quite expensive. So just to summarize what we have learned so far, management of the earlier phase is what Dr. Adarsh had dealt with earlier. We've looked at the terminology, we've looked at what are the complications and how we're going to deal with it. Your job here to learn from this is, we are playing the long game. You're going to delay whatever interventions, the surgery or whatever, in the group which is acute severe, in the group which is going to need some intervention later on. You're going to use other modalities like drainage, like endoscopy to buy you some time. You're going to be very judicious in the way you use antibiotics. You're going to have your whole team working with you. You're going to use what is known as a step-up approach. Step-up approach used to be a surgical step-up approach. Now we have endoscopic step-up approaches. And we're going to see more and more of these endoscopic procedures coming in and managing acute severe pancreatitis. Thank you.
Congratulations to sir for the nice presentation. So doubt is endoscopic approach, laparoscopic, transperitoneal versus the VAD. So how will you choose the patient?
I can answer this in different ways. I hate VAD. I hate VAD because 1 in 3 VADs end up with a colonic fistula. So I prefer to go transgastric. I prefer to go transgastric, or I'll go from under the colon. Second is, not everybody can do endoscopic cystogastrostomy. You need somebody who can do EUS. You also need an affordable patient, and the anatomy has to be favorable to you. Many times you have collections, they go all the way up to the left iliac fossa. Sometimes you have collections which come right across to the right side. So endoscopy has got its own plus points, but the problem is many a times endoscopy, you put the drain, but the stuff doesn't come out because it's not fully liquefied. Then your team has to be ready to go in and then do a necrosectomy through the endoscope, because you can't spend 2 lakhs and then expect the surgeons to come and do an endoscopy, because that will double your cost. So if you're going to do a endoscopic stent placement, you're going to have to do necrosectomy if they don't subside. So when you read papers, you realize that sometimes there are re-interventions required after the endoscopic drainage also. So my answer would be all of these interventions are tailor-made for each individual anatomy, each individual clinical situation. The other thing is, I was always under the impression earlier that once you do a percutaneous drainage, you wouldn't do an endoscopic stent, because we always scared about fistula forming from the stomach or wherever you've drained. The Europeans and all, they don't care about this. They'll drain and then they'll go and put multiple stents into the stomach, and they don't form fistulae. So that is also a definite option. Let us assume that there is total necrosis. But let's say that the patient is sitting, having coffee and smiling. We're not going to intervene. It all depends on what you're dealing with, the clinical scenario. Organ failure, not getting better, you've done a decent antibiotic, you've done whatever you can, then you have to decide, is the anatomy favorable for an endoscopic procedure, or do I want to do something surgical?
Thank you, sir. Now, I would like to call upon Dr. Ravish KR to felicitate the speaker as well as the moderators. The common bile duct, a slender thread of life, easily lost, deeply missed. When it's harmed, the body grieves its silence, yellowed and weary. It teaches us that even the smallest pathways carry great purpose, that gentleness in our hands is what keeps the flow of life going. Now, I invite Dr. K. Hemant Kumar, consultant surgical gastroenterology, GI oncology, and robotic surgery at Manipal Hospital, Old Airport Road, Bangalore, for an elaborate look into tackling CBD injury, when, where, and how. I would like to invite Dr. Timaraj Nayak, Dr. Praveen Kumar, Dr. Pooja, and Dr. Sunil Kumar KP to be the moderators for this session.
Sorry for the delay. So just will connect. ಹೋಗುತ್ತೆ pen drive. Good evening, everyone. I take this opportunity to thank Pradeep sir and Sushoda team for this opportunity. So in the next few slides, I will take through what we call as a surgeon's nightmare, common bile duct injury. As we know that bile duct injury is one of the most common cause for highest number of medical legal cases in consumer courts. And it is not because of the complication, because complications are inevitable, but it is mainly because of the delay in the diagnosis and improper management that what leads to increased compensations and replications. So in the next few slides, I will take you through how to prevent these complications and how to handle it so that we don't end up in a soup. As we know, the most common reasons for bile duct injury is iatrogenic, and laparoscopic cholecystectomy being one of the very common surgical procedure which is done in day out day in is one of the most common reasons. And if you look at the incidence is 0.1 to 0.2% in open, and whereas it is 0.2 to 0.6% in laparoscopy. Initially it was higher, now it is coming down with the more number of cases being done. Other surgeries like HPB, complicated surgeries, liver transplantation can also be the reason for bile duct injury, and also a trauma, one blunt trauma or a penetrating trauma leading to bile duct strictures or bile duct injury. And if you look at the reasons, it's mainly not only always the surgeon, it is also because of the difficult anatomy, like difficulty in the anomalies in the cystic duct or the sectoral duct anomalies, because bile duct is one organ which is almost 10 to 20, 30% of the times is anomalous. So various different anomalies can be there, and if you are not well versed, there is very high chances of bile duct injury. And difficult pathology, to say it's like acute cholecystitis. If you intervene at a difficult period time in the not what we follow 48 72 hours window, you will end up in having increased risk of complications. And also in cases of chronic cholecystitis, because of the dense adhesions and a contracted GB, where we see if a ultrasound report showing as a wall echo shadow is indirect and evidence that it is filled with stones and a contracted GB. These are predeterminants where we can suspect that there might be increased chances of bile duct injury, and we can be careful. And Mirige's syndrome also. And in addition to that, a difficult surgeon, especially a casual approach. When we look at, once we place the port and once we look at the gallbladder, we always feel it is a very simple gallbladder and you are in a hurry to finish it off. So that is also one of the reasons where you might end up doing a bile duct injury. And if you look at what causes a difficulty during surgery, especially now we get a lot of morbidly obese patients. So that what's one reason where there might be increased chances because of the inadequate exposure, or an improper placement of trocar so that your traction is not proper, or a bulky hanging falciform ligament, bulky quadrate lobe, and undue speed while clipping and dividing the ducts or arteries, and injudicious use of electrocautery. The electrocautery use whenever there is a bleeding, if you start and going cauterizing everything which you see nearby, you might injure the bile duct, not in the immediate setting, but it might lead to delayed ischemic strictures also. That we need to be careful. If you look at what exactly a classic bile duct injury looks like, it is mainly like this. When we operate, you give a lot of lateral traction where the cystic duct, the bile duct is confused with the cystic duct, you clip and divide and you dissect further, and then again you see some more a tubular structure, you think that there is a double cystic duct, then again you clip and divide with a segment loss of the bile duct. This is what a classical bile duct injury looks like.
And definitely there is a learning curve. Most of the injuries happen in the initial phases of the learning experience, but it doesn't mean that a senior experience surgeon doesn't happen. It is because, again, I said the speed is one of the reason. And this, as I said, that is how a classical injury happens, because of the lateral traction. And in addition to these things, there are technical problems like if you don't occlude the cystic duct, if you don't choose the proper size, most of the times 5 mm clip is enough. But if some patient, if he has a wide cystic duct, if you don't choose the appropriate clip, then also leads to bile duct injury. Or if you pull too much and apply on the bile duct, leading to a side bile duct injury can also be the reason. And thermal injuries, as I said before. And there have been various classification to tell us what type of bile duct injury has happened. So these are the different classification, but the most common in practice is Bismuth's classification, which divides depending upon the length of the bile duct left from B1 to B5. And we have the Strasbourg classification, which from category to A to E5. And this is the one which we commonly use in, so that the standardization, if I say there is a type D injury, so everyone knows that what kind of injury has happened. So as we all know that prevention is better than cure. So there are a lot of techniques which you can use to minimize the risk of bile duct injury by using a 30-degree scope rather than a 0-degree scope, and avoidance of electrocautery near the common duct, and dissection near the cystic duct and GV junction, and converting to open interpretation of anatomy, especially if you have got an MRCP or any scans done before, a correct interpretation will also help in minimizing the risk of bile duct injury. This critical view of safety is one everyone talks about, and there has been enough data to support that if we follow this principle of critical view of safety, almost the chances of bile duct injury will be negligible. And it has been defined by Strasbourg, where the triangle of Callet must be cleared with, as you can see here, the triangle of Callet has been cleared with fat and fibrous tissue. And the gallbladder must be separated. At least we say 30% of the gallbladder should be lifted up from the liver bed, and there should be only 2 structures seen to be entering the bile duct. So if you are able to achieve this during our laparoscopic cholecystectomy, then we are rest assured that the chances of injury are very, very minimal. And the other one is identification of the Roux sulcus. It's almost seen in around 80% of the population. So as you can see here, when we put the port, we know where there is a Roux sulcus. So all your dissection should be above this line. So we have something called as an R4 line also, Roux sulcus to segment 4. You draw a line and your dissection should be above that, so that you know that you're not going into the bile duct and injuring it. If you follow these 2 principles, the chances are less. And then there is something called as culture of safety in cholecystectomy. This is very essential, especially for the younger surgeons, to follow these principles, because as I said, one bile duct injury in career, it is a stain for the rest of life kind of a thing. So in the culture of safety, we speak of establishing a critical view of safety and understand the potential for aberrant anatomy in all the cases, and make a liberal use of cholangiography if you are well versed with using it intraoperatively, and to consider intraoperative timeout during cholecystectomy prior to clipping, cutting, and transecting. This is very essential. So before you put a clip, you stop, you ask your resident, because the most common reason is not the type of surgery, it is mainly because of the visual misperception. So we always do, we just take a time out, you ask the residents or whoever is assisting you, is it fine, is it cystic duct, something like that, so that they also, because the way we look at is entirely different from the other person. So it is always better to stop and then clip before you apply any clip and divide structures. And if it is difficult, always call for help. And if you practice in a multi-disciplinary team or anything, it will be very useful. Why we talk so much about bile duct injury is because of the impact it causes both in the short term and long term. If you look at the short term complications, it can go from biloma to biliary peritonitis with sepsis, multi-organ failure, biliary fistula, cholangitis, liver abscess, and even death. And long-term complication leading to biliary strictures, intrahepatic stone, secondary biliary cirrhosis, and portal hypertension and end-stage liver disease. And coming to the clinical presentation, how do we know that there has been a bile duct injury has happened? It depends upon the type of injury, and we can detect it at 3 stages. One is during surgery, we can know that there has a bile duct injury, and the other one is immediate post-op, and the third one is delayed presentations. At surgery, we know that the gallbladder bile is more of a greenish bile, whereas the bile duct bile is more of a golden yellow. If after surgery, if you see any golden yellow bile coming somewhere from the hilum or somewhere, think that there has been an intraoperative bile duct injury. Then depending upon coming to the management, I will tell you how to address it once we diagnose it. And we can use if you use intraoperative cholangiogram also, then also you can identify if there is any bile duct injury. In the immediate post-operative period, it is depends upon whether there is a bile leak or a occlusion, whether they have just clipped it or whether they have just divided it. It also tells us depending upon the presentation. In the post-operative period, as you know, laparoscopic cholecystectomy is kind of a daycare surgery where the patient should be up and about the next morning, eating, having coffee, all those things. If you see your patient on day one not comfortable, then the first thing which has to come to your mind is bile duct injury, nothing else. So if you have placed drains, that is one of the bile starts coming in the drain, then we can know that there has been a bile duct injury, or any subtle signs, patients not being comfortable. And if there is an anatomical abnormality and if you have divided only a sectoral duct, the patient may not present for months together because the liver might go for an atrophy, but that can be only detected with imaging. And long-standing obstruction can present with secondary biliary cirrhosis or hypertension. How do you manage? Once we know that there is a bile duct injury, how do we manage? To manage, it requires a careful planning and a thorough investigations and patient preparation. And we need to address these 5 questions before we contemplate definitive management. One is there any subhepatic collection or an abscess? Is there any ongoing bile leakage? And what is the level and extent of injury in the biliary tree? Are there any associated vascular injuries? And is there any evidence of lobar atrophy? This is very essential so that we can plan the management, when to intervene, when not to intervene, and what kind of surgery we are going to do. All depends upon these 5 parameters. And to help address these questions, we have different investigations coming to our help, starting from simple ultrasound to MRI scans. A duplex ultrasound will give a plethora of information, especially in the immediate post-operative period. It will tell us whether there is any intra-abdominal collections or about the even vascular injury status. And in the delayed cases, it might tell the intrahepatic biliary radical dilatation. And CT scan in the immediate post-operative, if there is any intra-abdominal collections or any vascular injury, this information also can be got from CT scan. And the one more scan is HIDA scan. Occasionally we use, is mainly used to establish biliary entry continuity, especially day 1, day 2, some bile is coming. You want to go ahead to do an ERCP, but ERCP is invasive. Then you want to know whether it is just a partial injury or something like that. Then we can go ahead with the HIDA scan to see that whether there is any biliary entry continuity so that we can plan the further treatment. Then we have endoscopic retrograde cholangiography. This is diagnostic and therapeutic in some cases, especially it will tell us if there is any partial type D kind of injury or a type A kind of injury. It will tell us to localize what is the site of injury, and we can manage also by using endoscopy technique. And if you ask one gold standard in investigation in biliary anatomy and biliary duct strictures and injury is MRI scan, which is a non-invasive one, and it will completely help in evaluating the biliary system, both proximal and distal to the injury, and also any associated intra-abdominal injuries, intra-abdominal collections, vascular injuries, and even liver ischemia can be detected. And it is one investigation which yields anatomic detail in the immediate preoperative period and also can be helpful in post-operative management or follow-ups. Coming to the treatment, it all depends upon the method and timing of the repair, depends on the extent of injury and also expertise of the operating surgeon and team, and amount of acute inflammation in the area and the hemodynamic stability of the patient. A complete detailed diagnosis and associated vascular injuries should be achieved before attempted repair. And the most appropriate management of bile duct injuries depends on the type of injury and the time of diagnosis. So as I said earlier, if we detect intraoperative, what should be done? So if there is a bile duct injury and we see some bile coming from the hilum, what has to be done? So if you detect intraoperative during surgery, it depends upon the experience. If you are an experienced HPB surgeon who has been regular in managing these kind of cases, then it is better to do an immediate primary repair. Or if you're an inexperienced surgeon not dealing with these kind of cases, it is always better to put multiple drains and refer to the highest center. Why it is important? Because it has been proved beyond doubt, and there have been enough evidence showing that the repair done by an experienced surgeon has got better outcomes. And you can, if you plan to do, then we can do an intraop cholangiogram. Because the aim of the initial repair is to maintain the ductal length below the hilum and also to avoid an uncontrolled postoperative bile leakage. And repair definitely is difficult because it's most of the times an undilated duct, and referring to a specialist is more important and crucial, because each failed repair is associated with some loss of bile duct and the strictures goes up. A type 1 stricture can become type 2, type 2 can become 3, type 4. So every failed attempt at repair worsens the patient's condition. So it is always the first repair is the best repair. So you have to be very careful if you plan to attempt it. When we speak of the surgical technique which we can do in the immediate surgical repair during the surgery, one is we can do if it is a complete transaction, you can do an end-to-end repair over a T-tube, or you can do a Roux-en hepaticojejunostomy if you are well versed with it. And among the two, always Roux-en hepaticojejunostomy is better, because end-to-end anastomosis has got the highest stricture days. Again, you need to do a repeated dilatations, all those things. What if you diagnose in the immediate postoperative day? If you diagnose in day 2, day 1, or day 3, what has to be done? How do we know? It is mainly the clinical clues. If you have placed a drain, you can see the bile in the drain, or the patient, if he is not settled, when you investigate and find out that there has been an injury, then how to manage it. It all depends upon whether it all similar to the previous cases of necrosectomy. It all depends upon the clinical condition of the patient, with the aim to make it a controlled biliary fistula if the patient is hemodynamically stable and has a biloma, and to improve the nutrition and keep the patient sepsis free, and attempt the definitive repair at a later date after 4 weeks or 6 weeks. Or if the patient has biliary peritonitis sick, then you have to do a laparoscopic lavage or a laparotomy lavage, drain it, and again make it a controlled fistula and come back. Never attempt, or don't try to attempt doing it in day 2, day 3, because acute inflammation itself is a risk factor for increased risk of recurrence and strictures. What has to be done if you diagnose at a later stage? If some patient has been referred to you after 6 weeks, 8 weeks, or 2 months with an established stricture, then it is relatively easy. We can go ahead with doing a Roux-en hepaticojejunostomy. Or if there is any lobar atrophy or a sectoral duct injury, you might have to do a hepatic resection with reconstruction. And in very, very rare stages where the patient has already secondary cirrhosis, then you might have to do a liver transplantation also. So the treatment varies from simple ERC stenting to major liver transplantations. A word about vascular injury. This is also when there is a bile duct injury. If you look at the incidence of concomitant vascular injury, it is almost 7 to 32%. And this is one area most of the times you miss. It is very important not to miss, because the outcome of your surgical repair depends upon also the risk of vascular injury. And right hepatic artery is the most commonly injured one, and it results in bile duct stricture. And it is very important. If you don't recognize it, you will end up having high risk of stricture rates. This is how the injury happens. When there is a bile duct injury, you will do a small cut in the hepatic artery, which may present with a pseudoaneurysm and bleed at a later date. So if you look at the factors influence the surgical result: concurrent cholangitis, external biliary fistula, intraabdominal abscess, multiple prior attempts, and end-to-end anastomosis, and surgeon experience and associated vascular injury has come with a poor outcomes. And a word about endotherapy is definitive in type A and type D injuries. I'll just take you through a case which we recently managed, who has been referred to us from Haveri. So he was a 75-year-old gentleman. He came with diffuse abdominal pain with vomiting for 2 days to ER. He had underwent a laparoscopic cholecystectomy and ERCP in the same sitting on 13th of May. And post-operatively, there was a worsening of the liver function with a biliary output from the drain. He referred to us. On examination in ER, he was tachycardic, hypotensive, and icteric. There was a diffuse tenderness in the abdomen. His counts were relatively on the okay side, but his serum bilirubin was 14 and albumin was 2.5. We got an MRCP done in the immediate post-op. It was day 2. It showed normal liver with no IHBRD, and there was a 5 into 1 centimeter collection and a normal CBD and 4 mm diameter. But so by looking at the MRCP, it looks like just a small collection. You can put a pigtail and you can manage. But his clinical condition was worsening. Take for laparoscopic lavage and do the proceedings. As you can see here, when we put the camera inside, though the MRCP findings were entirely different, the abdomen was completely filled with bile, as you can see here, and dense adhesions in between. So we plan to convert it open. Though, so we should not be misled by the immediate imaging reports. We have to keep always the clinical condition in our hand. So we did, so intraoperatively this was a distended stomach and dense omental adhesions and almost 1 liter of bile. As the bowel was dilated, distended, and we didn't have much space, we converted to open, and we did a thorough lavage and we placed multiple drains to make the patient sepsis free and to make it a controlled fistula. Post-operatively, he was shifted to ICU and then allowed orally. So his bilirubin started coming down from 14 to 7, but again on day 10 it started again increasing. So in view of persistent hyperbilirubinemia, we got a repeat CT done to rule out is there any bile duct stone, because the ERCP was attempted outside. We thought whether we are missing any bile duct stones, but again MRCP, the bile duct was normal. We got a CT done, it didn't show much, it had only collection. Then we thought we'll do an ERCP because the bilirubin was not coming down. The patient's relatives were very apprehensive. We did an ERCP. The cannulating the ampulla, the guide wire was found to be outside the bile duct. They suspected it may be a duodenal perforation or a duodenal diverticula. Then the procedure was abandoned and the patient was shifted to ward. On day 13, the patient was doing well with a controlled biliary fistula, was on normal diet, but had a drain output of almost 400 ml, and he was planned for discharge. When we planned for discharge at 12 p.m. after the initial morning rounds, the daughter came running saying that there is a blood in the drain. Then we had to go rush him. He had tachycardia, but there was no hypotension. We resuscitated him and immediately we shifted him to get a CT angiography. As you can see, the CT angiography showed a pseudoaneurysm from the right hepatic artery. The patient was having tachycardia, but he was fine. So you can see there is a blood in the drain. So there was a 18 into 14 mm pseudoaneurysm arising from the right hepatic artery. We immediately rushed him to do a hepatic artery stenting. As you can see here, there is a contrast pooling here. We attempted and did a right hepatic artery stenting. Then the patient was shifted to ICU for monitoring. Then he was allowed clear liquids. On day 16, we removed the ADK drain and he was discharged with the JP drain and Romovac drains. And after that, patient was regularly coming to follow up, but he had a persistent hyperbilirubinemia with undilated ducts. So it was very difficult for us to correlate. The bilirubin is not coming down. The biliary tree is also, we expect it to stricture and the bile duct to dilate, but nothing was happening. So then we got a HIDA scan done to look for the bilioenteric continuity. There was no bilioenteric continuity. All the bile was coming inside the drain. And we got a liver biopsy also to rule out whether there is any pre-existing hepatic disease, but there was no evidence of any cirrhosis at that point of time. 3 months post follow-up, the patient had a controlled biliary fistula, eating well, all those things, but there was a persistent hyperbilirubinemia, undilated hepatic duct. Very difficult call whether to intervene, whether to operate, and because the patient was fed up by that time having that bile drain. So we discussed in detail, and then we contemplated to do a Roux-en-Y with hepatococcygeostomy. As you can see here, so that was the stricture. We could cannulate the right and left hepatic duct. We got an MRCP done. It was a type 3 stricture. Then we did a Roux-en-Y hepatococcygeostomy. Post-operatively, the patient was allowed orally and his bilirubin started coming down from 10 to 5, but he went into liver decompensation. There was an ascites, hyperbilirubinemia. Again, his bilirubin went up to 15, 20. We managed conservatively with pigtails, all those things, and he was discharged on day 11. Now, this is the latest follow-up on 3rd October. His bilirubin has come down to 2. He's fine. He's doing well. So the take-home message is prevention is better than repair. Critical view of safety is our best insurance. If in doubt, stop and seek help. In difficult cases, opt for subtotal cholecystitis and early diagnosis and referral to experts will definitely improve the outcome. And a simple bile duct injury will make. And as I said, this patient has underwent, you name the complication, he underwent through all those complications. So a 75-year-old patient, a simple laparoscopic cholecystectomy going wrong and enduring not only the mental harassment, the economic, all those things is a really nightmare. So prevention is better than cure. That's what I want to say. Thank you very much for your patient hearing.
Very nice talk, sir. And indeed,
you.
it's a nightmare for every surgeon
Yeah.
who has CBD injury. Due to want of time,
Sure,
we'll
sure.
be moving to next session. Next talk, please.
Thank you, sir. I would like to call upon Dr. Pradeep Kumar to present the memento for the talk. I request the moderators to remain for the next session.
ಬರ್ತಾ ಇದೆಯಾ? ಇವ್ರನ್ನ ಕರೀರಿ. ಕರೀರಿ ಸರ್.
Endoscopic ultrasound is where vision meets depth. It allows us to see beyond the surface, to listen to whispers of hidden organs, to trace shadows before they become storms. It's a marriage of precision and perception, turning curiosity into clarity. In its quiet hum, it reminds us that progress in medicine often begins with courage to look a little closer. I now invite Dr. Ravindra B.S., Senior Consultant Medical Gastroenterologist, Fortis Hospital, Bangalore, for a talk on the role of endoscopic ultrasound in pancreatico-biliary diseases.
Good evening, everybody. I think we are running late by 1 hour. I think there is an instruction I have to finish in 12 minutes to 15 minutes. Let me just share. See, everything has changed. From open surgery, we have become laparoscopy, laparoscopic to robotic, from robotic to no surgery. I think that's what is the thing which is going to happen. I think there are many changes which are happening. We thought MRI is the best, PET scan is the best. Now we have a modality which is better than MRI scan or a PET scan. This is known as an endoscopic ultrasound. See, this is how we do. We use the same technology. That is how we do. The endoscope goes here. We can see the endoscopy here and then ultrasound on this side. These are the various endoscopic ultrasounds which are presently in the market. My work is half completed because Adarsh and they have already spoken. Because my work is endoscopic ultrasound in pancreatic disorders. We all know now pseudocyst drainage is mainly done by endoscopists rather than surgeons. Because pseudocyst is a completely management by endoscopy room, no role of surgery almost in pseudocyst. Coming to the WOPN, 70% can be managed by gastroenterologists, 30% to be managed by surgeons. Because now, as Dr. Adarsh showed, one of the stents that is known as a hot axio stent, even though Dr. Neil is not here, now Chinese are coming up with a new hot axio stent, 2.5 lakhs will become 50,000 rupees, and then pseudocyst drainage can be done in 3 minutes, 4 minutes. Surgeons will take 2 hours, recovery takes 1 week, whereas entire procedure will happen in 1 day, next maximum 1 or 2 days patient will go home. And then these are the various endoscopic ultrasound. Without endoscopic ultrasound, I don't think pancreatic disorder can no more be managed. Pseudocyst needs endoscopic ultrasound. Pancreatic necrosis needs endoscopic ultrasound. Pancreatic cancer, cystic neoplasm, and even we have taken away anesthetist job also. For celiac block, anesthetist used to do celiac block. Now we do in 5 minutes celiac block, so that which can be done. Can even manage double pseudocyst also. This was in fact sent by our surgeons. In these, see, there are 2 pseudocysts. In both the pseudocysts, see, first one we are draining. Just like surgeons, we are making a big hole. This is the first pseudocyst. Same time we are draining the second pseudocyst up. Both the pseudocyst drainage, 4 stents placed, and then patient becomes better. Because if they want to do surgery, they have to attach at 2 places. Now we can do both together at 2 different places. At the fundus we are puncturing, at the antrum we are puncturing, 4 stents placed, pseudocyst drainage done. Now I think this is, they showed the metal stent. I will show you how after metal stent we do. See, once this metal stent is placed, after if there is a block, this is how we do. We go in and then we do necrosectomy, what surgeons do. This in fact was sent by the surgeons only because this was a very old lady not good for a intervention. See, this is how we remove the debris, and then we slowly remove the debris, and then we use hydrogen peroxide in very small cases wherein we use hydrogen peroxide to remove entire. See the entire necrotic cavity you are seeing from stomach, we are entering into the cavity, and then the whole stent. Now we are going to remove the stent. This is how a stent being removed and entire necrosectomy done without surgery. Somebody were asking where we should be doing endoscopic necrosectomy. If it is only in the head, in the pancreas, we should do necrosectomy. Both side, if they are going right side, left side, both side necrosis is going, that should be sent for surgery because they can do one time. That's how it is done. I think this we have already seen hot axial stent. Now I told you pseudocyst from surgery it has become almost endoscopic method, and then necrosectomy 70% done by endoscopists, and then 30% will be done by the surgeons. And then now pancreatic cancer. For pancreatic cancer, CT scan and MRI remains the gold standard. All of you sitting in the room, all of us, we used to send CT guided biopsy, but CT guided biopsy is very inferior because you have to go through stomach and all these things. See, now very easily you can go in. See, this is a pancreatic tumor. Just put a needle. In 5 minutes, biopsy will also come because pathologist will be there inside the room. He will say that biopsy, it is cancer or non-cancer. This is the beauty of endoscopic ultrasound on-site pathology. Now we have a new instrument wherein just you need to put these slides inside, and then there is an artificial intelligence which will say that this is probably malignancy. Sometime pathologists also will be out of job. I think sometime radiology and pathology department, these two things will go into vain almost, because very recently we had a machine which was brought to our hospital. You just put the biopsy inside, it will show that it's a malignancy, which we recently used in one of our cases, in one of our conferences. I think Pradeep was there in that. See, now we have an endoscopic ultrasound for cystic neoplasm. Whenever there is a pancreatic cyst, this can be 4 things: serous cystadenoma, mucinous cystadenoma, IPMN, and then as Dr. Adarsh and Neil Shetty showed, pseudocyst. For a pancreatic cystic neoplasm, first investigation is CT scan or an MRI, but CT scan MRI will always give a confusion. That's when we see this is a cystadenoma which was sent for surgery. And when we did an endoscopic ultrasound, this doesn't need any surgery at all because this was a serous cystadenoma. See, this is the beauty of endoscopic ultrasound. See, now everybody can see what CT scan is showing, what the EUS is showing. This is a serous cystadenoma. This doesn't need surgery. Patient just needs an observation. This was sent for a endoscopic ultrasound. See, this was a young lady who came just before marriage, and then somebody told it's a cancer. And then this was an endoscopic ultrasound which was done, mucinous cystic neoplasm, and there are some mural nodules. Very beautiful. You can see the very good CT on this side. On that side, you are seeing an endoscopic ultrasound, how beautifully you can see it. And then this was in fact sent for a ERCP, thinking that it was a pancreatic duct stricture. But when we did an endoscopic ultrasound, this turned out to be an IPMN tumor. And then patient, we didn't do an ERCP. This patient underwent a complete total pancreatectomy. That's the beauty of endoscopic ultrasound. And then this once again is in one more lesion they told, but it was a solid pancreatic tumor, solid SPN tumor which was biopsied, and then patient underwent a surgery. And then this was a very young patient who used to always come with recurrent hypoglycemia, sent from Niemann's. See, this was a neuroendocrine tumor, insulinoma. Patient used to carry sugar with him, and this biopsy turned out to be an insulinoma, and then patient was operated. Now, I told you from MRI and CT scan and PET scan, we have slowly moved into the endoscopy room. PET, MRI, which is not, one time it was superior, now we have almost replaced into endoscopic ultrasound in almost in most of the cases. Now let us show how anesthetics are being replaced. See, this is radiologically, when there is a pancreatic cancer, this is how a celiac block is being done. Earlier radiologists used to do. Now it is a very simple procedure. 3 minutes you can do. Just go in, put a needle just to the celiac block, put absolute alcohol and then bupivacaine. 5 minutes, entire procedure is done. Celiac block being done in a pancreatic cancer. This is how a EUS is done. Now let me conclude. Pseudocyst from surgery to endoscopy, pancreatic necrosis from surgery to endoscopy, pancreatic cancer, radiologist to endoscopy room, and then cystic neoplasm, PET scan, MRI to endoscopic ultrasound, pancreatic cancer from anesthetist to the endoscopic room. You can do a celiac block in 5 minutes with endoscopic ultrasound. Now let us show you, all of us, for gallstone and CBD stone, the investigation of choice is MRI. Now this is also almost going to be replaced by endoscopic ultrasound. See, this is a case, very good radiologist, MRI done, after spending 9,000 rupees, the final diagnosis, that once again there is a question. Now when we do an endoscopic ultrasound, see, this is a beauty of endoscopic ultrasound. You can see here the entire bile duct. We can see this was in fact sent for a surgery, gallbladder, and then see this whole bile duct, nothing is there. On that side, you have an MRI report which is suspicious. That's why good endoscopic ultrasound is going to completely replace MRCP for CBD stone. This is the beauty of endoscopic ultrasound. See, you can see very beautifully whole bile duct and pancreatic duct. And then we are not using a MRCP for a CBD stone almost for last 10 years. This is the beauty. And then finally, for bile duct cancers, see MRI done, there is a block. Nobody can say what is happening here. This will show that there is some block. See, the beauty is with endoscopic ultrasound, now you can see, you can go in and then very beautifully, anybody in the audience, they can say that this is a tumor. But an MRI will never say that there is a tumor. They will say some block. Once again, 9,000 rupees gone. When a EUS will tell you endoscopic ultrasound, biopsy, everything done in 12,000 or 15,000 rupees. That's why EUS is a good modality in distal cholangiocarcinoma. And this, I've already told you, this is, I showed you in the previous portal hypertension, the fundal varix being managed. I think now I showed you how a EUS guided coiling. This I've already shown. I'm just skipping this. This is a duodenal varix. We can just manage by putting glue into the duodenal varix through endoscopic ultrasound, just like radiologists, how they do. And then an EUS guided duodenal varix management. And now, this is because of the shortage of time. Now, suppose there is an ERCP failure. Suppose you cannot do an ERCP, what we can do? See, this is a new method wherein we can puncture the bile duct directly from the duodenum. This is known as a choledochoduodenostomy. From duodenum, we are puncturing the bile duct and we are placing a stent through the duodenum. This is known as a EOS guided choledochoduodenostomy. And then similarly, PTBD we can replace by a hepaticogastrostomy. See this? We are puncturing the bile duct from the liver and then placing a stent from liver to the stomach. This is known as an hepaticogastrostomy, which will avoid both radiologists and then as well as a failed ERCP. We can usually manage with a endoscopic ultrasound. Finally, who thought that one day GJ will be done by a physician? Endoscopic ultrasound can be done in 5 minutes in endoscopy room. That is known as an EUS guided GJ. In my lifetime, we never thought that GJ will be done by a endoscopy. That is also can be done by a EUS guided GJ. This is a GJ being done in 5 minutes. Entire GJ procedure can be done in 5 minutes. But only thing is now the cost of the stent is high. That's the only problem. And then why not we use endoscopic ultrasound in surgery? We are not competitors with surgery. We always work with surgeons. See, this is a pancreatic tumor. Now endoscopy is going and laparoscopy is going. See, we are using an endoscopic ultrasound and helping the surgeon. See this? On this side, laparoscopy instrument is going. On this side, endoscopic ultrasound is going. And then we tell them where exactly is the tumor and then they will operate. This is how. And then after the surgery, once they remove, this is how an EUS shows that completely they have removed the tumor. And finally, in liver resection also, we are helping the surgeons. See, this is a case of left hepatectomy. And then they have already cut the left hepatic artery. They are blocked it. And now, once the left hepatic duct is blocked, see this? Like a laparoscopy, we are passing an endoscopic ultrasound inside the peritoneal cavity. And then we are showing them where exactly cut the liver. See, this is the beauty of endoscopic ultrasound. Through the laparoscope it is going, through the mouth it is going, through the anus it is going, all the places we can go. This is the beauty of endoscopic ultrasound, how it can be done. And finally, one day gallstones, everybody were thinking gallstones can never be removed from the surgeons. Even EUS guided gallstone removal can also be done. This is only if the gallbladder is very thick. See, now you can puncture a gallbladder, place a stent in between and you can remove the stone. This is EUS guided gallbladder drainage and removal of stones. But this is at the moment, if the gallbladder is very thick and dilated, then only you can do. This is still there with the surgeons because gallbladder has to be removed because gallbladder will always form the stones. Now, let me tell you what has changed with endoscopic ultrasound. Surgery to endoscopy. See, pseudocyst, once it was surgery, now it has become endoscopy. And then GJ, nobody thought that it will never be done by a physician. GJ can be done by anybody because it's become a very simple procedure. In 5 minutes, you can do a GJ. From stomach, you can puncture the duodenum and then place a stent. This is the major change which endoscopic ultrasound has done. Nobody thought that MRI will be replaced. Endoscopic ultrasound has replaced MRI from the CBD stone. Lower cholangiocarcinoma, once again from radiology, endoscopic ultrasound is doing. Pancreatic cancer biopsy from radiology, gastroenterologists have started doing. And finally, intervention radiologists work also we have started doing in GI bleed in fundal varix. Once again, in failed ERCP, we can do by endoscopic ultrasound. We have a role even in surgery. Thank you very much for your kind attention. I think one thing you have to remember that time is changing and then the technology is always changing. We have to adapt to the new technology.
Very quick walkthrough the role of US.
Because Pradeep told me 12 minutes.
I just
hope
I just
made-
have one question for like what is now the hindrance for the referring surgeons or anybody? It is a lack of expertise or it is the cost or
Which
it
one?
is
The gallbladder?
no for US people not referring or their is
See,
it the lack of knowledge?
I think it's lack of knowledge because initially the cost of the endoscopic ultrasound was very much. When we started in 2011, Bangalore had only 3 endoscopic ultrasound. Now Sushoda has endoscopic ultrasound. I think Narayana has endoscopic ultrasound. Everybody are doing endoscopic ultrasound. Only thing is people are not aware that this can be done. And then still we are doing MRI for a CBD stone. When they can do a beautiful endoscopic ultrasound, then find a stone. If there is no stone, if there is a stone, they can do a ERCP. We have stopped MRCP for CBD stone from 2011. Almost now 14 years we have not done an endoscopic ultrasound. Only where I do MRCP is bile duct injury. That's where I do a bile duct. When there is a bile duct injury, we do an MRCP. And then pseudocyst, completely EUS guided. I think, in fact, surgeons, they send lot of cases. It's not a competitive because we find many tumors and then they are doing more Whipples. Our department is giving more Whipples to the surgeon. We are taking away small cases from them.
So being surgeon, I can assure you that any intervention or any new advancement is always welcomed because patient care is at the center.
Yes. No, we are not. This basically it's a one-to-one acceptance, and then surgeons are more benefited because see, gallstone is a small surgery, Whipples is a big surgery. You will get big surgery, and then we take away the small surgeries.
Agreed.
Thank you, sir. I now call upon Dr. Arjun Roy to felicitate the speaker as well as the moderator.
ಅದು ಹಳೆದಿದಲ್ಲ ಲ್ಯಾಪ್ಟಾಪ್
Chronic liver disease is the slow poetry of resilience and regret. The liver, ever forgiving, bears the weight of our choices in silence until one day it speaks. Fibers replace freedom and rhythm of life falters. Yet within that struggle lies hope, for the liver, more than any organ, believes in second chances and in the power of renewal when care and conscience align. I now invite Dr. Mallikarjun Sakpal, consultant hepatobiliary and transplant physician, Aster Hospital, Bangalore, for a talk. I also invite Dr. Ravish KR, Dr. Manjunath FV, and Dr. Srinath to moderate the session.
Yeah. So once again, thank you, Dr. Pradeep, for this opportunity. So I am going to talk on
management of CLD. It's a huge topic. Again, try to be finish in 10-15 minutes. So we'll start with the simple case. What you see in day-to-day OPDs, like a 45 years old male diagnosed to have cirrhosis and around 3 to 4 years follow-up, then presented with hematemesis. So at the admission, his hemoglobin was 8.9, platelet 45,000, INR is 2.3. So this is a common scenario. You see CLD patients coming with upper GI bleed. So if you look at the natural history of cirrhosis, they start with compensated phase and goes into where there is no portal hypertension related problems. They develop portal hypertension related events like bleed, ascites. We call it as a decompensation. When we are managing them, there is some acute insult, whether it is related to liver or non-liver related acute hit. They further decompensate and leads to death in majority of these patients. So why you need to know whether patient is compensated or decompensated? There is a huge difference in survival whenever patient goes from compensated phase, where there's a life expectancy around 7 to 10 years, drop to less than 2 years when they develop complications of this cirrhosis. So this patient presented with GI bleed, how you will manage to them? So usually starts with managing the vasoactive drugs. We commonly use vasopressin or octreotide, and it continue for 2 to 5 days. And do early endoscopy is very crucial. The timeline is between 6 to 12 hours, but in the peripheral setting, as early as possible, once patient is hemodynamically stable, please subject them to endoscopy and do the banding. Some of these patients may not respond to your banding, or they will have what is called a refractory GI bleed. Now there is a concept called TIPS, where you can rescue these patients. And TIPS is nothing but a stent placing between the hepatic veins and portal veins, and this is where you need to refer them to higher centers. So then we can avoid the further mortality in these patients, and these are easily done with a good intervention radiologist. So when this patient we managed with endoscopy, we did because he's first time decompensated, and ultrasound showed ascites. So whenever there is ascites, we need to confirm, find out what is the etiology and what are the complications of ascites. You know that whenever patient has ascites, 80% of cases it is due to underlying cirrhosis, and there are some other 10 to 15% other causes. And ascites, you know that this is the whenever patient has compensated, the ascites is the first, usually the presentation of decompensation, followed by GI bleeding, encephalopathy, and jaundice. And ascites occurs around 7 to 10% per year. And whenever you have a first time ascites, you need to do detailed analysis to find out what is the etiology. To say it is portal hypertension related, you have to do a SAG. That is SAG, nothing but you take serum albumin and subtract with the ascitic albumin. That is what called SAG. If it is more than 1.1, then it is suggestive of portal hypertension related ascites. Then management, how you will manage the ascites is you start with the simple. If there is a mild ascites, start with the salt restriction around 4 to 6 gram per day. And if the patient has moderate ascites, then you start diuretics, start with spironolactone and gradually add furosemide. So it you manage with the monitoring the electrolytes and renal function every 3 to 5, keep escalating. If there is how you'll assess the response, patient has to lose at least half kg per day. That is how you assess the response to diuretics. If there is no response, see that whether patient is taking salt. Sometimes that is where patient lie. They are inadvertently taking salt in their diet. So, and keep monitoring the complications of these diuretics, like look for hypo or hyperkalemia, renal failure. Some of these patients end up in even encephalopathy. When even after giving diuretics, some patients will have a large ascites, what you call as a refractory ascites. Then you need to do a LVP, what is called large volume paracentesis. Some of the tips you need to follow whenever you're doing it. So my usually used to do under ultrasound guidance, because we have some of the patient lost because of massive hemorrhage after the doing non-guided LVPs. And routine requirement of platelets or INR is not required before doing LVP, and usually blood products are not required in case doing LVP. And to prevent complication, please use albumin if you are removing more than 4 to 5 liters. And other advice is to remove as much as possible ascites, 10, 15 liters, not 1 or 2 liters, because patient will visit frequently and that will end up in more problem. So always recommendation to make a dry tap. So this step approach, start with sodium restriction, use diuretics, and even patient has more ascites, then go for LVP. Despite of LVP, then there are other complications because patient repeated tapping will lead to complications. Then that time you can consider in this patient say tips like I said for refractory GI bleed, and you bridge for the transplantation, because once there is ascites, the overall survival is less than 5 years, and as the complication increases, the mortality increases. We did tapping in this patient, the ascitic fluid was SAG was 1.9, that is confirmed patient has ascites secondary to portal hypertension. Then total count says 560. So that in fact there is some problem in the ascitic fluid. So if you look at the infections, then these CLD patient, most common infection was you see is SBP, followed by urinary tract, respiratory, cellulitis, and some other infections. And majority times how the patient present is just worsening of ascites or sudden development of encephalopathy, or they may have a worsening renal failure. That will be subtle signs in some patients. Or hypotension. So do a diagnostic tap, and if polymorphonuclear count is more than 250, then it is called as SBP. And in this other advice is what peripheral center I have seen is they send ascitic fluid in a specific for 2 to 5 ml for culture. That is a wrong method. Please send at least 10 ml in a blood culture bottle to get a good yield so that you can treat with the appropriate antibiotics. So whenever you have SBP, please avoid nephrotoxic drugs, vasodilator, and large volume paracentesis. And based on the patient profile, the best recommended is cefotaxime 2 gram, 1 to 2 gram, 3 times a day for 5 days. Along with you use albumin because that will prevent organ dysfunction and majority patient will improve. We treated this patient with antibiotic. However, he developed altered sensorium. So what we call as a hepatic encephalopathy. Does all the patient with, we need to answer whenever patient with CLD comes with the altered sensorium, is it truly hepatic encephalopathy? And always assess what is the severity of the encephalopathy and where to manage. Is it in the ward or in ICU? And what is the role of ammonia? So usually ammonia is not required for the diagnosis of hepatic encephalopathy. So you need to think other differential diagnosis whenever you are thinking of hepatic encephalopathy for first time presentation. There are various reasons, because majority what you see is alcoholics. They are taking continuous alcohol coming with altered sensorium. Sometimes it is not the HE, it is all withdrawal syndrome or intoxication. And somewhere we missed in many cases there is persistent HE, and second day, third day we investigate they have IC bleed. So be careful whenever labeling somebody having HE. So as I told, one you to need to identify the various precipitating factor why this patient is developing HE. These are the list of precipitating factors. Most commonly it is either infection, GI bleed, or diuretics related. Or sometimes when you evaluate further, some of there is no precipitating event, then what is called spontaneous HE, and measure these patients will have underlying shunt. So you categorize which is the grade of these patients. Usually grade 3, grade 4, they required ICU admission, where grade 1 and grade 2 you can manage in the ward with use of start with the lactose, and you can add rifaximin. So only 2 drugs has been as well studied and is useful in this patient management HE, that is lactose and rifaximin. Rest of the drug there is no good data to support them, but still in a refractory case you can use Lola, sodium benzoate, probiotics, and other laxatives. But data is only for the lactose, rifaximin, and supportive care. Other aspect what I heard always is the protein restriction. That is a old concept. We don't restrict any more protein in patient who have hepatic encephalopathy. Please give adequate protein around 1.2 to 1.5 gram per kg per day. This is a overall approach. I'm not going to the details. So when this patient was having HE, we also told that in the beginning the patient has a creatinine of 1.4 and it is gradually elevated to 1.6. If you look at the renal dysfunction in this group of patients, of the patient if CLD, initially 2/3 will be always pre-renal and 1/3 will be either renal related issues, and majority 2/3 will respond to volume expansion. When there is no volume, they do not respond to volume expansion, then there is comes what is called as a hepatorenal syndrome. And based on the creatinine, we stage the kidney injury as a stage 1, stage 2, or stage 3. Stage 1 is further divided based on the if the creatinine is less than increase 30%, but absolute value less than 1.5, then it is called as stage 1A. And when it is more than 1.5, it is called stage 1B. And if when it is 2 to 3 fold, stage 2, and absolute creatinine beyond 4, we call as a stage 3, because it is helps you in the management. And usually early grade of renal failure we can manage with eye fluids treating the precipitating factors, or sometime when there is no response you can give the albumin. So we can resuscitate up to 48 hours with albumin. If there is no response, then we can start transplant like terlipressin or octreotide in this group of patients. So whenever patient is developing HRS, then median survival is very less. So it is indicating that the mortality is going to increase in few months of time. So median survival drops in type 1, type 2, or earlier what we call is 6 months to 1 year. So you need to identify this. So how you grade the assess the severity in this group of patients in cirrhotics? So there are criteria. I'm not going to detail. You know that child score is there. Based on that, you can assess the severity. And there is a MELD score. This is a web-based. You can put the value and you can identify. So we need to identify from compensated to decompensated to the further complications, because there is a huge going to change in the mortality or survival is in these patients. Once they develop like SBP, HRS, then mean survival drops to in a 1 year to 6 months of time. So when you should think of a transplant in this group of patients? So whenever there is a child score increase more than 7 or MELD more than 10, you should start counseling them. But when MELD score become more than 15, or development of one episode of SBP, HRS, or there is a recurrent HE, ascites, what is called refractory ascites, or HEC, you should consider for the transplant. So in our case, son came as a donor for the transplant. So we did a LDLT in these patients. Many ask what is the post-transplant survival after these patients. So nowadays we always talk of long-term survival. These patients live more than 10 to 15 years and survival is around 50 to 60% at 10 to 15 years. So it is the transplant gives overall good long-term survival. So in a compensated cirrhosis, management goal is to treat etiology, screen, and prevent the complications. And some of them you can prevent even further also, like treating hepatitis B, stopping alcohol, or hepatitis C treatment. Now NASH has a very good treatments are upcoming. We may halt the further decompensation. But once there is a decompensation, the MELD score more than become 15 or any complications, you should think of transplant. Thank you.
I now call upon Dr. Anil Vidri to felicitate the speaker. I request the moderators to stay for the next session. A liver transplant is not just a surgery, it is a rebirth. One life offering another the chance to begin again. One heartbeat carrying forward the rhythm of two. It is where science meets sacrifice and hope becomes tangible. In the quiet between incision and closure lies a profound truth that healing is not only about survival but about the grace of giving life anew. I now call upon Dr. Pradeep Krishna, consultant hepatobiliary and liver transplant surgeon, Clinicals Hospital, Bengaluru, to give a talk on liver transplant.
ಇಲ್ಲ ಇಲ್ಲ ಇದಲ್ಲ ಇದಲ್ಲ ಇದು ರಾಜಗೌಡ ಅಂತ ಪ್ರದೀಪ್ ಕೃಷ್ಣ ಅಲ್ಲಲ್ಲ ಅಲ್ಲಲ್ಲ ಇದು ಲಾಸ್ಟ್ ಒನ್ ಇದು
Pradeep and Dr. Arjun for giving me this opportunity. So most of the things I was supposed to cover, Dr. Mallikarjun has covered. Bear with me for some repetitions. So I'll be talking upon liver transplantation, cirrhosis, and the contraindications and indications for liver with decompensated cirrhotic liver disease on the outcome and patient survival. So liver transplantation, as you all know, it's a surgical procedure where we replace a cirrhotic nodular liver in an end-stage liver disease with a healthy donor liver. It's become a standard of care now in a patients with decompensated cirrhotic liver disease with the excellent outcomes of late. It's a treatment of choice for the patients with end-stage liver disease. So the first transplant, liver transplant in the world was performed in 1967, but it took 30 years for us to get it to India. In 1998, the first successful liver transplantation was performed in India, but we have come a long way since then. Currently, India ranks third globally in total number of liver transplantations behind USA and China. When it comes to living donor liver transplantations, we are the masters actually, and we perform the second highest number of living donor liver transplants in the world, next to Korea. Briefly looking at the milestones, 1967 was the first successful liver transplantation, and 1998 was the first successful adult-to-adult living donor liver transplantation was performed. So there are various indications for liver transplantation. I'll briefly touch upon the common things that we see in day-to-day clinical practice. So when it comes to adults, most common things we see nowadays is the alcoholic liver disease, is the most common indications for patients coming for liver transplantation. And second, it is MAFLD or non-alcoholic steatohepatitis. So viral hepatitis, hepatitis B and C are also one of the common indications for patients coming for liver transplantations. Second is the acute liver failure. Patients with hepatitis A, hepatitis E, and more commonly what we see is patients having ratol poisoning as a suicidal attempt. The yellow phosphide, it's a component of ratol poison, cause liver damage leading to acute liver failure. So other rare causes like Wilson's disease, autoimmune hepatitis, and acute fatty liver of pregnancy also can lead to acute liver failure requiring liver transplantation. Pediatric liver transplantation, biliary atresia is one of the important cause for liver transplantation in pediatric age group. Around 40 to 50% of the pediatric liver transplantations are secondary to biliary atresia. Otherwise, other causes, there is a long list of metabolic and genetic disorders. So one thing I need to highlight is the tumors in the pediatric age group. Hepatoblastoma is the commonest liver tumor. In stage 4, that is pretext stage 4 case of hepatoblastoma, which doesn't respond to neoadjuvant chemotherapy. Even there, the liver transplantation is indicated in pediatric age group. And coming to the tumors in adults, so liver tumors, we have expanded the indications for liver transplantation in liver tumors, most commonly for the hepatocellular carcinoma, and then comes the cholangiocarcinoma, intrahepatic cholangiocarcinoma, and the metastatic liver disease, now colorectal liver metastasis, and also neuroendocrine tumor liver metastasis. We offer liver transplantation to improve the survival rates. So transplant oncology with expanding horizons. Now it's a new field where we are expanding our limits of offering transplantations for patients with liver tumors. Initially, to begin with hepatocellular liver cancers, there were strict size criteria in the beginning where we used to transplant patients who belong to within the Milan or UCSF criteria. These were basically based upon the strict liver size of the liver lesion criteria. So with new innovations and the downstaging modalities coming up, like TACE, TARE, and microwave ablation and RFA, and the new addition to the list of late is immunotherapy. So we are able to downstage these advanced liver tumors to within the transplantable criteria, and the good biology tumors are selected. So case selection is required in these cases, and post liver transplantation we are able to offer good post transplant survival in these patients. So the published survival rates of around 55 to 60% are there for these patients post liver transplantation who have been downstaged and transplanted. If not for the liver transplant, these patients will not have survival beyond 1 to 2 years. So this was one of our publication in American Journal of Transplantation, where for the first time we used immunotherapy as a downstaging modality using atezolizumab and bevacizumab in case of an advanced liver cancer with portal vein tumor thrombus who underwent living donor, ABO-incompatible living donor liver transplant after immunotherapy, after downstaging of the tumor. So like I mentioned, transplant oncology is expanded to other malignancies as well beyond HCC. So when it comes to colorectal liver metastasis, if the primary tumor is treated and there is enough gap at least of 2 years after treatment of the primary tumor, and there is specific set criteria for selection of the patients, like there is SICA trial, there is Oslo's criteria. So these include specific criteria basically to choose the patients with good biology of the tumor. And when the colorectal liver metastasis is specifically limited to only has also been offered to these patients. In 2021, International HPB Association published their consensus guidelines. This is another recent publication in 2024 in Lancet, where they're talking about considering liver transplantation as a standard of care in patients with metastatic colorectal liver cancer. Liver transplantation has also been offered to patients with cholangiocarcinoma, locally advanced cholangiocarcinoma, which is unresectable, with prior neoadjuvant chemoradiotherapy in a select group of patients who are expected to have a prolonged survival and good biology tumor. Coming to the contraindications, uncontrolled sepsis, advanced cardiopulmonary disease with severe heart failure, uncontrolled pulmonary hypertension, active extrahepatic malignancy, persistent substance abuse, and severe psychiatric illnesses. These are a few of the absolute contraindications. Irreversible brain damage, it's more relevant when it comes to acute liver failure setting. So patients with acute liver failure tend to develop severe cerebral injury. So prior to liver transplantation, it's a protocol in most of the centers to do a CT brain to confirm there's no irreversible brain damage before subjecting them for liver transplantation. So relative contraindications, age more than 70 years, again, fitter patients can undergo liver transplantation, severe obesity with BMI of more than 40, suboptimal family or social support, chronic but controlled infections. Portal vein thrombosis, it was a contraindication before, but now with improved surgical techniques, portal vein thrombosis is no more a contraindication, except when it is extremely extensive, blocking entire portal vein and the superior mesenteric vein. Otherwise, more often than not, we are able to transplant these patients with PVT. If it's extensive portomesenteric thrombosis, the only treatment option available is multivisceral transplantation. So I think Dr. Mallikarjun has already discussed about the natural history of the disease. I'll skip this slide. So as he already mentioned, once these cirrhotics develop decompensation with complications like ascites, jaundice, hepatic encephalopathy, and GI bleed, the survival is bound to decrease. So all the cirrhotics, the median survival is around 9 to 10 years. But once they develop decompensation, the survival drops down to 1.5 to 2 years for ascites. That means 50% of the patients may not survive beyond 2 years after they develop decompensation without liver transplantation. So once these patients develop an initial complication, they are bound to develop subsequently the other complications. With each increase in and adding on to the secondary complications, the survival is bound to decrease steeply. So the median survival for a decompensated cirrhosis after first onset of major complication is around 2 years. When we look at ascites, the median survival is 1.5 to 2 years. There is a risk of infections. SBP has already been mentioned. There is electrolyte imbalances. These patients may have malnutrition and develop sarcopenia. And these patients have got survival less than 2 years without transplantation, specifically in patients with refractory ascites, where the prognosis is worse and the median survival is less than 6 to 12 months. They're bound to develop spontaneous bacterial peritonitis, and this has got a 1 year survival of less than 30 to 50%, meaning half of these patients may not survive beyond 1 year without transplantation. The in-hospital mortality is around 20 to 40%. And this goes, even if they manage them medically and if they get treated, the chances of recurrence are high due to the severe impaired immunity of these patients. Often, once these patients develop SBP, they are bound to develop other complications due to further worsening of the liver functions. They might develop hepatic encephalopathy, hepatorenal syndrome. They might even go on to develop multi-organ dysfunctions, leading on to mortality. So the timely transplants are the only treatment that can save these patients. Another complication is hepatorenal syndrome. I think this has already been mentioned. This is one of the worst complications with acute HRS, which is rapidly progressive. That's a type 1 HRS, where the median survival is actually 2 weeks without treatment or without transplantation. And in case of chronic HRS, it's slowly progressive, but even then, the median survival of this patient is around 3 to 6 months. So it has got extremely poor prognosis without liver transplantation. So ascites, SBP, hepatorenal syndrome, and now coming to the hepatic encephalopathy. Again, that's a sign of advanced liver insufficiency. These patients with recurrent HE, patients who develop recurrent HE, there is quality of life is bad and there is a burden to the family and it impacts social life as well. So overt HE is also associated with high mortality, with less than 40 to 50% of the patients surviving beyond 1 year. It has got 40 to 50% mortality at 1 year. So I discussed about the impact of these various complications on the survival of this patient. Earlier patients, there's no nil 1 year mortality, but 2 year mortality it is around 15%. But when it comes to child B, there's got 20% 1 year mortality and 45% 2 year mortality without transplantation. Child C patients have got 55% 1 year mortality and 65% 2 year mortality. So if you look at these child B and child C patients, these are the patients who need to be told about liver transplantation and should be referred to the liver transplant units for further management. Early referral meaning once the patient develops the first decompensation, they usually have huge impact on the survival. Early transplantation in these patients, when the patients are fit for surgery, has got better surgical outcomes, early recovery, and also have a better resource utilization. So we all know as DCLD patients with ascites, SBP, jaundice, hepatic encephalopathy, or GI bleed, whenever these patients develop this first episode of decompensation, so they should be explained about the further or future need for liver transplantation and should be referred to the transplant units, because transplantation is a surgery which cannot be performed in the very short span of time. Usually it needs mental preparation for the family, to financial preparation, and to look for the donor, cadaver donor registration. Again, that's got a long waiting list. So an early introduction of concept of liver transplantation to these patients with continuing medical management will help them to receive a liver transplantation at a timely rate. So patients with MELD more than 15 and CTP more than 7 should be referred for transplant units. Actually, yeah, MELD more than 10 as well. So because the early referral, like I said earlier, will help these patients to understand the concept of transplantation. So optimal transplant window. So whenever the patients with MELD scores of 15 to 20, transplantation at this time has got beneficial risk. The benefits outweigh the risk in these set of patients. Listing these patients early after early decompensation while the patient is still stable enough for surgery, I already mentioned, has got better post-operative outcomes. And when it comes to hepatocellular carcinoma patients, these patients early transplantations, we can give them cure. These patients get curative treatment when they get transplanted, ideally in early stage, and they need to be listed in the initial phase as we diagnose the hepatocellular carcinoma, with them being on bridge therapies when they continue to be on waiting list. Now, I mentioned about how the complications are going to outcome the survival, meaning each complication brings down the survival in this patient by 50%. Only 60%, 30 to 35% of these patients are going to survive beyond 2 years. So now let's look at how post-liver transplantation survival is, how the liver transplant is going to improve survival in these patients. So 1 year post-liver transplant survival is around 85 to 90% now, with improvement in surgical techniques and expertise, and improvement in the ICU care and better understanding of the immunosuppressions. 85 to 90% of the patients do well in the first year. Only 5 to 10 to 15% of the patients might succumb secondary to some surgical complications like hepatic artery thrombosis or portal vein thrombosis or sepsis or early autograft dysfunction. At 3 years, 75 to 80% survival, and 10 years survival of 60 to 70%. This is an excellent survival when you look at their survival without transplantation. So there is huge disease burden. 2 lakhs of Indians are diagnosed with end-stage liver disease. Around 18.3% of deaths in India are related to, around 18% of the global liver cirrhotic deaths are happening in India. Around 25,000 people require liver transplantation. So we do usually, the commonest transplantation done in India is living donor liver transplantation, okay, where the donor has to be a relative or a family member, and it accounts for around 75 to 80% of the liver transplant performed in India. So there is right lobe graft, left lobe grafts, and left lateral segment graft. Left lateral segment grafts are primarily used in pediatric age group. And cadaver transplantation, as we know, the whole liver is transplanted from the healthy donor. Although it's a very minimal numbers in India, accounts for only 10 to 15% of the liver transplant. The main reason being the shortage of organs. So I request all of you to encourage your students, your community, general public to register for organ donation and be an organ donor. Thank you.
Thank you, sir. I now call upon Dr. PLN Achar to
Next.
A space occupying lesion in the liver is more than just a shadow on a scan. It is a question. It is a question that life quietly poses. In the organ that renews itself endlessly, something begins to grow where it shouldn't. Between fear and faith, medicine steps in to discern, to define, and decide. And through that journey, we are reminded how, even in the heart of darkness, light often begins with understanding. I now invite Dr. Raji Gowda AS, consultant liver transplant surgeon, Apollo Hospital, Bangalore, to give us an idea on space occupying lesions in the liver. I also invite moderators Dr. Arvind N and Dr. Guru Channa sir on the stage.
So it is very simple topic. So we'll not go in. Everybody day to day, you do face lot of issues like whenever anybody who presents with pain abdomen, we do advise ultrasound abdomen. Otherwise, usually now you have health awareness, everybody will go for a health checkup. Health checkup after doing ultrasound, you do find some liver lesions. So that is the first initiation. We start worrying what is happening in the liver. So for that, I'll give a little bit suggestions for that. Okay. So today's topic regarding that liver SOL. So once you find ultrasound, it shows that there's a lesion in the liver. Okay. There's accurate ultrasound. It may not give you accurate characterization. For that, next step is always CT scan. CT scan easily available almost in every corner of even Taluk. Any corner of India is available. Better get a good CT scan, triphasic CT scan, it will be helpful. So it will characterize very well. So in that, when you find an SOL, diagnosis is always a bit challenging. So you have to correlate clinically and with radiological findings and blood, whatever other lab investigation to come proper diagnosis to treat the lesions. So to go about it, next. Next slide, please. How to go? Here, you have to press like, yeah. Right. So usually liver lesions, either you find it in a children or adult, either it may be benign or malignant, or it may be solid or cystic, either it could be an hypervascular lesions. So CT scan is a basic standard. It is a triphasic CT scan. It is CT scan have a first CT scan non-contrast CT is a base standard protocol. Pre-contrast is a basal CT scan. Next, after giving contrast is the arterial phase. Next, portal venous phase. Next, delayed phase. So MRI is never be competent to the CT scan. It's always a complementary. When you are finding a difficulty to get any characterization of the lesion, better you do complementary MRI. It will help you to characterize the lesions. Always problem solving, not a problem creating. So basal CT scan, if you do basal images with non-contrast CT, it helps you if you do any procedure on the liver SOL. And liver mets most of the time will be hyperdense lesion. Usually we pick up number of the lesions in the basal scan. And pseudo lesions, which non-tumors and calcifications, suppose dead lesions in the liver, dead infective lesions. So arterial phase is usually it is helping identifying hypervascular tumors. Portal venous phase usually to assess the quality of it is good enhancement of the liver parenchyma, helping identifying the hypervascular mets and wash out of the hypervascular lesions, biliary abnormalities, and intrahepatic vessels anatomy. Delayed phase helping as hypervascular tumors and wash out of the HCC tumor. So what are the solid SOL we find in the liver? Usually benign, hemangioma, adenoma, focal nodal hyperplasia, hematomas, malignant lesions like HCC, fibrolaminal HCC, cholangiocarcinoma, lymphoma, MEDS, mesenchymal tumors. Next one is pseudotumors. So cystic SOL usually find simple cysts or hamartomas or polycystic liver diseases, biliary cystadenoma or carcinoma, liver abscess, pyogenic or amoebic, next hydatid cyst. So hemangioma, commonly any ultrasound, they say is hyperechoic lesions. So next, when you do CT scan, is the most commonest benign tumor available. Usually, the most of the time will be 5 centimeter asymptomatic. If it is a more than 10 centimeter, it calls a giant hemangioma. Usually, they will be symptomatic. They are located in the periphery or in center. Okay. Symptoms either they present with pain or mass pressure effect, non-specific symptoms. Sometimes they rupture present with acute abdomen as a bleeding. So it will never be AV malformation. These are arterial malformations. So no venous branches. So no, they have pseudocapsule. Most of the time, if it is asymptomatic, we know the character is it is clear-cut hemangioma. Usually, will not do surgery. They do observe. Surgery is indicated if the giant hemangioma, very active persons, they are located in the periphery. Chance of rupturing is quite high. So they do need surgery. So sorry. Hemangioma. See, this is a CT scan usually show low attenuation and non-contrast CT. You can see the CT scan if it peripheral enhancement in arterial phase followed by the globular centripetal enhancement in the portal, venous phase, portal and delayed phase. It will wash out of complete. So classical is a peripheral to central enhancement. Globular enhancement is a hemangioma. Next comes focal nodular hyperplasia. It is second commonest purely benign, no malignant changes. It is hamartoma lesions. This is hyperplastic reaction to the ischemic arterial malformation, asymptomatic, most of them incident detection. Presence of Cooper cells is the diagnostic markers. If you do technetium 19 technetium colloid scan is a diagnostic marker for that, or else you can do MRI, super paramagnet heron magnetic contrast study is a definitive study. So if you do CT scan, there is a central fibrous scar in the CT scan which radiated fibrous septations. There is a classical findings of typical FNH. It contains dystrophic vessels. The findings, CT scan findings here, usually they started enhancing from central to the periphery, centrifugal enhancement. It have a labulated counter, no capsule, usually no biopsy, no surgery required. If it is a symptomatic, he needs either resections or maybe ablations as it is a non-malignant lesions, emboliations. Adenoma. Adenoma, it is one confusing. Usually find in young women, childbearing age, solitary most of the time. Sometimes it may associate, they are associated with OC pills, anabolic steroids, sometimes glycogen storage disorders, metabolic associated disorders. Sometimes you find a more than 10, 15, 20% of adenoma in the liver, called adenomatosis. Here, opposite to focal FNH, you find no Cooper cells or bile ducts. So asymptomatic incident detection, either they present with rupture, hemorrhage, acute presentations. There is 5 to 10% there is a malignant transformations. So what CT scan finding says is a well marginated, isolating to liver and non-contrast CT. If you do contrast, there is a homogeneous enhancement in arterial phase and persistent peripheral enhancement and isodensity in portal venous phase and delayed phase. So it is a chance of rupture and young childbearing age women and malignant transformation. Ideally, they need surgery. Of course, if more than 10-15% of adenoma, they do need transplant. SCC, it is a commonest primary malignancy in the liver, usually associated with metabolic associated disorder, HB, hepatitis C infection, and cirrhosis is a pre-malignant condition for SCC. Usually, either it presents asymptomatic, non-specific symptoms, or malignant symptoms, loss of weight, appetite, loss weight, and also ascites. If it is advanced lesions, usually AFP in that time you have to do PUCA test, it will be elevated. So normal liver, good performance status, you can do resections. Cirrhosis, if it is a smaller lesion, child age status, you can do resection or maybe ablations in equally good result, or maybe multifocal lesion, you can do TACE. Usually, best cirrhosis with HCC, you can do transplant with smaller lesions. MEDS, of course, is palliative care. Now, immunotherapy they are discussing. Of course, now immunotherapy with locally advanced lesion, you can do immunotherapy downgrade and you can do treatment. So what HCC can say is, see HCC, hypodense lesion in non-contrast CT, there is arterial enhancement in the portal, in the arterial phase. Then portal venous washout in the portal vein and delayed phase. This is the classical findings because it's applied by the hepatic artery, not by the venous, any other branches. So Enhancement in the arterial phase, washout, and the venous phase is a classical findings of HCC. Another variety you find in HCC, fibrolamellar type. It is subtype of HCC, young adult. It interliminal fibrosis will be there, asymptomatic vague presentations. AF will be normal, mildly PUK will be elevated. You have a lymph node mets. Surgery, compared to surgery, it is indicated, have a good prognosis. So you can see that this fibrolamellar HCC, what the finding is between, this is a combination of HCC and FNH. You can find central scar calcification in the center part. And these are also classical findings of enhancement and washout in like HCC. Cholangiocarcinoma, second commonest tumor in second primary tumor, is usually PSC, parasitic infection, hepatolithiasis, and viral infections. So CA19, CA elevated is coalition tumor. It is a combination of HCC and cholangiocarcinoma. You do find. So what the findings of cholangiocarcinoma is a hypodense lesion, irregular, infiltrating to the surrounding layer, delayed enhancement in the portal venous space, not enhancing the arterial phase. Other findings are biliary dilatation, vascular invasion, lobar atrophy, and lymph node mets. Gallbladder malignancy, of course, gallbladder malignancy arising from the liver surface, infiltrating into segment 5 and 4B, they do present with as a mass. Along with there's a portal structure involvement and lymph node mets. Okay. So vascular malignancy, these are angiosarcoma, hemangioendothelioma. This is angiosarcoma. This is also atypical hemangioma findings, but they have malignancy feature. Just keep in mind, they may not be hemangioma. Okay. So another malignancy is epithelial hemangioendothelioma. Okay. So they have a multiple lesions, like their endothelial malignancy and epithelial endothelial malignancy. They have lollipop signs. They usually located in the periphery. They do need surgery if they're symptomatic. Next is lymphoma, is a part of NHL or primary lymphoma. They don't have any, they will not irregular shape, delayed enhancement, no biliary dilatation, no calcification, no septum. Hypertension both in the plain CT and contrast CT. Mesenchymal tumors usually find in the children. They do resemblance like a cystic lesion, but there are mesenchymal tumors like rhabdomyosis, embryomenocarcinoma, hypodense, pseudocapsule, no vascular invasions. Next comes GIT mets and neuroendocrine mets. So they are all hypodense lesion. You can find out on all phases. They are not enhancing. Neuroendocrine tumors, they are hypervascular tumors. They are well enhancing in the opposite ground, in the background of liver. Simple cyst, cystic lesion. Simple cysts are biliary in origin. The serous contents, incidental female, asymptomatic. Either they presented with mass effect. So usually either present infection, hemorrhage. No septa, no enhancement on contrast enhancement. Usually they do asymptomatic will left out like this. If it is a symptomatic, percutaneous aspiration, ablations, or deroofing, resection for recurrence lesions. PCLD is a polycystic liver diseases. They usually associated with primary liver cirrhosis or maybe associated with other polycystic kidney, associated with pancreas cyst, splenic cyst. They present with discomfort. So, and loss of pressure symptoms basically mainly. So surgery usually aspiration, deroofing, partial liver resection depending on size of the lesions, okay, where they're locating. Of course, at the end they might need transplant for cure, primary cure. The patient have a GI parasite amoebic infection. Usually they spread through the portal vein into the liver. That's why most of the time you'll find on the right lobe of the liver. Serology positive, single thing. How to find pyogenic liver abscess? They have a very thick rim. Usually drainage is not required, and is amoebicidal. Anti-amoebicidal is enough to treat that one. Pyogenic liver abscess, it spread through the biliary or artery or vein. So it is multifocal. They have very thin rim enhancement compared to amoebic liver. So they are multifocal, not maybe single. Drainage, antibiotics, and treat the underlying cause. Hydatid cyst, of course, echinococcal granulous infection. They have slow growth, asymptomatic, or maybe pressure effects. Either they communicate biliary obstruction, communication, infections. Okay, they are all well encapsulated internal septation. Depending on they have a stage. Early stage of a simple cyst, later develop into daughter cyst, and finally last stage will be calcification, dead cyst. So usually. So you can see here, this is adult stage. You can see the daughter cyst, encapsulation, multiple cysts. Here it is a mobile daughter cyst is called water lily sign findings. Okay. So next come biliary cyst study. This one always confuses either hereditary cyst. It's called women, middle age, mass effect. They're not doing well. If you do CT scan, you can find internal septation, nodules, papillary projection, mural nodules, intercystic debris. So surrounding structure invasion. These are the either biliary cyst study or malignancy. They need to surgery. Commonly, they're located in segment 4, segment 5 location most of the time. Caroli, this is a type 5 biliary cystic dilatation found in the liver.
Dr. Pramod Kumar DA, consultant hepatology and liver transplant physician, to tell us more about this. Thank you.
Can you call? Where is the people? Mail. Delhi. Present review. At the outset, I would like to thank Dr. Pradeep for the invitation. Even though Delhi is a boring topic, basically Delhi is associated with symptomatic illness and morbidity, and even it can be life-threatening in some cases, and some patients even undergo liver transplantation. And other thing is diagnosis. Diagnosing delay is most challenging for physicians and even for hepatologists because of it's rare, and in variety of it presents in variety of it has clinical phenotypes, and as well as it doesn't have any specific biomarker to detect or diagnose delay. If you go coming to the epidemiology, as we don't have any specific studies to look into based studies, the incidence varies between 2 to 20 cases per 1 lakh population per year. And we do have various prospective delay registries. In India, we have Indian delay registry. And if you look at the most common drug class causing delay in USA, it is antimicrobials, followed by the herbal preparation or dietary supplements, and followed by the cardiovascular drugs. Whereas in Spain, it is again the antimicrobials. In Latin America, again, the NSAIDs is the most common drug. And as we know, in the last decade, the herbal medicines may have caused the large spectrum of liver injury, and again ranging from mild asymptomatic enzyme elevation to even to liver failure. And in US delay registry, around 16% of the cases were caused due to the herbal preparation and dietary supplements. In India, we have the common drugs we see is ashwagandha and the giloy, and the recently many cases reported with the usage of the turmeric. And the risk factors for delay, we have host-dependent factors and dose-dependent factors. And again, with the increasing age, there is a risk of the delay, especially for isoniazid. And in younger age group, the valproate is the one. They are at high risk. In female, coming to sex, again, female patients are at risk of developing ALF, acute liver failure, when you compare with male counterparts. And coming to the ethnicity, again, certain the East Asian group with the specific HLA polymorphisms are at risk of developing delay with amoxiclav and also with nitrofurantoin. And alcohol is again the most significant important risk factor for delay with ATT. And again, with the underlying metabolic syndrome and chronic liver disease, again risk factor for delay. Coming to the drug-dependent factors, dose is an important factor. Again, more than 50 mg or 100 mg per day, along with significant hepatic metabolism of any drug, is associated with development of delay. And third thing is lipophilicity. If a drug is more lipophilic, then they are at risk of developing delay. And these are the few factors basically causing patients at risk of developing delay. And delay again classified depending on the type of injury, direct hepatotoxicity or idiosyncratic hepatotoxicity or indirect hepatotoxicity. Again, the direct hepatotoxicity or intrinsic delay is typically dose related and occurs in a large proportion of individuals exposed to the drug. And the usual onset is within a short span of time, hours to days. Classical example for intrinsic delay is high dose of paracetamol. And for idiosyncratic delay, again, it is very rare, not dose related. And it again occurs in small proportion of exposed individuals. And again, it exhibits a variable latency to the onset of days to weeks. And the classical drug which causes idiosyncratic hepatotoxicity is amoxiclav, and followed by the what we commonly see is with isoniazid. And indirect is the again newest classification. Again, either due to the indirect action of the drug on the liver or by stimulating the immune system. Again, the anti-neoplastic agents, monoclonal antibodies, are the one which can cause indirect hepatotoxicity. Coming to the pathogenesis, it's again, as I earlier mentioned, it is the dose of the drug and the lipophilicity of the drug, which can lead to the formation of reactive metabolites. These reactive metabolites, they form a covalent bonding kinase pathways and leading to the mitochondria and ER stress, and leading to, in certain patients, they develop lethal necrosis of the liver cells, and certain patients, they adapt and they counteract the whatever stress because of the drug. And in few patients, these reactive metabolites acts as the antigen or aptens, which can lead to the activation of innate immune system followed by the adaptive immune response. These are the patients are at risk of developing idiosyncratic delay. And again, the delay based on the severity, we can classify them into the severity of enzyme elevation, and also the pattern of liver injury can be classified into hepatocellular, or cholestatic, or mixed type based on the ratio between ALT and the ALP. And if any patient develops jaundice along with the increase in ALT, and if you look at the mortality, it's between the 10 to 50%. Any patient who develops jaundice, then they classify into severe delay. So, it's a different PPT. Old PPT. Half PPT. ಬೇರೆ ಆಫ್ ಮಾಡಿದ್ದು ಬೇರೆ ಪಿ ಪಿ ಟಿ ಅನ್ಎಡಿಟೆಡ್ ಬೇರೆ ಇದೆ ನನ್ನ ಲ್ಯಾಪ್ಟಾಪಲ್ಲಿ ಮೇಲಲ್ಲಿ ತಂದಿದ್ದು ಅಲ್ಲ ಇದೆ ದಿಲ್ಲಿ ಬಟ್ ಬೇರೆ ಪಿ ಪಿ ಟಿ this one. Okay. ಈಗ ಮತ್ತೆ ಬೇರೆ ಬಂದಿದೆ. 66 ಸ್ಲೈಡ್ಸ್ ಬರ್ತದೆ. 23 slides ಇದೆ ಅಷ್ಟೇ. That's okay. ನನ್ನ ಲ್ಯಾಪ್ಟಾಪ್ ತಗೊಂಡ್ರೆ ಲ್ಯಾಪ್ಟಾಪ್ 10 slides ಅಷ್ಟೇ. Yeah, a few cases I have. Yeah. Okay. Hello, it's a different PPT. That's all. Yeah. I will go to the few cases. Sir, full screen ಮಾಡ್ತೀನಿ. ಬಿಟ್ಟು ಇದೆನಾ? Okay, that's okay. I'll share few cases then. That's okay. Okay. Sorry for the delay. There is some confusion. Full screen. So, I will share few real life case scenarios what I've seen in our clinical practice. This is again a typical case we see in our daily routine practice. Again, 42-year-old male with pulmonary TB started on developed fatigue, nausea, and jaundice. If you look at the enzyme levels are more than 5 times along with high bilirubin value. Again, this is a typical case of ATT-induced hepatotoxicity. How to manage them? Stop all hepatotoxic drugs like isoniazid, rifampicin, and pyrazinamide. You continue with non-hepatotoxic drugs like ethambutol. You can add on aminoglycosides like streptomycin and also fluoroquinolones like levoflox or the moxifloxacin. You give them supportive therapy, and once LFT normalizes, then you can reintroduce the ATT drugs like rifampicin. You can start with lower dose, and within 3-4 days you can go to the maximum recommended dose. Then you can add the isoniazid. Lastly, you can consider using pyrazinamide. But in severe cases, if patient develops jaundice or any prolonged INR, again you can avoid reintroducing pyrazinamide. In other cases, in mild cases, you can consider reintroducing rifampicin, isoniazid, and pyrazinamide. If patient is pyrazinamide intolerant, you can consider adding other drugs like aminoglycosides or fluoroquinolones. Main thing, there are certain risk factors for ATT delay. Again, the incidence varies between 2 to 28%. Around 7% of the patients goes on to develop the severe liver injury like acute liver failure. Once the patient develops acute liver failure on ATT, the death rate is around 70%. Coming to the second case, again, anticonvulsant induced hepatitis. This is again a young female having GTCS started on valproic acid initially, later switched to phenytoin because of financial issues. After 2 weeks of starting phenytoin, she developed fatigue, nausea, and jaundice. Again, labs showing the hepatocellular pattern. Again, it's a phenytoin-induced hepatitis. Certain patients, even they develop the eosinophilia rash and all, they present like a DRESS syndrome. And in this kind of cases, you stop the phenytoin immediately. Again, you can start these patients on the liver non-hepatotoxic anticonvulsants like levetiracetam, and again supportive therapy is needed for them. Again, it is advised to avoid lifelong these phenytoin, carbamazepine, and phenobarbital in this kind of patients. This is one of the recent case, a young male patient. Again, he was a fitness trainer. He was started on 6 weeks. He was taking oxametholone along with stanzolol for muscle gain. After 2 weeks of starting these anabolic steroids, he developed cholestatic jaundice with severe pruritus, and he had a bilirubin of 15. If you look at the liver enzymes, they had marked elevation of ALP and gamma GT. Again, it's a classical case of anabolic steroid-induced cholestatic liver injury. In this kind of, again, supportive therapy comes first. Stop all anabolic steroids. Usually, we start these patients on first drug is UDCA followed by cholestyramine. If patient is not responding to these two drugs, then you can consider adding rifampicin or sertraline. This patient had no improvement with these medications, and bilirubin was worsened to 25 milligram per deciliter. Then we started him on short course of steroids, and this patient underwent 3 cycles of therapeutic plasma action. With that, the bilirubin slowly improved over a period of 3 months. So these are few publications from our unit. This is one of the case where with single dose of etodolac led to the acute liver failure in 2 patients. Again, one patient, we could salvage one patient with the therapeutic plasma exchange, and other patient we couldn't do. And one more case where elderly man was the antifibrotic agent. This patient presented with acute liver failure and succumbed to it, and post mortem biopsy showed again severe necrosis. And this is an interesting case. Again, a young patient with the simple biliary stone-related pancreatitis and underwent cholecystectomy. However, he was advised to take antioxidant containing vitamin A along with beta carotene. He was taking this combination for more than 7 years. One day, suddenly present with acute liver failure, and he had hepatic encephalopathy. Immediately, we started him on therapeutic plasma exchange along with CRRT and steroid pulse. And later, with these supportive medications, he could recover completely. And one more young female, she was taking ciproterone acetate for hirsutism. She was taking around 25 mg, and again she presented with acute liver failure. And lastly, favipiravir. I think everybody must have used this drug during COVID, and this is again first reported cases of drug-induced liver injury, which we published way back in 2022. Thank you.
Thank you very much for this well-explained drugs, where we really sometimes we give blindly this amoxicillin and the steroids and ashwagandha, other things. I think it's eye-opener for everyone. This. Thank you, sir. Thank you very much.
Most of the cases, what we have seen is after post-COVID, many, I think in general population started taking the ashwagandha, giloy and all as a immune boosters. And they presented like the autoimmune hepatitis kind of presentation, and few patients, they required even steroids for them. Yeah.
True. I think take-home message should be, before we prescribe, know your drugs, like that. Definitely for ashwagandha, steroids, other things, definitely we should think twice before prescribing.
Thank you.
Ladies and gentlemen, the young lady who has been actually anchoring, she is Dr. Samritita Mukhopadhyaya, intern in Sims Medical College, where I was also a professor and head of the department for some time. And I was very much impressed, and I'm sure all of you are. And she has been doing it right from 1 o'clock onwards. And that flawless anchoring, very apt in introducing the topics. And I learned a lot of things from her. Ladies and gentlemen, give her a big hand. Dr. Praveen Kumar wants to present a memento to her.
I now request Dr. S.B. Hegde to present the memento to the speakers as well as the moderators. As the scopes are stilled and the slides put away, we pause to reflect on the lessons today. From reflux and ulcers to livers that ache, to the quiet resilience of each gut we awake. We came seeking answers, we leave with more. For medicine is not a map, but a shore, where curiosity meets compassion's hand, and healing begins with understanding, not demand. So, as we close, may we carry this truth that every human we study holds living proof of wonder, of balance, of stories untold, a reminder that science too has a soul. I thank all of you for making this program the success it is. I, Samadrita Mukhopadhyay, now take your leave. Hope you have a lovely rest of your night.
Former slide. I thank one and all, the seniors, my friends and colleagues, to stay till the end of the program. This is not possible without support of pharma industry. I like to mention the main sponsors for this event: Lupin Pharma, Lorenon, Cipla, Olympus Medicals, Zydus, Alnich, Takeda, Genealogies, Apollo Hospitals, Microlab Limited, Mankind, LPG Life Sciences, Astor Hospital, Alchem, MacLeods, Alembic, Kims Hospital, and Aristo, Zoentis, Intas, and Chemican, then Dr. Reddy's Lab, and Eris Life Sciences. Thank you and all for this making this event grand success. So please join us for the banquet next to the hotel. Thank you.